To all of you present here. We now commence the day 2 of our program, CME on secondary procedures in brachial plexus injuries. And to begin with, we have our talks with the most eminent faculties and delegates today. And we have a lot of other surprises, quizzes and e-posters and a lot of academic activities to make this an enriching experience for all of you. To start with, we have our first talk by Dr. Praveen Bharadwaj. The moderators for the session will be Dr. R.K. Sahu sir and Dr. Neeraj Rao sir. Dr. Praveen Bharadwaj will be talking about current concepts in secondary reconstruction after brachial plexus injury, when primary surgery is not enough. May I please invite Praveen Bharadwaj sir to deliver his talk.
Is coming.
Very good morning to all in the auditorium. It's in the past day with a heavy schedule, it's very difficult, but still we will start in time with our program. So this is a very difficult topic. So the current concepts in a secondary procedure, it's a very top one. So it will be help you in every aspects. I invite our Dr. Praveen sir to deliberate his talks.
Okay, thank you, sir. Good morning. So in this session, which is a very focused session on secondary procedures on brachial plexus injuries, we will be, actually there may be so much overlap because many talks will be having almost same type of theme. So, and there are some videos which were put in the program, but those were the cases which we operated yesterday. So maybe those videos again would not make that much of sense. So what I thought is we will have a more kind of interactive session where people, if they have any doubts, which we can clear, and it will be more beneficial for everyone. To begin with, first of all, intro of our theme. What is these secondary procedures? Because many times there are a lot of confusions in terminologies, especially when you talk about brachial plexus injury, you divide it into two groups. One is the traumatic, other one is the birth palsy. In traumatic, it is sometimes told as adult brachial plexus injury or brachial plexus injury as such or adult brachial plexus palsy. So our theme also we see secondary procedures in brachial plexus injury. So injury sometimes would mean whether it is accident only, but birth palsy also can be considered an injury. There is more confusion in terminology for birth brachial plexus palsy. More of the previous literature would tell it like obstetric brachial plexus palsy, OBPI, or UBS palsy. But if you call it an obstetric brachial plexus palsy, you are almost dictating that the injury happened because of the obstetrician. So that's why the terminology has been totally taken off, and all the recent journals, when they accept any article, they would specifically tell not to mention this as an OBPI. So the standard terminology is BBPP, birth brachial plexus palsy. So we should not term it like UBS palsy. UBS again means the upper plexus palsy. So the global palsy is not a UBS palsy, but still it is termed very often. So the terminology what we should use is birth brachial plexus palsy. Now all the surgeries what we do on the nerves are the primary surgeries, and the surgeries which are not on the nerves will be termed like secondary surgeries. Secondary surgeries basically involve tendon transfers, muscle transfers, including the free functioning muscle transfer, the osteotomies, and the arthrodesis. So these four type of operations would be the one which we'll be discussing all today. Now, when we compare these secondary procedures with primary surgeries, in nerve surgery especially, there can be some specific advantages that they are more predictable than nerve surgery. Actually, when you do a tendon transfer for radial nerve palsy, you know that it is going to work. So it is a real complication with which it may not work. Otherwise, you know that it is going to work. But when you repair a radial nerve, you can never say that it is going to work. You know that it is good chance is there, but you cannot say that every time it is going to work. But tendon transfers are more predictable. More than that, in brachial plexus injuries, they give more early function, which is unlike any of the nerve injuries. As I was mentioning yesterday while we were doing the biceps to finger flexor transfer, that patient who underwent biceps to finger, in the same evening he will move the fingers. So it is such a surprise for the patient that for 1 year we waited for the elbow to come and shoulder to come, and then suddenly in one day itself the finger bends. So those are the advantages, but we should not get carried away with that advantage, because the tendon transfers, even the best of the transfers, cannot give the nerve-like swiftness of the movement, nerve-like strength of the movement. So the tendon transfers at best gives about 30 to 40% of the normal level strength of that particular muscle. So that is the reason why the nerve surgery should be in the real front when you are treating the nerve injury patients, and the tendon transfers come only when the nerve surgeries are not possible. So when these operations are required. So in traumatic conditions, it is basically required in three situations. First is when the patient presents late, which is the commonest reason in our Indian practice, because most of the patients, if they have even if little bit recovery, they feel like it is going to come. And they keep waiting, and then the time for the nerve surgery goes off. It is very important to know that the golden period for doing nerve surgeries is only 6 months. In brachial plexus, if any patient comes after 6 months, then the result of the nerve surgeries are very poor. So this is the big chunk which will require secondary procedures. And that is the reason why I think the theme is taken for this meeting, because a lot of patients fall in this category. The second one is to augment the outcome which is achieved by the primary procedure. We noted that yesterday. So some patients' shoulder movement has come, but it is not complete. So you can augment it with additional tendon transfer operation to make it more effective and more functional. The third one is when the primary procedure fails. So nerve surgery, not that every time it is going to work. The best of the nerve surgeries can also not have a 100% outcome. Patients often will ask 100% whether it will come. So 100% cannot never be assured. So whenever the primary procedure fails, again we need to resort on to the secondary procedure. So these are the three situations in which we are going to require secondary procedures when you are dealing with traumatic brachial plexus injuries. Now what about birth palsies? Actually, birth palsies, the primary procedures have secondary role, and the secondary procedures have the primary role, because most of these patients whom we think that they have recovered or which are thought to be having a recovery would actually have so many secondary deformities which will require corrections. So these patients, even if they are functional, they may have some postural deformity which can be very concerning for patient, which will require surgeries. And these all come in the category of the secondary operations. Now, why these deformities happen? Why in the children, actually the deformities is a big chunk of the operations what we will do. It is mainly because when the nerves are recovering, they will have cross innervation, which causes co-contractions. And these co-contractions result in shortening of the muscles. There is also some muscle imbalance, and because of the abnormal growth, the deformities will happen. There is a recent emergence of this concept that there is some internal change in the muscle itself because of which there is increase in some growth factors which cause the muscle to shrink. And this concept is proposed by Dr. Cornwall, and he even believes that there are some drugs which can inhibit this growth factor and prevent the formation of contracture. It is still in experimental stages, but if it comes, it will be a very great thing. In birth palsy, all the operations, again, where you do the nerve surgery primary and the secondary surgeries you do on the bones and on the muscles. How often would we require this operation? So it is very surprising and strange sometimes that you cannot believe that these operations are required that often, because when we talk about brachial plexus, we only think about nerves. In our hospital, I will put the statistics of last 3 years. So secondary operations in birth palsy, 87% of the total surgeries in birth palsy, and traumatic, 43%. So we had a total of 591 patients, and in them we can see that more than half of the patients are actually the secondary surgeries. Almost similar in 24, and last year where we had 660 cases of brachial plexus related cases, but 90% of the operations in birth palsy were secondary and 46 in adults were secondary. So secondary operations you are going to require more often than when you do a primary surgery. So that's why in brachial plexus, it is a very perfect combination of a specialty where you will require a complete hand surgery skill. You should be good enough to do a nerve surgery, you should be good to do a bone surgery, you should be good to do a tendon surgery, you should be good to understand the biomechanics, and you should be also good to be able to talk to a mother who is crying that my child is not able to move and how it is going to recover, how much recovery has come. And these all things make the brachial plexus surgery very interesting and very challenging also. Thank you so much. Now I'll ask Shrikant sir to give his talk on adult brachial plexus.
Any question from the floor? Praveen sir, one question from my side.
Yes, sir.
How early we should start the secondary procedures in birth and traumatic without waiting for more? How early we should start the secondary procedures?
Yes, sir. So secondary procedures, actually, as I was telling, even the Botox injection also we will consider like a secondary procedure, sir. So at 6 months, injections till 1 year. But if you are doing a surgery, 1 year is the time.
Okay.
Because at 1 year, our time for the nerve surgery is over, and then we start doing the surgery on the muscles.
Okay.
So initially, from 1 year to the 3 years time, it will be more of muscle releases. Then from 3 years to 6 years, it is more of tendon transfers. Then after 6 years, then it will be more operations on the bones.
Okay. Thank you, sir. Thank you for your excellent deliberation.
Thank you, sir.
2 things are more important in brachial plexus surgeries. One is the planning, and second is the timeline, when to do, what to do. Now, in this regard, Dr. Shrikant sir will enlighten us, and we are inviting Dr. Shrikant sir. He is a well-known figure, no need for introduction. Dr. Shrikant sir, please.
Praveen said there will be a lot of overlap, but actually in such a small gathering, overlap helps because it is something like a reinforcement of learning. You are not going to forget it because the same thing is going to be discussed time and again. No one likes secondary surgery because it implies that your primary nerve surgery has failed. Regardless, it is best to be prepared right on day 1. So we commonly identify what functions we are going to restore. You say that I want shoulder abduction, I want elbow flexion, I want wrist extension. Even more important is to identify what muscles are preserved after the injury, because they are the ones that you're going to need for your secondary correction at a later date if your nerve surgery doesn't work. So the clinical examination to know what is present is as important as to know what is absent. So we all know about C5, C6. More important is to know that when you have a C5, 6, 7 lesion, your wrist extensors are going to be weak, the triceps is going to be weak, and when you have what is called a T1 hand, you won't have a triceps, you won't have wrist extensors or finger extensors. At the most, you are going to have finger flexors, which may be weak, and the LD may be absent. I'm not talking about the intrinsics, because the intrinsics never serve as the donors. So it is best to have such a chart in mind, because this kind of a root value chart of individual muscles, and the key muscles that I'm talking about are flexocarpi radialis, pronator teres, flexocarpi ulnaris, and the palmaris longus, because these will tell you that if you need to do a secondary surgery, are the muscles available? Are the muscles and tendons normal? So in a partial plexus injury, when you do a secondary procedure, you're probably using normal muscles. As I said earlier, you need to know what are the normal muscles which can be used at a later date. So you would probably do pedicle functioning muscle transfers and tendon transfers. But in the setting of a total plexus injury, you're probably using re-innervated muscles which may have recovered spontaneously, or they have recovered deliberately because of your nerve intervention. Unless, when nothing else is available, you have to do a free functioning muscle transfer. When do you decide that it is time for the secondary surgery? Now that would depend on whether your primary surgery was nerve grafting or was it a nerve transfer. Obviously, the results of nerve transfer are seen much earlier. So I would say that anywhere between 12 to 15 months after a nerve transfer, a secondary surgery is indicated if function has not returned. Whereas if it is a nerve grafting that has been done as a primary surgery, you wait for a slightly longer time, because nerve grafts take time to grow. So you would plan your secondary surgery between 15 to 18 months. Now this is the key. This is the MRC grading, and anything less than M3 is considered to be functionally useless. I won't even say inadequate, it's useless. If your patient gets M3, he's much better off. Anything less than M3, secondary surgery is required. And this works for all joints or all the principal movements in the upper limb. This is a wonderful classification of Dr. Praveen. I will tell you why it's very important. He subdivides the classical MRC grade of 3 and 4 into subgrades. Now, these are situations where some amount of function may have been achieved, but it is not good enough for your patient if he's got some demanding tasks of the upper limb. So that means here we are going to augment the function. When it is less than M3, you are going to replace a function because it's not worthwhile. Whereas if it is in these grades, you could technically think about augmenting the function and making the patient much better. So this is a very useful classification which we should adopt. So I'm just showing you some videos. And this is a patient who had had an intercostal nerve transfer for the biceps. He's able to flex if you eliminate the gravity, but otherwise he's not able to do. So I don't think that's a good enough thing, and he requires secondary surgery. Whereas this patient, he had a functioning muscle transfer. If you can get this from a functioning muscle transfer, obviously you should get much more from an intercostal nerve transfer. So that sort of, this comparison tells you that the patient on the left needs secondary surgery. That is never going to be useful, however much you put the limb in any position to get some amount of elbow flexion. So now we see example of partial plexus injury where a nerve transfer has been done. He's got a reasonable amount of abduction. The hand and fingers were essentially normal. He's got full range of elbow flexion. And then you see he can internally rotate, which obviously he can. The external rotation is a bit contrived. He has some difficulty. But then next you will see that when he tries to abduct his left upper limb fully, there is some kind of a restriction. He is not able to really get beyond 90 degrees. In addition, this patient, if you notice it, has a slight weakness of the triceps consequent to the Somsack's procedure. So he is going to need some kind of secondary surgery for improvement. Whereas this patient here, again, a partial plexus injury in which a nerve transfer has been done, has probably got no useful function in the shoulder. Abduction is limited, external rotation is limited, and obviously having waited for, say, 18 months, he is going to need surgery on the shoulder. The elbow is fine. You also need to know what is anti-gravity triceps. If you are deciding that your patient needs augmentation of abduction, unless he's got anti-gravity triceps, don't aim to do any procedure that is going to lift the abduction angle beyond 90 because the hand will just fall down unless you tackle the problem of the weak triceps. This is a patient with a birth plexus palsy who had underwent primary nerve surgery. He seems reasonably all right. All my patients, before I decide they need secondary surgery, what I do is I stand in front of them and I demonstrate the global movements of the upper limb. My resident stands in front and takes a video. Because sometimes when you go through the video repeatedly, you will understand what exactly is going to be the functional deficit that the patient needs to be addressed. And that's a very useful technique instead of, just saying that he's got elbow flexion, he's got this. Just put him through a range of motion. This patient incidentally had a weak thumb abduction, palmar abduction, and he's got an ulnar deviation of the wrist which needs to be balanced. So this kind of a videography is very helpful. I won't go into the details of this. What are the options when you have an elbow flexion deficit? We also need to keep in mind that if you do nerve surgery, the patient will get biceps and supination. But when you do your muscle transfers, he is going to get only flexion, not supination, in case it's required. I have heard about the brachioradialis migration as a technique for replacement of elbow flexion, but I have no experience of that. The rest we'll see subsequently when I talk about it. Shoulder, you need to understand whether I am trying to give him mobility or stability. In an upper plexus injury, it is reasonable to provide shoulder abduction and external rotation because you have good amount of motors available. But in a panplexus injury, you don't have much options. So, even though you assume it is that you are providing mobility with a trapezius transfer, quote unquote, you are only providing stability. Now that's the simplest method of providing stability in a flail shoulder. You could do shoulder arthrodesis, you could do an arm derotation osteotomy, which sort of facilitates putting the limb in a more functional position. But mind you, if the serratus anterior is absent, a shoulder arthrodesis is contraindicated because the scapulothoracic component of the movement will not be there. This again, I'm not really talking about it, but when you do a trapezius transfer to a deltoid, two things you need to know: whether the spinal axillary nerve was used earlier. The team from Ganga has proved that you can use it, provided you have done your SAN to SSN cooptation at a very distal level. The upper and mid trapezius are still available. If you're not careful, then it may not work because the mid trapezius could have been denervated. So this is the technique which he demonstrated yesterday. And this is the controversial technique that I demonstrated yesterday, but I have based it on what I've seen in literature. It's not something that's created. In a panplexus injury, knowing very well that I want the shoulder only to be stable, I don't mind doing this procedure because it is less cumbersome than having to translate a bone onto the proximal end of the humerus. It's an alternative. I don't say this is the best method. So this is what was done yesterday. When it comes to the shoulder, we always, sort of concentrate about shoulder abduction. I could do with shoulder abduction because I've been having frozen shoulder, But the point is, shoulder external rotation is very, very important, which we miss out. The ability to, sort of take the hand out like that gives you a bigger working space. And so this classification, like Praveen's classification, is extremely important. Even though it was devised for birth plexus injuries, it can be adapted to the adult population also. Again, the grade 3 is the cutoff. As you can see, grade 3 has got slight external rotation. If the patient has no external rotation, that is an indication for secondary surgery on the shoulder from the point of view of rotation rather than abduction. So, what are the transfers that are available for providing external rotation? Teres major to teres minor, commonly done in birth plexus injuries. You could do a contralateral trapezius, preferred in case of the adults, where you transfer it to the infraspinatus. When it comes to the wrist and the finger, as you all know, it has to be either tendon transfers, which again can be normal, or those that were re-innervated earlier, but the options suddenly come down drastically. This is one situation where prevention is better than cure. So what is prevention in the setting of this? Do the newer distal nerve transfers. When you do your primary surgery, walk that extra mile to do a PQ to ECRB or a nerve to the brachialis to the anterior interosseous nerve for the finger flexors, a supinator to EDC for finger extension. Now, if you do these extended distal nerve transfers, the likelihood of a secondary surgery for the distal part of the limb is decreased or can be decreased. This is an example of a patient. This was actually a lower plexus injury where we transferred the nerve to the brachialis to the anterior interosseous nerve to give him finger flexion. It is not normal, but to begin with, he had a flat hand with complete inability to flex his fingers. And we also have an example of a patient for whom this standard procedure of PQ to ECRB is done, where the patient has anti-gravity extension of the wrist. So this sort of brings down the incidence of secondary surgery. Unfortunately, he required something for extension of the fingers, but then you could work with lesser number of donors, which is usually the problem in brachial plexus injuries. So, when you have failed nerve surgery, do you need secondary or tertiary salvage procedures? Primary, secondary, tertiary. What do I mean by tertiary? Tertiary, for example, when you have to do a biceps to FDP, right? That's a variety of a tertiary procedure. Secondary procedures could be that you have got some function, but you want to improve that function to sort of increase the functionality. Typically, it would be thumb CMC joint fusion, PIP joint fusion, and wrist fusion. So that's the end of it. I know there were some repetitions, but I work in my own way, he works in his own way, and I assume that all of us are going to gain something. At least I gained a couple of points from Dr. Praveen yesterday, so it's been worthwhile coming to AIIMS. Thank you.
Thank you, Shrikant sir. Any questions from the audience? Sir, I have one question. Throughout this, how do you counsel the patient and the patient relative for any patient who comes for primary or secondary procedure?
See, it would be fair to tell the patient that some patients require secondary surgery, 30% or 40%, but patients do not understand percentages. He is bothered about him. So essentially, I look at the time since injury, and as the time since injury keeps increasing, I do counsel primarily that yes, you are going to have some return of function, but the possibility of failure goes up, and you're going to require a secondary surgery. So the time, like Dr. Praveen suggested, was 6 months. Even sometimes 6 months is too late. If you've got a clear-cut diagnosis of an injury which has not recovered by 3 months, maybe it's time to operate, because the earlier you operate, the greater the chance of recovery. But 6 months in our country, yes. If he comes at 9 months or 1 year, then obviously at least with 1 year, at least 50% of them are going to require secondary corrections. As you saw, even in Praveen's statistics, what struck me is the comparison between the previous year and the next year as far as adult. I don't do much of pediatric. Even though the percentage of secondary procedures in the adult remained approximately the same, overall, the number of primary surgery successes seem to have increased. So if you look at it from that point of view, the requirement for secondary surgery was actually less. So that's experience, I guess.
Thank you, sir.
Thank you so much, sir. Now we proceed to have since Mukund Thate sir could not be with us today, he has prepared a short talk, and we would now like to share the message that he has sent to us with all of you. Dr. Mukund Thate does not need any introduction. He is a pioneering plastic and reconstructive surgeon with over 40 years of experience. He has been globally recognized for his expertise in complex hand microsurgery, pediatric reconstructions, and advanced facial aesthetics. A dedicated educator and researcher, Dr. Thate is widely celebrated for restoring both form and function to thousands of patients and changing their lives. ये वाला नहीं, हाँ हाँ हाँ, वो ठीक है, वो तो चेंज करना। Please request Dr. Subrajana sir to join the moderation, to join as a moderator. Yes. Yes, sir.
Very good morning. Is it a voice over or so it's a pre-recorded talk? So the control is with us. Can start.
Saraj told that Saraj two videos, so at that time he will be online to answer whatever the queries are there.
Good.
So we can show the video, we can show the talks are now, and at that time we'll take the questions and you can moderate this time.
So how long is this paper?
30 minutes, 25.
15 minutes.
25 to 30 minutes, yes, sir.
All together.
All together.
Okay.
Dear seniors, colleagues, ladies and gentlemen, thank you very much for inviting me for this program. As per the instructions of Professor Sanjay Giri, I am giving a talk on management essentials in birth brachial plexus palsy. The essentials are diagnosis, investigation, timing and strategy. So the diagnosis is very simple. It's a newborn infant with a lower motor neuron monoplasia. We need to exclude cerebral palsy and spastic conditions. Only 50% have shoulder dystocia and only 10 to 20% are heavy, that is greater than 4 kilo. Very few have diabetes or CPD in mother. In short, why some babies get it is still a mystery, but roughly 1 in 1,000 babies get birth palsy. We owe a lot to this man, Algimantas Narakas from Lausanne. He gave this classification, where group 1 refers to C5, C6, shoulder abduction, external rotation and elbow flexion is lost. Group 2, C7 is added, and triceps and wrist extension is lost. Group 3 and Group 4 are global. Group 4 also has Horner's. These are the simple rules for motor function. C5 represents deltoid, C6 biceps, C7 triceps and wrist extension, C8 extrinsic muscles of the hand, and T1 intrinsic muscles of the hand. There are exceptions, of course, which I have listed below. And the sensory examination just goes anti-clockwise. C5 on the outer aspect of shoulder, C6 on the forearm on the radial side, C7 middle finger, C8 little finger, T1 in the medial forearm and T2 in the medial arm. It is very simple to remember. The following videos will show you the examination. It helps to cover eyes to induce movement. So I have always said that timeline is very, very important and indicates prognosis. Earlier the recovery, the better, mainly in upper plexus. This is a child taken serially on day 12, day 16 and day 32. On day 10, only finger movement was observed. On day 16, elbow flexion was observed, which means prognostically very good. And day 32, almost all movements were restored. This child went on to have a near complete recovery and has not had secondary surgery. This is for checking abduction. Close the eyes. Child tries to take the hand to catch your hand and you see the abduction. Hand and FPL movements. Give a pen in the hand of the child and see the child gripping the pen. For triceps, we need to stimulate the forearm with the elbow flexed and the child will, this is an anti-gravity extension of triceps. And there you see it. I want to show you false elbow flexion because it is very important to differentiate it from actual elbow flexion. See, the right side is proper. The left side went up and then fell by gravity. This is false flexion. I'll show it to you again. Sorry. Look at the left side. Antepulsion and then falling with gravity. This is true spontaneous recovery. Both elbows flexed spontaneously, anti-gravity and went to mouth. While this is global palsy with Horner's, there is no movement anywhere and the eyelid is obvious. This video I want everyone to see. Examiner's thumb on the child's forearm can induce finger movements, which are false movements. So never ever hold the forearm on the volar side. Always hold it on the dorsal side. So in summary, we have to decide the type of palsy, check spontaneous recovery and take a call on the timeline. Investigations are a chest X-ray for fitness and diaphragm palsy, MRI neurography on a 3 Tesla machine if possible, and electrodiagnostic tests I think are most important. An example of a raised diaphragm, an example of a good MR neurography where you can see the avulsions here, C7, 8 and T1, similarly seen over here. And you can see the rupture over here and the avulsed roots over here. This is an adult picture because you get a much better picture. But basically, a MRI can give you very, very good information. In electrophysiology, we do a detailed study. All NCV values are documented. Representative muscles undergo needle EMG. If required, we do a SSEP. Basically, we want to know whether it's a pre or post ganglionic injury and the severity. Also, if there is ongoing reinnervation. So, see a typical report. C5 to T1 fibers at pre greater than post ganglionic, complete axon degeneration. Additionally, spinal accessory neuropathy. This is very bad. And if you see the needle EMG, complete denervation of all the representative muscles. How do children differ from adults? In children, findings change over time. The history of temporal improvement is very, very important. If in a grade 1 spontaneous elbow flexion is back in 6 weeks, secondary surgery is most unlikely for shoulder. And therefore, serial examination and noting timelines is very important if indicated serial EMG. Also very important to document clinically and on EMG co-contractions for shoulder and wrist function. Prognosis is vastly superior compared to adults. Even a global palsy can show great recovery, including the hand, if proper nerve surgery is done at the right time. The distance to travel for the nerves is very short, ability to regenerate is very high, and cortical plasticity is excellent. We now therefore have two possible situations: a group 1 or 2 Narakas upper plexus injury or a group 3 or 4 Narakas global injury. In case of global injury, the strategy is very clear. If the injury has remained global at 3 months, operate. Hopefully you will get it post-ganglionic and have enough donors on the same side. If you don't have them, consider opposite C7. For upper plexus, there is a huge debate on timing. At one time, Alain Gilbert wrote a paper which showed that if there is MRC3 elbow flexion at 3 months, surgery is not needed. This is no more the landmark that we achieve. Recent data shows we can wait up to 6 months if biceps is not flail, which means while you are examining the child, hold your fingers on the biceps, move the elbow passively. You will feel the biceps contracting if there is some innervation. If you don't feel it at all, that means the biceps is flail. Why do we keep on talking about the biceps? Because it's the only C5, C6 muscle with a single movement on a single joint. There is no ambiguity. If elbow flexes, biceps is working. If biceps is working, upper trunk to biceps pathway is intact, which means C5, C6 looks good, which is why biceps is the important indicator. So the strategy is see biceps at 3 months. If both are absent, clinical and electrophysiological denervation, operate. If the biceps is failed but not anti-gravity, wait and watch. Maximum is 6 months. If there is no anti-gravity biceps at 6 months, operate. This is a child which changed between 3 and 6 months. This child, if the examiner put in flexion, was holding in flexion but was not flexing himself. 15 days later, the same child started flexing the elbow on its own. Like so, which means the biceps was anti-gravity and we did not operate. So the question of timing, in global palsy, earlier the better, more time available for growing axons to reach the target while it is still viable. Ideally 3 months and 5 kg baby in our setup, we operate a global palsy. Second question I am always asked is how late is late? I cannot quantify it, but in a baby I am willing to take a chance till at least 1 year and sometimes even up to 1.5 years if it is completely untreated. Taking this chance is preferable to doing nothing because at worst no recovery will occur, and in any case there is no recovery, and therefore giving a try is still worthwhile in a baby. Counsel parents clearly in writing and take written informed consent about the delay and the lower prognosis. We have published extensively on this, and some of the papers here I am showing you. So the strategy depends on the number of available routes. 4 to 5 routes are available, very rare, but then directly coapt them to respective trunks and cords. 3 routes, 1 each to medial, lateral and posterior, 11 to SSN. And so on and so forth. But the best route should go to hand, always. Number 2, biceps, and then number 3, the shoulder. An example, 1 route available. Route to lower trunk or median cord, 11 to SSN, ICNs to biceps. Also an indication of contralateral C7 if that 1 route is not convincing. So in that case, we do CC7 to C8T1, 11 to MCN, cervical motors to SSN, and whatever root stump is available to posterior division of upper trunk. Typical reconstruction, if roots are available, is shown like this. All roots were available and therefore all were done to their respective targets. As I said earlier, C5 is more deltoid and therefore given to PDUT. C6 is more biceps and given to ADUT. C7 to C7 and C8T1 to C8T1. And this is a long-term result of the same child. Notice that despite a complete reconstruction, wrist extension is not working as well as it should. Now some examples. This is a single root reconstruction. This is early result. This is a complete reconstruction with 2 roots. Very reasonable result. The more interesting part is same child at a follow-up, shows a very different result. So cortical plasticity plays a large part, and therefore following these children for at least 15 to 18 years is very important. This is an 8-year follow-up of a complete reconstruction with 2 roots. And very complex actions are now possible. The same child, if you had seen a 1-year follow-up, you would have seen only basic movements. If there is no root or a poor root, use CC7 as I showed. This is very early function. This is intermediate, child showing skilled activity. This is slightly older, child showing even better activity. This is the same child as a 10-year-old, showing independent wrist extension. Same child showing eating with the affected hand. Same patient at the age of 14. This is my longest follow-up, operated in 2004. Initial restoration of function, and a 19-year follow-up as a medical student. His latest X-ray in the dissection hall. The take-home message I want to give is a detailed history, a serial clinical examination, chest X-ray, MRI, electrophysiology, and form a therapeutic plan. Do not wait and watch these children. These children require early nerve reconstruction. If you are not doing it, send it to a center doing it, but do not delay these children. Thank you for the privilege of addressing you, and special thanks to Professor Dr. Sanjay Giri for giving me this opportunity. Thank you.
Sir, first of all, how to do EMG study in this earth brachial plexus palsy? Painful, scary for the parents, and sometimes we don't get proper results also.
Yeah. Actually, that is the same feeling what most of the people have. But Thate sir is very lucky to have a nice EMG center. And I have gone there once, and the center itself is quite dedicated, and those people, the way they do, with a lot of interest, and knowledge also is there. Unfortunately, most of the neurologists are not so much interested in doing EMG.
mostly in the peripheries and even in bigger towns also, it's done by the technicians only.
Yeah.
Neurologists, they only do the signing part.
Yeah.
So,
So I think it is just because he's got a very good center where they are doing it nicely. They do it really well. Even I saw them doing 2, 3 patients. They were really so much dedicated and so much concentrating to do it nicely. And some information should come. So if they are personally involved, it is a very useful thing. But if they are not personally involved, then it is very dangerous thing. Even to tell example, I had a cubital tunnel surgery done for myself.
yes, you told it.
And when I went to do a EMG with a famous neurologist in Coimbatore, he asked the technician to do. And he did all the nerve conduction study and stimulated only below the elbow. Everything is normal, he is telling. Then I told him, cubital tunnel is above the level where you are stimulated. You please do it properly and then tell. So that much is the thing. And finally, they give the same report, whatever diagnosis you have written clinically. So it is very, very highly dependent on the person who is doing.
Actually,
Uh, Children,
EMG sedation.
it can be done, sir, but they don't do in sedation. Actually, they first do the surface EMG and then they will even inject the needle. Needle is very thin only. The baby will little bit be crying only. So parents also have to be understanding that this is being done for the good for the baby. And the needle also they will put, they will check the needle response with the insertion and they will give some response. So he very strongly bases his decisions on EMG because he has got a reliable center. But I will just like I am also not having, and I totally don't believe. Totally don't believe means not do it at all.
Yeah, because
Because
having a wrong result in hand,
yeah,
then the
yeah, yeah.
parents also don't believe on the surgeon that we do
Yeah, yeah.
surgery.
And it can be actually counterproductive
Yes.
sometimes because the patient will say that EMG is showing that it is working and you are telling that I have done a nerve transfer after cutting that nerve. So it can be very dangerous also. But if you have a good person to do, or you can encourage somebody to do it properly, then it will be a good adjuvant to your clinical exam.
Sir, another two questions. First is, like Srikant sir also told, you also told, and Mukund sir also told, that contractly C7. In CC7, are you using the whole of the CC7 or the anterior division or the part which is most pec major part you are taking?
No, I do contralateral C7 only in adult plexus injuries, and I take the whole C7. Even when you take the whole C7, you have to take it long. So that means it's already divided into anterior posterior divisions. Even when you take that, you will find it does not exactly match the inferior trunk, which is joining of C8 and T1. So we do the whole C7. I think Dr. Thatte is probably the only one who is still doing the split contralateral C7. And there also, he uses a nerve graft because it's a child. He doesn't do the Wong's technique.
So,
So they are two different things.
That was my next question. Do you do the Wang's technique or do you do the
No, I do the Wong's techniques because I do it in adults. If you are doing a pediatric plexus, you could probably do a hemi C7, but you will be putting a nerve graft.
So you do Wang's procedure, you do the humeral osteotomy.
No, I don't do the humeral osteotomy.
Okay.
So it will be based on the exploration. What is the amount of CAT1 that you are getting on the injured side? And if I'm reasonably sure I'll be able to approximate it directly by mobilization, I'll do it. I don't do osteotomy.
So then,
Dr. Giri, I think
We are away from the topic.
Yeah, we'll have from topic. Let's restrict ourselves to discussing only the secondary procedures. So these are all primary procedures that we're talking about. I think we'll go to the next presentation. Dr. Giri, what is the next presentation? Please come up.
Hello. Thank you so much, sir. Our next presentation will be by Dr. Praveen Bharadwaj, sir, on restoring shoulder function, modern strategies for stability and motion in chronic BPI.
So now starting the sequence of reconstruction from proximal to distal. So first we will talk about improving the shoulder function. At shoulder, there are basically two movements what we are desiring. One is abduction, another one is external rotation. Also, not a movement, but stability at the shoulder is also an important component. And it becomes part of the abduction as itself. So when you are doing a procedure like fusion or doing a trapezius transfer, it is the stability which comes, and then that, if more stability, that is called, it is the abduction. So when you are doing a procedure for abduction, basically you are having two options. One is doing a trapezius transfer, another one is doing a shoulder fusion. Both are well-known operations with a high experience available, lot of literature available. But very interestingly, all the brachial plexus surgeons can be divided into that these people do trapezius and these people do fusion. And in spite of all the conferences and discussions, they remain in the same group. They don't change. So it is such a very strict thing. To solve that, there is a nice meta-analysis paper by Dr. Dafang. So he is a guy from Boston, and he's come for some fellowship to our hospital, and that time we were discussing that, okay, there is no solution for this question. He did a meta-analysis, and finally the conclusion of the meta-analysis was that there cannot be any conclusion derived because there are no specific indicators that you can do this for this patient, do for that patient. So it will all be based on your personal experience and more so your training. So most of the people who have a plastic surgery background or a plastic surgery type of thought process would never believe that shoulder fusion can be done. And most of the people who are from the orthopedic background, they feel like, how can trapezius transfer work? You would have seen sir doing the fasciolata like that. So orthopedic people will think how this fasciolata will stretch with time. So it has to be something strong. So at least some screws should be there. So that is the reason I think it is not changing, and people still debate which is better. So we will talk about that little more. Second one is external rotation. So external rotation can be restored by two techniques. One is a tendon transfer, other one is the humerus external rotation osteotomy. They can be really separated as an indication. If you have a passive external rotation present, you do a tendon transfer. If you don't have a passive external rotation present, you do a external rotation osteotomy. So that is quite logical decision, and it is useful. Now, if you are a young person who has to decide to do a trapezius transfer or shoulder fusion for a given patient, so these are the logical thoughts which should come in your mind. So if you have a patient who has a total global instability at the shoulder, then trapezius transfer is not good, because it is not going to provide a global stability at the shoulder. So such a patient, you should think that you will do a shoulder arthrodesis, not a trapezius transfer. But if there is some amount of muscles working around the shoulder, around the elbow, in those patients, you can think of doing a trapezius transfer. The main advantage of trapezius transfer is that it is not a very gross operation. Gross operation means it does not abruptly change something which is not changeable. Shoulder arthrodesis is a gross operation. You just fuse the shoulder, it will going to be remain like that, and it is irreversible. So if you tell to a patient that your shoulder is going to be like that and you cannot lift it with the other hand also, so many patients will get very scared and they will tell there is no need for doing such operation. There are some very specific things, very pertinent and important, difficult problems after shoulder fusion. Number one, the patient cannot lie down on the side where shoulder fusion is done. So if you are telling all those things to the patient and then he is agreeing, he is the perfect patient to do. Because shoulder fusion provides such a fantastic stability at the shoulder, And because of the scapulothoracic movement, he will look as if he has a real control on the shoulder. So it is a good operation, but to be done for a patient who has understood all that. And most important thing, that they should have the serratus working. So there should be some scapula mobility present for it to work. If the serratus is not working, shoulder, then if you fuse the shoulder, if scapula movement is not there, you are not going to have any movement. So if you have a patient where you have a good scapulothoracic movement, the global instability is there and patient has understood that this is the kind of thing he is going to have, shoulder fusion is good. Otherwise, if you want to play safe, then the trapezius transfer is a nice thing. And in our center, most of the times, we end up choosing trapezius transfer. So if we are doing 50 trapezius transfer, we will be doing one shoulder fusion only. So it is that much uncommon, but in that selective indication, we have found that shoulder fusion also is quite good. And trapezius transfer we do by the technique what we saw yesterday during the live surgery, fix with one screw, and we with more than 200 cases, I am quite sure that the one screw is quite sufficient, provided that you have prepared the bone well and you have kept immobilized for about 2 months. And as I was telling yesterday, we always do that proximal pulling of the deltoid and suturing over the trapezius, which tends to increase the lever arm action of the trapezius and provides a better shoulder abduction. So this is the typical patient. Pre-op, you can see that he has elbow flexion and shoulder no abduction. So you can see that there is no opening up in the axilla. So he appears like he is doing anything up there, but the arm does not open up. And this is after trapezius transfer. This is the general result what a trapezius transfer patient will get. So we cannot tell that your hand is lifting up, but the shoulder becomes stable and he is able to clear up his axilla. Some patients may get a result like this, which is a very good result of a trapezius transfer. But I think whenever you have a result like this, you should very carefully see that this patient would have some spontaneous recovery of some of the shoulder stabilizers. Otherwise, trapezius is not capable of lifting so much. It will be coming around 40 degrees. So this was one nice audit done by one of our fellow on trapezius transfers, what we have done. And then very striking, nice thing, very statistically significant, we found that whenever there is any muscle working around the shoulder abduction recovery was almost double. You see here 22, 44, 25, 52. So from that time onwards, we never do a trapezius transfer before we have restored elbow flexion. There are many people who go that you go proximal to distal, first do shoulder trapezius transfer and then come and do the FFMT for elbow. But the results of trapezius transfer are very poor if there is no muscle working around the shoulder. So as a rule, we first always go to the elbow, get the elbow flexion, and once the elbow flexion recovered, grade 3, then only we go to the trapezius transfer. Now, what these patients benefit? Now, suppose you tell to a patient that you are doing an operation for lifting the arm up, but arm lifts only that much. So to a surgeon itself, sometimes it may appear as if like whether you are doing anything good. So that is the only research we did. So only in the OPD, just asking the patient what you are feeling better about. Surprisingly, all patients feel that they are better. First thing, when they be putting their clothes, they feel it is much easy to put. The most useful thing they felt is the heaviness of the upper limb reduces. And since the heaviness or weight of the upper limb reduces, also the dragging pain gets reduced. So these are the things which make the person feel that this procedure was quite useful. As Sir also mentioned, when you have taken spinal accessory, it would first thing appear is trapezius may not be working, whether it can be used for trapezius transfer or no. It can be still used, provided your trapezius has been harvested, spinal accessory has been harvested correctly. We should go down, dissect deep, and cut the spinal accessory in the depth. If you do so, you assure that the upper and the middle trapezius is functioning. If it is functioning, then the trapezius can be used for trapezius transfer and it will work well. But if you have not dissected it more distal, you have taken it off more proximally, then the trapezius will be very weak and then that patient will not be very suitable one to do a trapezius transfer. So whether the trapezius will be suitable for doing a trapezius transfer or no would be actually dictated by the time when you have done the spinal accessory transfer. So always go little deeper and make sure that you have left the branches innervating the upper and middle trapezius and then only take the spinal accessory nerve. Now coming to the next movement, that is the external rotation, which again is a very useful movement and patients really don't like that elbow coming and hitting onto the belly. So it is called a belly flexion. So patients really don't like, and getting some external rotation makes the movement look more natural and also is functionally quite useful. There are two tendon transfers which are described. One is using the lower or the middle part of the trapezius for the external rotation, but this can be used only when the spinal accessory has not been taken off. If the spinal accessory has been taken off, this lower trapezius becomes non-usable because it is paralyzed then, so you cannot do that. So then in those cases, you need to go for the contralateral lower trapezius, which again is quite an effective operation and it works quite well. So you go onto the opposite side, harvest the lower trapezius, flip it on and attach to the infraspinatus. So this is one of the example. This patient extended upper plexus palsy. He underwent nerve surgeries to get a decent amount of shoulder abduction and elbow flexion. But there was no external rotation. So this patient we took for the contralateral trapezius for external rotation. It actually comes quite nicely. Always to be extended with a fasciolata graft. Though the initial technique says that you can take the paravertebral fascia, but it is not so thick, you sometimes get worried whether it will snap off. So we always augment it with fasciolata graft. It will nicely and quite comfortably reach to the infraspinatus. And this is the kind of external rotation you can get. Actually, this is the involved side and you can see this is the lower trapezius going there. So nicely seen contracting there and good amount of external rotation. It really works well. But patient requires a lot of training. Almost 3 months it takes for them to understand that you are going to contract that lower trapezius and then you are going to get this type of external rotation. But once they understand, it looks quite natural and works quite well. However, most of the patients by the time they reach to us would have some stiffness at the shoulder and passive external rotation will not be present. When passive external rotation not present, you cannot do a tendon transfer. And in those cases, external rotation osteotomy of the humerus is quite effective option. This patient here, when he flexes the elbow, all the time the hand goes and touches the stomach. That's the kind of belly flexion, which many of the patients don't like. So here we have done an external rotation osteotomy, and after osteotomy, you can see a good amount of elbow flexion is retained and it looks more natural, comes out straight. One important point to note, observe here is, you see that we have done osteotomy in the lower humerus level, not in the proximal level. Whenever you have done a nerve surgery, your nerve graft will be going in this area. So it is very risky to go and do an osteotomy in the upper part of the humerus. So you safely go in the lower part and same amount of result, same type of result would come. So that summarizes that these are the procedures what we do for shoulder. So basically the patients will have a deficit of shoulder stability, shoulder abduction and shoulder external rotation. So the options what we would have for shoulder abduction is you have to choose between trapezius transfer and shoulder orthodesis. And for external rotation, you have option available of doing a tendon transfer and osteotomy. If you are doing a tendon transfer, the prerequisite is you should have a good passive external rotation. If patient has undergone a previous nerve surgery where spinal accessory is harvested, you have to go for contralateral lower trapezius for external rotation. If the spinal accessory has not been used, then ipsilateral lower trapezius can be used. And in patients who have a stiff shoulder, external rotation osteotomy of the humerus works quite well. Thank you so much. So if there are any questions on this.
Sir, one question, sir. Sir,
May I put the projection on, please? Projection on.
sir, one question.
Yes, sir. This was the result. So these are the patients with global palsy with some muscle working around the shoulder, global palsy with nothing working around the shoulder. This is the upper plexus palsy with some muscle working around the shoulder, and this is the upper plexus palsy with no muscles working. So the main significant thing was if there is any muscle around the shoulder is working, the abduction is double than what you will otherwise get. And biceps and triceps both are considered to be muscles working around the shoulder because the long head crosses the shoulder and the long head of triceps also crosses the shoulder. So this is what we can expect. So sometimes, suppose you have a patient who is lifting so much, then we should not tell this is the result of my trapezius transfer. It is just like spontaneous recovery which has happened.
Dr. Praveen?
Yes, sir.
How much of this abduction you will give credit to this scapulothoracic and this scapulohumeral motion? How do you differentiate?
Yes, sir. Sir, I think partly the trapezius is kind of doing a hemifusion itself. It makes the shoulder joint stiff, and part of it is the scapulothoracic movement only. So we once started looking for this by taking X-ray in abduction. So half of the movement is scapulothoracic movement only. Yes, sir.
Sir, sir,
Yes.
sir, as you said that for a secondary procedure for both the, when there is no shoulder abduction and also no elbow flexion, you in your institute you people first go for the elbow flexion only always. But sir, patients come and they complain about the shoulder instability a lot most of the time. So how, what is there anything we can do during the FFMT? Suppose I am doing an FFMT for elbow flexion. Should I do something for shoulder also? Because many of the time, because of the patient's request, we do trapezius transfer first in my practice also.
Yeah. But you next time observe that whenever you do like that, no, the final outcome after 5 years is poor. So this one I am telling not for the patient, this I am telling mainly for surgeons only. Because so we always feel patient is telling that shoulder is like that.
Actually,
we can put the shoulder strap. Shoulder strap if put properly, actually it works quite well. And we also used to get dragged like that, especially in our hospital, patient come from very far, he has come from Jammu Kashmir, come from Assam, I cannot come again, sir, you do it now itself. But when we tell him, no, see, this is the difference, what it is going to cause, so then they can come again. That is okay.
Dr. Praveen made
yes,
a point. What's your name?
Hi, yes.
Dr. Praveen made a point. The biceps and the triceps have essentially got nothing to do with the shoulder, but they act by pulling the humerus up. Okay. And when you do a trapezius transfer, you are preventing inferior subluxation. So, if you do only a trapezius transfer without innervating the biceps and or the triceps, it is still going to, gravity is going to pull it down. So, it always makes sense to make sure that you provide elbow flexion and extension if possible, then do the trapezius transfer.
Yeah. So this is what I think Sir was talking about, Saha's principle. So Saha's principle, one of the very fundamental biomechanical principles in shoulder when we study in orthopedics. So shoulder require two set of muscle. One is the stabilizer, other one is the mover. So stabilizer are the rotator cuff muscles, which are very close to the joint. The mover is the deltoid. So if the stabilizers are not there, the mover cannot do anything. It will not work well. So that two muscle requirement concept actually comes again important in this. Suppose biceps is working, the long head starts acting like a stabilizer of shoulder. then your trapezius to deltoid transfer is likely to work better. But if it is totally flail and there is no stabilizer at the shoulder, then the mover is not going to work. So it correctly reflects your clinical experience and that biomechanical principle why you are seeing that. So that's why I think it is good on our part, because the operation is not being done for 1 year, 2 year, it is for the whole life of the patient. So, and if we advise them correctly, most of the patient will understand actually and they will appreciate that. And by the time it is you do the trapezius transfer, you can put a nice shoulder strap inside. It will come under the normal dress. They can put that and roam around. So that will provide enough stability till you go for the trapezius transfer. Thank you.
Thanks.
So, what about secondary procedures for elbow flexion? As I said earlier, you're only restoring flexion, you're not restoring supination, which the biceps normally does. Because almost all these transfers tend to pronate the forearm. So the accepted methods of restoring elbow flexion are the bipolar LD transfer. The LD is a synergist. Every time you flex the elbow, you can look at me. The LD pushes the arm back and that helps in flexing. So it's a perfect synergist. The triceps to biceps, I agree, is an antagonist. The Steindler transfer, again, is a synergistic. In fact, the Oberlin procedure works initially because of the Steindler effect. In a panplexus, obviously, you have the gracilis functioning muscle transfer. I have heard about the brachioradialis migration, but I've never seen a paper, at least full text. So it's theoretical for me. So first, you need to know whether you've got an M0, M1 elbow, M2 elbow, or an M3 elbow. If it is M0 and M1, regardless of whether it's upper plexus or total plexus, I would choose to do an FFMT. Because majority of the pedicle functioning muscle transfers for elbow work only if there is some kind of an initiation of the elbow flexion by the previous nerve surgery. So that means M2 should be there. What about M3? And again, that is where Dr. Praveen's classification comes in. If you are in the first 1 or 2 subgrades, you have to do something to augment and not to replace. So that is called improvement of existing function. And obviously it has to be done end to side. So the LD transfer can be unipolar or bipolar. You may need to incorporate a skin paddle because the distal end is pretty wide. There is a possibility that you can split the LD muscle and use a part of it, but obviously the power is also going to become half. At least an M2 biceps is required. So would you be doing end to side? And as I say, it is eminently synergistic. Relearning is no issue at all. So that is the kind of, the LD muscle. So you have to do a lot of trimming, tailoring. In addition, quite a few people recommend that you incorporate a skin paddle so the distal closure at the elbow is not a problem. As I said, you could take a part of the muscle if you have patients with a high BMI. But then obviously it's going to decrease the power that you generate. The Steindler transfer, certain preconditions have to be met. See, you would always see a patient where he's not able to flex his elbow and repeatedly he curls his fingers. So that means the Steindler effect is already there. So you want to improve it by transferring the common flexor origin to the humerus to make it an elbow flexor. First and foremost, the patient should have active wrist extension of at least neutral, otherwise it's not going to work. Second, it's a procedure. You may in your mind imagine that I'm going to just detach the common flexor origin and transfer it to the humerus. It doesn't work that way. You should intentionally skeletonize the median and the ulnar nerves to keep them out of harm's way. So I would always use a nerve stimulator intraoperatively and do it without a relaxant. You have to preserve all the median nerve branches to the flexor muscle mass, insert it into the humerus as lateral as possible to overcome the pronating effect, and you accept a residual loss of elbow extension, meaning the patient will have a flexion contracture at the end of the surgery. You're just converting the arc of flexion. You can't get from 0 to 135, so you get something from 45 to 120 or whatever. So this is some images to show that the common flexor origin has been isolated, the median and ulnar nerves have been separated, then subsequently you prepare an area in the humerus which is deep to the brachialis muscle, which is going to receive that osteotomized medial epicondylar fragment, and you can fix it with, I think it's called a corticocancellous screw with a washer. So this is a technique that can be done. The next, the one on the left is something like a pectoralis major transfer, which has been described by Clark, it has been described by Dr. Doi, or a pectoralis minor transfer. I don't have experience of it, but it's been described by Dr. Julia Terzies. And they are eminently suitable for upper plexus kind of injuries, where you know that the contribution to the pectoralis major from the lower trunk is intact. It's a very cumbersome operation. You need to harvest the entire sternocostal portion of the pectoralis major, prolong it with a part of the anterior rectus sheath if you want to avoid putting a fascial lata graft, so that it reaches the distal end of the elbow adequately. You may or may not detach the origin also. So it would be again unipolar or bipolar, but it's an operation of a considerable magnitude. A lot of dissection is required. You can see that incision right from the clavicle down to the upper third of the abdomen. There is a simpler technique which I actually picked up when I attended the congenital hand meeting in Ganga, where it was actually described for arthrogryposis multiplex congenita, kids, who can't flex their elbow from birth. There they just detach the insertion of the pec major and detach the long head of the biceps and then weave it across. I can understand that this coaptation is very far away from the elbow. So again, it should preferably be used in a patient who already has some residual elbow flexion. You can't do this for an M0. So this is what we did in that patient. It was only about a couple of months back. Use that incision to expose the insertion of the pec major. When you cut it, you can immediately see the long and the short heads of the biceps. So detach the long head and then weave it in a pulbotapped fashion. No graft, nothing is required. So, but such proximal muscle transfers, I would encourage you some kind of an early active movement for two reasons. Because these are proximal transfers, the chances of adhesions are very, very high. Second, before the patient goes home, he has this confidence that, yes, I have been able to start moving my limb. I'm not doing the movement, the patient is doing the movement on his own. It is only that I'm assisting him in his elbow flexion. You can do that even before the patient is being discharged. I found this technique interesting. I don't have much experience, but it removes the cumbersome process of dissecting the entire, anterior chest wall and the upper abdomen using the conventional method. Then we come to what is called the triceps to biceps. Both these patients have got a complete flexion at the elbow because of a triceps to biceps transfer. I admit that I don't have any recent photographs. Most of the time now I'm taking videos only. So when you do this kind of transfers, again, before you discharge the patient, some kind of assisted active movement is much, much better because the patient is confident that he's able to move. And sometimes it makes sense. How are you going to teach the patient by transferring the triceps to the biceps, which is an antagonist? I sort of learnt a jugaad. Hyderabad, the word jugaad, it means that it's a shortcut. I tell the patient on the normal side, you extend it, and on the ipsilateral side, you flex. This is a very natural movement. So here is moving the triceps, that is somehow signaling his brain to flex the other side. I don't know whether there's any substance in this, but I do this. When you do a triceps to biceps, you have to have an M5 triceps. If you have M4 triceps, then you expect a weakness in elbow extension. Use the long head past medial to anterior. Don't use the lateral head. End to end is always better than end to side. Rarely in a panplexus injury, when another procedure has failed, say a functioning muscle transfer, I would use the entire reinnervated triceps to transfer to the elbow flexor. But in such situations, the patient will have a flexion contracture of the elbow. This is just a child in whom secondarily we had to do a triceps to biceps. And you won't believe it, children don't need any training. They seem to do it automatically, even if you immobilize them for 4 weeks and then call them back. So they can, sort of generate enough strength. You can put your finger across and give resistance, but still the kid will be able to do without any teaching. So it is a useful procedure, even though it defies any logic. So I finish by saying, why should it work and why should it not work? I mean the triceps to biceps. Children learn automatically, so there is probably an element of cortical plasticity. And as I said, the trick is alternate extension and flexion of the two elbows may sort of induce the patient to be able to flex the elbow in a triceps to biceps transfer. With a proximal muscle transfer, the chances of adhesions are extremely high, so some kind of assisted active movement will give you much better results. I would be very wary of doing a triceps to biceps in a patient who is head injured or elderly patients who may be having some cognitive difficulty, because these are exactly the patients in which I have not got a good result. Beyond that, I have not really researched into it, but just keep it in mind. Just before I finish, if anyone in the audience wishes to give me the answer, I have never been able to figure this out. Which is more important as an elbow flexor, the biceps or the brachialis? The brachialis or the biceps? Why do I say this? Every time I look at that small muscle across the elbow, I am reminded of the supraspinatus at the shoulder joint. Without the supraspinatus, the shoulder cannot abduct. So is it true that the brachialis initiates the elbow flexion and the biceps carries it out? That makes sense because Ganga Hospital team has proved that double fascicular muscle transfers are better than single fascicular muscle transfers. So the brachialis is actually a pretty important muscle. I think so. I don't know. Thank you.
So free functional muscle transfer is there also for next to follow. Thank you very much.
Okay. Thank you, sir. Now I would like to invite Dr. Giri, sir, to kindly felicitate our moderators.
Speakers.
Thank you, sir. For the next session, may I please invite Dr. Sunil Raut, sir, and Dr. Kalyan Das, sir, for moderation. Dr. Kalyan Das, sir. May I please request Dr. Devi Mahapatra, sir, to kindly moderate this session? For our next talk, can I invite Dr. Vibhuti Bhusan Nayak sir for insights into brachial plexus injury.
Professor Vibhuti Nayak doesn't need an introduction. He's a well-known face and well-known faculty for the entire nation. So straightforward, I would request Vibhuti sir to start his deliberation.
A very good morning to all of you. At the outset, I must congratulate Dr. Giri and his team for yet bringing out another excellent workshop. They have been doing it on a regular basis and are really in the forefront of academic and practical teaching in the state of Orissa. Congratulations to the team once again. My talk is Insights into Brachial Plexus Injury, and I have been into it since last 3 decades. 30 years ago, during my residency, the brachial plexus injuries I saw were predominantly global palsies. The results appeared poor. The textbook concept of the flare limb and even amputation in selected cases seemed reasonable at that time. Over the years, conferences, interaction with experienced brachial plexus surgeons and my own experience completely changed my perception. The important lesson, brachial plexus injury is not one disease. The pattern of injury determines the prognosis. What remains is as important as what is lost. In upper and upper middle trunk injuries, particularly when the lower trunk and hand function are preserved, neurotization can produce excellent results. Shoulder abduction and elbow flexion can be restored. Functional recovery can be substantial. Many patients can return to most activities of daily living. So here is an example. He's an engineer by profession, and he had upper and middle trunk injury. He is a nephew of one of the senior plastic surgeons. He is able to flex his elbow completely, and he is able to do most of his activities. And since he was an engineer, I asked him, what score will you give at the end of the surgery for your recovery? I know the score, but he gave 10 out of 10 out of emotion. It was not actually 10, it was 9. So here is another patient, upper and middle brachial plexus injury. If you look at the video, it's difficult to make out which side was affected. But why I'm showing you this slide is because you can get excellent results in upper and middle trunk injuries. The problem with waiting for recovery, brachial plexus surgery is a surgery of patience for both the surgeon and the patient. The patient may see little visible movement for months. Shoulder recovery may begin around 4 to 5 months. The elbow recovery may take 8 to 12 months. But after waiting almost a year, if meaningful recovery has not occurred, the surgeon faces a difficult reality. At this stage, we have to consider the possibility that the reconstruction has failed. And this is not merely a surgical problem. It becomes a communication problem as well. The patient has waited for months with great hope, financial difficulty, and emotional investment. Telling the patient that the expected recovery has not occurred can be one of the most difficult parts of brachial plexus surgery. So counseling is part of the operation. Before surgery, the patient should understand when will recovery appear, what function are we expecting, what may not recover, how long will we wait, what will we do if recovery does not occur. This is particularly important in global palsy. A technically successful operation and a satisfied patient are not always the same thing unless expectations have been correctly established. Low trunk injury is a different ball game. Upper trunk plus preserved low trunk, generally excellent potential for functional recovery. Low trunk plus preserved upper trunk, much more difficult. Reason, the regenerating actions have a long distance to travel to reach the target muscles of the hand, and the intrinsic muscles of the hand are particularly vulnerable to prolonged denervation. The prognosis of a low trunk injury cannot simply be extrapolated from the results of upper trunk reconstructions. So, the global brachial plexus is the ultimate challenge. The others are partial varieties where it's little simpler to manage, but global is always a big challenge. Historically, the global palsy appeared almost hopeless. With reconstruction, we can obtain shoulder abduction with reasonable proportion, in a reasonable proportion of patients, and elbow flexion in selected patients. Useful positioning of the limb is possible. And with secondary reconstructions, you have seen so many secondary reconstructions yesterday and the presentations today also. Useful function can be obtained. But there must be one very clear message. A global palsy can be transformed from a useless hand into a useful hand, but not into a normal hand. This distinction should be communicated before surgery and not after surgery. It is the hand where the real challenge lies, because it's the most distal. So, when we do muscle transfer, and in most of the cases, we find the wrist is unstable. And unless the wrist is stable, these transfers may not be helpful. So, gracilis is a good muscle for functional transfer. So, when it contracts, it brings in useful movement in the hand. If the wrist is unstable, the muscle might contract, but the transmission of power is ineffective. So, wrist arthrodesis has to be done, or it has to be stabilized before functional gracilis transfer. Power without stability does not necessarily produce useful function. So here you can see this example. This is a patient who had a functional gracilis transfer, but you see the position of the wrist. The wrist from the photograph itself looks quite flail. I'll show you the video. You can see the gracilis contracting very well, and he's able to produce elbow flexion. But look, when he's producing elbow flexion, what is happening to the wrist? That's not because we have not done the wrist arthrodesis. The patient was not willing at all to touch the wrist. I don't know why. 10 years after this also, he has not given his consent for the wrist arthrodesis. He's getting good elbow flexion, and if you get the wrist into cock-up, he's also getting some amount of finger movement, but still he doesn't agree for a wrist arthrodesis. But I have showed this video to show you what is the importance of wrist arthrodesis before we do a functional muscle transfer. So the goal of functional muscle transfer is not merely, can I make the muscle contract? The real question is, can the transferred muscle generate a movement that patient can actually use? Therefore, reconstruction must consider the entire functional chain. First, reinnervation, then muscle power, stable joint, appropriate excursion, then only you will have useful movement. This is particularly important in global brachial plexus palsy. In Indian scenario, in our part of the world, many patients present late. Some patients have seen neurologists, neurosurgeons, orthopedic surgeons, and general practitioners. I have seen patients as late as 4 years after they have consulted multiple neurosurgeons. At this stage, opportunity for meaningful nerve reconstruction may not be done. The reconstruction strategy therefore changes. The answer may be functional gracilis transfer. So this is a child, 2-year-old child who had obstetric brachial plexus palsy and no elbow flexion. So here the functional muscle transfer was the only answer. And this is almost 6 months after the transfer has happened. So he is able to get little bit of elbow flexion. And I followed up the same patient, and now you can see that he is able to flex his elbow, and most importantly, because the wrist is stable and he is to do he has the lower trunk preserved, he is able to do most of his activities. So if you compare early versus late presentation, in early nerve reconstruction is possible, late nerve reconstruction often no longer useful. So in early, you can do neurotization, in late, functional muscle transfer. In early presentation, you have better biological potential, but In late, there is established muscle denervation. In early, the goal is re-innervate the native muscles, but in the late, create new functional muscle. The psychological dimension. Brachial plexus injury is not merely a motor deficiency. It is a sudden transition from normal to disability. One fine day, you find that your hand is not functioning. The patient may lose independence, employment, social confidence, body image, ability to perform basic activities. Some patients have profound difficulty adapting psychologically to the new disability. And I have seen some of my patients receiving psychiatric treatment for the same. So the psychological impact of brachial plexus injury can be important as the physical disability. And counseling should begin very early. So there are three broad prognostic groups. One is upper or upper middle trunk injury. It's mostly predictable, excellent potential for meaningful recovery when appropriately treated. The low trunk injury, it's difficult, particularly because of the distance to the hand and the vulnerability of intrinsic muscles to denervation. The third component is the global brachial plexus injury. This is the most challenging, but not hopeless. Useful shoulders and elbow function can be achieved, and secondary reconstruction may convert a useless hand into a useful assisting hand. So what I have learned about the timing, the earlier the patient reaches the right surgeon, the greater the reconstructive possibilities. The first 6 months are particularly important for nerve reconstruction. Beyond that, the options progressively change. And when the patient arrives very late, do not waste time trying to reproduce an early strategy in a late presentation. Change the strategy. So what should we promise the patient? In upper and middle trunk case, we have a good chance of restoring significant function. In the low trunk, recovery of the hand function is much more difficult and less predictable. Global palsy, we may be able to make limb useful, but we cannot promise a normal hand. The patient must know not only what we hope to achieve, but also what we may not be able to achieve. So major insights, brachial plexus injury is a spectrum, not a single entity. Residual function is a major determinant of prognosis, just like when we resect a tongue, the residual tongue decides the function of the reconstructed tongue. Similarly, residual function is a major determinant of prognosis. Upper and middle trunk injuries can have remarkably predictable and excellent outcomes. Low trunk injuries are much more difficult, particularly for the hand function. Global palsy is not synonymous with a hopeless limb. Shoulder and elbow recovery are achievable even in global palsy. A stable wrist is essential for effective functional reconstruction. Functional muscle transfer has an important role, especially in late presentations. The hand remains the greatest reconstructive challenge. Timing changes the operation. Counseling is as important as the operation itself. The ultimate goal is useful function and not a normal limb. So 30 years ago, I saw a global brachial plexus palsy and I saw a flare limb. Today, I see a reconstructive challenge. I no longer ask whether I can restore a normal limb. I ask what useful function I can create. In upper and middle trunk injuries, that function can be remarkably good. In low trunk and global injuries, the challenge is greater, but even a useless hand can sometimes be transformed into a useful hand. The most important lesson is to understand the injury, respect the biology, operate at the right time, reconstruct intelligently, and above all, communicate honestly to the patient. Thank you.
Lot of take-home messages, and particularly the 12 principles which you enumerated. I think like Gillis principles of plastic surgery, this should be remembered by everybody. Regarding my particular, which I liked was power without stability is useless. That is a very nice comment and a very remembering kind of thing. And we showed it in example of the wrist stability. In addition to that, just I have one question, sir. Like depending on the type of injury, upper trunk, lower trunk, global palsy, do you have a threshold for like re-exploration or secondary procedure? Like you told, we wait for 1 year, then you see that if the site of injury is different, do you have a different threshold? Like somewhere you plan to jump in for the secondary procedure or a re-exploration, or somewhere you want to wait for a longer time? Do you have some guidelines for that?
See, in brachial plexus injury, unlike distal hand injuries, we have to wait. So the waiting, sometimes we can get result as late as after 1 year. So we don't know what is happening. Clinically, of course, we can look for Tinel sign and EMG nerve conduction studies, but they even don't give you a very good guide about what is happening. So you have to wait for 1 year. And after having waited for 1 year, re-exploring the same knob and repairing will not make much sense because most of the target neuromuscular junctions will have denervated. So in my opinion, if you have waited 1 year, you can wait 6 months more because anyway, you can have little more patience. Some patients also recover after 1 year and 2-3 months. That's also is seen in some cases. So instead of rushing in for another re-exploration, the waiting game will give you to another surgery that will be a functional muscle transfer because at that time you will not be able to renovate the muscles which are already biologically lost their neuromuscular junctions.
Thank you, sir. Any questions from the audience? Sometimes you might have seen an orthopedic patient who had clavicle fracture. He was treated by, hello, yeah, a orthopedic patient who had a clavicle fracture, also who had a global palsy or a brachial plexus injury, but was unnoticed by the primary surgeon. And he had his clavicle fixed with a steel implant. Then you do not have the scope to go and do a MRI. The patient comes to you after 2 months of having that surgery or the injury itself. And how are you going to deal with that patient? We are going to take off the plate and send him for MRI. We are going to wait and based on your clinical findings, we are going to suggest him that we are going to wait till the fracture units and then we are going to do the secondary procedures. What will be your...
Yeah, first let me tell you that there are some instances where patient with fractured clavicle and with a global brachial plexus, we have done both simultaneously. We have done the fracture fixation and at the same time explored the brachial plexus and done it, but that doesn't happen very frequently. And coming to the second part where it has been fixed, nowadays most of the orthopedic surgeons, they use titanium plates where you can do a MRI. Suppose they have put a stainless steel plate and you have you need a MRI, it's not possible to do. So there you have to go by your clinical examination. You look for Tinel's sign in the neck. If you're not getting any Tinel sign and all other clinical examinations reveal that it's a preganglionic injury, based on your clinical inputs, you can decide on the surgery. But let me tell you, in global brachial plexus surgeries, I have done quite a bit. Most of the time, exploring the neck doesn't give you a route which you can neurotize. Very rarely you will find out of 100, 3 or 4 cases, you might get some routes where you can use them for neurotization. Most of the time, the global brachial plexus surgery doesn't give you any scope to use those avulse routes. You have to look for other nerves for neurotization. So either way, it doesn't help. You have to go by your clinical acumen. Removing a plate just to do a MRI, I don't think makes much sense.
I also wanted to know whether based on your clinical diagnosis only, you're going to explore the neck and then proceed with the primary nerve surgeries. You're not going to document it with a MRI?
See, MRI documentation, why do you need a documentation? If you can clinically...
For any legal dispute, if it arises later.
Okay, so that's something I have to look into. I have not done it yet. I have not faced that legal issue either. So doing a MRI when the implant is already there, your justification is that MRI cannot be done. So based on the clinical findings, these are my findings. You can take the findings from a neurologist also. You will also have EMG nerve conduction to give you inputs about the nature of the brachial plexus injuries. You have the video recordings of what the patient had. So just MRI is not going to save you. If the patient is not happy with you, patient will not be happy with your MRI either. So you will have to fight a court case.
Dr. Shrikant had something to say. Please tell, sir.
Am I permitted to give my comment? Because there are a lot of students here. One, your diagnosis of brachial plexus injury is a clinical diagnosis. Any investigation that you do is only going to tell you what you are going to do. Once you decide that so much of time has elapsed since the injury, there is no clinical recovery, you have to operate. I can understand your concern because when you write in a case sheet, no one is going to believe you. You give a computer-generated report, they are going to believe you. That's how the system works. You can't help it. There are some MRIs, even with stainless steel implants, they are able to do. Now, I don't know the technology. If you can't do, get an ENMG done. They also have a computer-generated report, so that should be sufficient for you. But you do not base your decision to explore on the basis of CT, MRI or ENMG or whatever. It's only clinical diagnosis. What you expect when you explore is what MRI tells you or ENMG tells you. Not even ENMG, MRI tells you. But now, HRUS is being used even for brachial plexus injuries. At least our radiologist for infraclavicular plexus injuries is able to tell us the site of injury, if that is what you're looking at.
Thank you, Shrikant sir. Thank you, Vibhuti sir, for your nice presentation. Now we'll call the next speaker.
Respected seniors, colleagues, and my dear friends, at the onset, I would like to thank Dr. Sanjay Giri sir and the entire Department of Plastic Surgery at AIIMS Bhubaneswar to give me this opportunity to talk about free functioning muscle transfer in brachial plexus injury secondary procedures. I would also like to thank Dr. Shrikant sir and Praveen Bharadwaj sir for their excellent demonstration yesterday. And it is an honor and pleasure for me to talk in front of the stalwarts of brachial plexus surgery in India. Just now, Nayak sir presented his 3 decades long experience in plastic surgery. Ours is relatively small, less than 3 years. So indications for brachial plexus repair is most commonly in our setting, it's a delayed presentation because the patients are referred from various people, various branches, various departments, and so there is a delayed presentation. And the another indication is unsatisfactory outcome from a prior nerve surgery done by ourselves and absence of any local donor tissues or a complete or severe supraclavicular root avulsions. The goal of FFMT in our hands is mainly restoration of elbow function and restoration flexion and restoration of finger flexion. So pre-op evaluation and clinical diagnosis, as sirs have rightly said, is the most important thing. But another thing which we have to look specifically before performing a free functioning muscle transfer is CT angio and Doppler of the entire hand. That day on the rounds with Shrikant sir, he aptly demonstrated that to feel the radial artery pulsations so as to clinically judge if any subclavian artery thrombosis or any other vascular problems that can be anticipated and confirmed on a CT angio. And also at the same time look at the donor nerves for coaptation. So this is the basic marking of a free functioning muscle transfer, gracilis, which is the most commonly used, from the pubic tubercle or the pubic rami to the medial femoral condyle. The gracilis muscles lies posterior to the adductor longus muscle, and it can be the skin pedal can be marked in the approximately 3 finger bits below the pubic tubercle rami. This is a very small video that will demonstrate how the free gracilis muscle is harvested. The exploratory incision is taken, the tendon of the gracilis muscle is identified, And after that, we keep as much as fascia and over the gracilis muscle possible so that it glides well. Then the skin pedal incision is taken, and hitching sutures are taken so that the skin pedal is adequately stuck to the muscle. Yes, recently many hospitals, including Ganga Hospital and I think AIIMS Bhubaneswar also, they have stopped giving the skin pedal, but we continue our journey with a skin pedal so as to monitor our success. As we go below the skin pedal, we will go near the vascular pedicle and identify the vascular pedicle coming below the adductor muscles. Just above the adductor, just below the muscles will be the vascular pedicle, which will be perpendicular to the muscles, and above it will be the nerve coming from the anterior branch of the obturator nerve. This is the complete isolation and islanding. The gracilis tendon is harvested as long as possible, at times with the periosteum of the tibia. This is the isolation of the vascular pedicle and the new nerve. The flap is disconnected, and the microvascular anastomosis is done most of the cases in our experience with the thoracoacromion pedicle. Usually we do both the veins, try to find another vein and do both the veins and an artery. And in this case, we have done a spinal accessory nerve to the branch of obturator nerve. In this case, we could achieve an M3 elbow flexion. The video has been sent by the patient's relative from his native place, and we had immobilized the patient at 90-degree flexion and arm in supination. Initial immobilization of the elbow in 90-degree flexion and arm in supination, then gradual passive stretching, followed by an electric stimulation to maintain the muscle tone, and motor re-education, which will utilize the donor nerve triggers. To conclude, free functioning muscle transfer is an essential stage for late presenting brachial plexus injury. Gracilis is the work of flaps, and modifications as necessary, as we have learned so many in the past 2 days, are necessary at the later stage. So a small stats at AIIMS Nagpur, we have done up till now 47 brachial plexus injuries, 30 have been nerve transfers, 5 had neurolysis, 2 trapezius transfers and 10 free functioning muscle transfers. And I would take this moment to invite all the PG students and residents from the state to attend a quiz which we are conducting next month. It is an online and offline quiz. They can contact me for further details. Thank you so much.
Brachial plexus injury cases at your institution. I believe students will have questions for you, because there are so many practical aspects to free functioning muscle transfer. Yes, Second sir has some.
Before the student asks question, the teacher is going to give a comment. You seem to be a videographer's dream. Did you understand?
Sorry, sir?
You seem to be a videographer's dream. I noticed that you were sitting and operating end on. It's a very difficult position to operate. You were somewhere near the knees, not on the right or the left of the patient.
Okay, sir.
Isn't it? So then your videographer has got his full view. I don't know how you do it, but wonderful.
Thank you.
Second, for some reason, I can't explain, you don't have to do 2 veins. One vein is more than sufficient. I think in less than 2% of all the functioning muscle transfers that I've done, I have done 2 veins. I don't know why, but one is more than sufficient.
So probably beginners.
Yeah, I understand, but over a period of time, because if you're doing the thoracodorsal pedicle, it's not going to be easy to find a second vein.
So at times the cephalic is also there. So
No, when you do thoracodorsal, thoracoacromial is okay. You have cephalic and you have a deep vein.
Yeah.
When you come to thoracodorsal, if you're doing for finger flexion, you will get the thoracodorsal artery with vena comitatus.
Single.
Sometimes there is an additional vein which goes through the fat onto the lateral chest wall, but that is unusual. So over a period of time, you can switch to doing one vein. It's okay.
This is again comment about the 2 veins. when you do two veins, you are little lax because you know that one vein doesn't work, the other vein will take over. But if you do one vein, in your mind, you know you have to score 10 out of 10. So you are much more concerned about the anastomosis. And the literature shows that it's not much difference. And at the same time, when you do a second vein, you are wasting more time dissecting and doing another anastomosis. So if you are doing one vein and you have to do one vein, you will try to score 10 out of 10, a perfect anastomosis.
Thank you so much.
Any other questions from audience? Yes, please. Mike, please.
You stated 10 FFMTs, right? All were done for elbow flexion or any were done for finger flexion?
No, elbow flexion. Thank you, sir. Thank you.
Okay. Thank you so much for a nice presentation. Next speaker, plastic surgeon with decades of experience in microvascular hand and brachial plexus surgery. So I expect sir's presentation will be definitely providing some more insight to us as well as the younger surgeons. Sir, please.
Thank you. I forgot it last time. So, respected moderators, faculty, ladies and gentlemen, I put on record my sincere thanks and appreciation for having a 2-day CME on secondary procedures in BPI. So I'm probably the first one that I'm attending, which is a dedicated CME or a conference on secondary procedures alone. So yesterday it was a very long session, but it was a very educative session because we have amongst us two magnificent faculties who are, internationally acclaimed surgeons on brachial plexus injuries. So the two nomenclatures that we are confronted with in brachial plexus is ABPI and BBPI. So my talk will be absolutely confined to ABPI, adult, because in children we do not do any arthrodesis. So as it is already discussed, despite the recent advances in microsurgery and nerve coaptations, we still have patients who do not get optimum result. And therefore, the secondary procedures are there and are evolving. When we now have more and more procedures offered to the patient, than when we started brachial plexus surgery, maybe 30, 40 years back in India. So the aim is to assist and optimize the results obtained by the primary procedures done so far. These are not primary procedures. So the secondary procedures are not to be a kind of a protocol, but it is based on the patient's results after the primary surgery, individualized. You cannot say for this you do this, and because the recovery from primary surgeries are going to be very difficult to standardize. But if you operate more and more of these cases after about a year, then you fall into a pattern of deciding what am I going to do for what. So arthrodesis is the first one that I have been asked by Dr. Giri to talk about because of my orthopedic background. So Dr. Praveen, here is an orthopedic and plastic surgery combined approach to the secondary procedures. And in arthrodesis, we know that the commonest arthrodesis we refer to is the shoulder arthrodesis. But there are other arthrodesis done as secondary procedures. There is arthrodesis of the wrist, as you have seen yesterday. Then intermetacarpal bone grafting, briefly touched yesterday also. CMC arthrodesis and IP arthrodesis. So these are basically stabilizing structures, Dr. Naik, stabilizing structures so that the power that this person has is amplified. It is not lost in stabilizing the joint so that we have more and more amplification of the power that is there in that patient. So tendon transfers, muscle transfers are all has been discussed. My take on arthrodesis is when you have a flail shoulder or a flail joint for that matter, it is not BPI anymore, it is a paralytic hand. It is a paralytic limb. So therefore, if you have something to stabilize the joint as it was discussed, let's examine a patient who has had spinal accessory to supraclavicular nerve transfer and has had achieved 10 degrees of abduction. This is a fairly stable hand, but we do not have good abduction. So probably these are the cases which will require or benefit from a trapezius transfer. But supposing the shoulder is subluxated, it is completely failed, and then we do not have time to wait further to get the movements in the distal joints like the elbow and the hand, we would like to consider shoulder arthrodesis. As has been discussed by Dr. Praveen, that before you suggest shoulder arthrodesis to the patient, you must show some of the pictures of shoulder arthrodesis in your hand and let him understand what he is going to lose and what is he going to gain. So in distal joints, we have this practice of fixing these joints temporarily with 2 crossed K-wires and ask them to tell whether it feels better. And these are paralytic hands, mostly the sensation is not there, therefore you don't even require local anesthetic to fix 2 K-wires across a joint. And then ask him whether he is able to perform better. And while doing so, we can also change the angle of predicted angle of arthrodesis and finally arrive at that this is the amount of angulation at a joint, like a wrist or a MP or an IP, that this is going to work best for this patient. So, shoulder arthrodesis, wrist arthrodesis, fast CMC arthrodesis, thumb IP arthrodesis, MCP arthrodesis, and PIP arthrodesis. We have all arthrodesis in the hand possible for a paralytic hand, applicable for a neglected or a poorly recovered brachial plexus injury. So in fact, this gives us an interesting arthrodesis ladder, like a reconstructive ladder. Shoulder arthrodesis to stabilize the proximal platform, that is the shoulder. Wrist, stabilize the carpal platform. CMC and fast 2-second intermetacarpal fusion to stabilize the thumb ray. Thumb IP arthrodesis to stabilize the terminal part of the thumb, followed by a prefunctional muscle transfer and FDP extension to get the best out of a neglected chronic BPI. Of the arthrodesis relevant to BPI, the strongest published evidence outside the shoulder is for wrist, fast CMC, thumb IP arthrodesis as a combined reconstructive surgery in complete BPI, ABPI. This is published in the American Journal of Hand, and it gives a perspective that arthrodesis should not be considered a no-no for any BPI patients. Coming to shoulder arthrodesis briefly, it is not a commonly performed surgery in BPI. However, BPI remains a common indication for this procedure. Please try to understand the theme of arthrodesis, that it is not a commonly performed surgery. But when you think of an indication for arthrodesis, BPI is a common indication. The advantages of shoulder arthrodesis is in treating upper arm type BPI, shoulder arthrodesis can further improve the functional outcome in patients with preserved or restricted elbow flexion function, which has been discussed recently. So patients with preserved scapulothoracic motion can obtain a stable, painless shoulder joint with some degree of active elevation of the shoulder after the shoulder arthrodesis. You see, existence of a good motor power in trapezius, teres major is and serratus anterior is very important to get any good result from shoulder arthrodesis. Therefore, it is like when we do a trapezius transfer, it is very difficult to find out how much of this abduction is because of the scapulothoracic motion and how much is because of the glenohumeral motion. If you look at a patient from the back, I will show you a few videos, you find that in both of these there is a scapular movement, a rotation of the scapula, which is happening to this shoulder, whether it is arthrodesed or it has had a trapezius transfer. Often done as a primary procedure in patients with neglected upper plexus injury, but this is not typically a primary one. This is a secondary procedure, but the first procedure in a neglected BPI. The pitfall, shoulder arthrodesis has been associated with a high rate of complications, including non-union fracture, implant breakage, and so on. Therefore, a less traumatic and complication-free and predictable technique of an ideal arthrodesis is the desired goal. So it is not without any complications. Arthroscopic assisted techniques have been published and have been discussed because it's a very grotesque surgery, open arthrodesis. So arthroscopic pairing of the glenoid and the humeral head cartilage followed by an implant fixation reduces the bleeding, reduces the trauma, and probably the patient can get back to work earlier than usual. So the optimal position of shoulder arthrodesis has been debated, but now we accept that it is 30-30-30. Like this, the patient has 30 degrees of abduction in the shoulder, 30 degrees of forward flexion, and 30 degrees of external rotation. So this position of 30-30-30 supposed to be working very well. So this is the picture of a person who has had previously operated shoulder arthrodesis in 4th June, right intermetacarpal bone grafting in 3rd July of 2023. Oberlin was done earlier on 11/10/2022. So we have done this procedure in a patient who has had fusion of the shoulder, carpometacarpal fusion, and an intermetacarpal fusion as well. So this is his position at rest on the right. This is the amount of abduction that is fixed, and this is the amount of abduction is possible after shoulder arthrodesis. No arthrodesis for elbow. Then you come to the wrist. But if you're, like I said, looking at the patient from behind to see the amount of scapular movement, Sorry, how do I? So look at the, I wish you to focus on the picture on the right, the amount of scapulothoracic motion that is required to produce an abduction of 90 degrees. This patient also had a Stindler's procedure, and that keeps the elbow little stabilized. The wrist surgery is waiting. Arthrodesis has been discussed pretty well. I'll come to this important thing that I have been doing quite often in these patients. Is, you see this patient has undergone a CMC fusion as well as an intermetacarpal fusion. So the position of the thumb now comes in front of the second metacarpal, is a perfect position of opposition, helps this patient to use his finger flexions of the other fingers in holding important objects, especially the bike that they drive. So this is the amount of flexion that was possible from the fingers. The thumb was completely paralytic, and so this is the position that we have after the CMC and intermetacarpal fusion. So if you mark his right hand when he's driving, he has had no wrist arthrodesis. He has only the intermetacarpal and the CMC arthrodesis. Gives him a very good grip and is able to ride a bike very comfortably. So what exactly is intermetacarpal fusion? The idea is that the first metacarpal has to come in front of the second metacarpal in a position of opposition. CMC alone doesn't give the kind of stability that CMC combined with intermetacarpal fusion gives. So therefore, in all patients with median and ulnar nerve injury, we consider this procedure, and we also consider the same for brachial plexus injuries. It has a lot of benefit. CMC fusion can be done in many ways. They are not difficult procedures to be done by plastic surgeons. You can always try and do it. You don't have to take the help of an orthopedic surgeon if you do not have one. If you have one, fine. So simply putting two K-wires after pairing the joint margins in two different angles will do the purpose. IP arthrodesis again is a very useful procedure that we do not do routinely, but sometimes when we find that the thumb grip needs a little improvement, supposing he's like pinch grip, key pinch, doing arthrodesis of the IP about 5-10 degrees of flexion gives him that strength in the key pinch. In summary, arthrodesis is often described as a functional tool in BPI. A functional tool in BPI. For the shoulder, it improves the stability and positioning. In the wrist, stable platform for a grasp. In fast CMC intermetacarpal fusion, a stable thumb ray and static opposition. In thumb IP, a terminal stability for pinch. And after that, the FFMT and tendon transfer do the miracle. Please remember that all these procedures require an intensive therapy. And if you think that you have done a procedure well and it has not been through a good therapist's hand, you probably will not get optimal result from any of these procedures. Thank you.
Thank you, Subhajana sir, for excellent presentation and explaining it so neatly. It becomes very easy to understand the sequence of arthrodesis, the indications for arthrodesis, and the outcomes. The shoulder arthrodesis, even I was not aware that you can get such good results. And sir, there was one point you told, intermetacarpal arthrodesis using bone graft. Or what is the purpose of the bone graft, sir?
The bone graft actually fuses the bases of the first and second metacarpal in the position that you want.
Okay, okay. All right, sir. Any other questions from the audience? Shrikant, sir.
Have you ever had an occasion to do MP joint arthritis?
Not in BPI,
Yeah.
but in other paralytic hands.
What was it actually?
See, this was not just one. There are many indications of having an MP joint arthritis is that if the MP is extended for a long time
Yeah.
and it remains fixed in that position, we do not expect any improvement to come in that MP joint because of arthrolysis. So they, especially in the second metacarpophalangeal joint, an arthrodesis in the functional position is
okay.
These are all for stability.
Any other questions from the audience?
MCP joint, very commonly in spastic hands, it will be.
I would do, yeah.
Because all of them will have hyperextension at the MCP joint. In brachial plexus, extended plexus palsy, sometimes when they are having the intrinsic imbalance, they will get a deformity like that. Otherwise, not very commonly. So your intermetacarpal arthrodesis is a nice, interesting thing, sir. We generally put one bone graft near to the head of the two metacarpals, like intermetacarpal bone graft. But your technique makes it more simple, I think.
This has been published. Actually, a triangular iliac crest bone, which subsequently gets absorbed, I believe, just because pairing the joint of CMC is just a centimeter away from pairing the bases of the first and second metacarpal. So it makes things simple, and then you are putting a K-wire. So you might as well put another K-wire in that position. It works pretty well.
Thank you, sir.
Thank you very much, sir. We come to the end.
Now, may I please invite Dr. R.K. Sahu, sir, on stage to kindly felicitate our moderators. Now we have finished with this session, and now we move on to our next session, that is e-poster competitions. The rules for this session is that the format has to be in the PowerPoint presentation. It will be a podium presentation in the 16:9 landscape with a maximum of 3 slides. No videos or animations should be present. The time given for presentation is 3 minutes, while there will be a 2-minute question and answering session. All the presentations will be judged under the following headers: relevance to the theme, clarity of the message, creativity, originality, and impact. May I please now invite the judges for the e-poster competition. Dr. R. Shrikant, sir. Dr. Praveen Bharadwaj, sir. And Dr. Devi Mahapatra, sir. May I now invite our first presenter, Dr. B. Pavani Lia.
Good morning, everyone. I'm Dr. Pavani Lia, resident of plastic surgery from IMS and Some Hospital, Bhubaneswar. My poster is on intercostal nerve to musculocutaneous nerve transfer for elbow flexion reanimation in global brachial plexus injury. Global brachial plexus injury accounts for 1.2% of the polytrauma that we encounter, and it presents as a formidable reconstructive challenge, particularly when extensive root avulsion eliminates conventional intraplexal donor options. In this setting, restoration of elbow flexion is pivotal to establishing a functional upper limb intercostal to musculocutaneous nerve transfer harnesses an extraplexal motor source to reanimate the elbow flexors and offer a valuable reconstructive option in these complex injuries. 7 patients were included in this study with traumatic global plexus injury, brachial plexus injury, out of which 6 are male and 1 female, with an age range of 18 to 47 years over a period of 2 years. All the patients are presented following high energy trauma with severe global upper limb dysfunction characterized by marked impairment of shoulder, elbow, wrist and hand movements. Elbow flexion was markedly impaired with widespread sensory and reflex abnormalities, multiple root, which is extending into multiple root distributions consistent with severe global brachial plexus injury. And MRI, mostly all the patients underwent MRI and nerve conduction study, which demonstrates there is a preganglionic root avulsion with pseudomeningoceles and associated postganglionic involvement in selected patients. The extent of injury, it ranged from isolated preganglionic to complete root avulsion of C5 to T2 or C4 to T2 root involvement. A nerve conduction study demonstrates severe axonal brachial plexopathy with motor axonal involvement in selected cases, supporting the diagnosis of extensive plexal injury and need for extraplexal neurotization. Surgery, all the patients underwent intercostal nerve to musculocutaneous nerve transfer using the 3rd, 4th, 5th intercostal nerves as extraplexal motor donors. The intercostal nerves were identified and meticulously mobilized to obtain adequate length for the transfer to the musculocutaneous nerve. Following preparation of the recipient nerve, microsurgical tension-free neurography was performed. Post-operatively, all patients underwent structural physiotherapy and motor re-education with serial clinical assessment for re-innervation and recovery of elbow flexion. Out of 7 patients who are prospectively followed post-operatively, 3 patients pertaining 42.9% achieved MEM3 and greater elbow flexion recovery with useful motor recovery observed at 8 to 9, 9 and 10 months respectively. 2 patients demonstrated no clinical or electrophysiological evidence of innervation at 12 months of post-operative period, and 2 patients are still in early post-operative period at 7 and 11 weeks respectively. And these patients who are in early post-operative periods or remained under physiotherapy and motor re-education with recovery yet to be assessed. No major procedure-related complications were observed during the reported follow-up. A conclusion, intercostal nerve to musculocutaneous nerve transfer represents a valuable extraplexal option for elbow flexion reanimation in global brachial plexus injury when conventional proximal donors are unavailable. In this case series, useful M3 or greater elbow flexion recovery was achieved in 3 patients, although recovery was delayed and variable. Early reconstruction, meticulous microsurgical coaptation, and sustained postoperative monitoring, postoperative motor re-education remain critical to maximizing functional recovery. Thank you, everyone.
Anyone would like to ask a question?
So, did you use the nerve coaptation? I mean, you did the nerve coaptation with sutures or glue?
Sir, both, sir. Most of the patients we used monofilamentous nylon, sir, along with fibrinogen glue also we used, sir.
How many intercostal nerves you used, and the routine that 2 or 3 nerves you used?
Sir, we used 3, 4, 5 intercostal nerves, sir. But many meta-analysis shows there is no difference between using 2 intercostal nerves and 3 intercostal nerves outcomes.
Did any of these patients had a phrenic nerve injury?
No, sir. No. Thank you, sir.
Thank you.
Good morning, everyone. So today I will be talking about management algorithm for traumatic brachial plexus injury. The aim of this study was to provide a workable algorithm for management of traumatic brachial plexus injury. PubMed and Google Scholar search were done for the words traumatic brachial plexus injury, review literature and systemic literature, and further all the selected journal data were compiled to give a probable algorithm. I'm not telling it's final, but it's a probable algorithm. So a patient presenting to us with a flail limb or inability to move any parts of the body can be divided depending on the presentation, whether it's immediate, early, that's within the NMG recovery time, and late, that's after the NMG depletion time. And in immediate presentation, patient with having open injury, penetrating injury, or respiratory vascular injury, we need to explore. And if the patient presents immediately with a closed injury, we can observe with clinical and electrophysiology studies, and whether the function is recovering or non-recovering, depending on the patient can be further classified. If the in recovering functions, we can keep on the observation, and in non-recovering functions, we need to explore the patients. And in patients with presenting early within NMG recovery time, in non-recovering function, we can directly go for explore, and in recovering function, we can do observation with EDS studies. So coming to the exploration, in root evolutions, we need to think of neurotization as early as possible, depending on the available functional nerves. That's interplexus neurotization is preferred over extraplexus neurotization. And in distal injuries, we can always reconstruct with nerve grafts. And after reconstruction, we can observe for the recovery. In incomplete recoveries, we can further do electrophysiology studies, and depending on that, if there is no EMG is negative, we can put it in the partial recovery group, and in EMG positive, the patient is having low power. Physiotherapy and muscle strengthening will help to gain some functions. And in patients who has partial recovery in either early or within NMJ depletion period, we can think of neurotization. And after NMJ depletion and the patient who presented towards late with no recovery, we can think of muscle transfers. तो So in partial recovery within NMJ transposition, depending on the function we want to achieve, we can do neurotization. It's always better to do a neurotization if the patient presents to us within the energy depletion period. And this talk is regarding the secondary procedures that are after an energy depletion and patient with no recovery. So in conclusion, the treatment of BPI includes multimodal treatment, and this algorithm may help to choose the best surgical option for the optimal care. Thank you.
Since we share a name, I have to ask you a question.
Sure, sir.
You did a literature search.
Yes, sir.
So what is the connection between the literature search and the algorithm?
Nothing, sir. Actually, there was only one journal. That's the.
Yeah, you can tell.
Sir, the second one, they have given a small algorithm. So the literature search was basically regarding. I tried to find if there is any algorithm already present. So and this was based on 4 or 5 literatures. Those.
What I mean to say is, if you have to derive an algorithm,
yes, sir,
which must be sort of based on a patient population, numbers should be mentioned. Then only you can say that you have a valid algorithm. You can't fashion an algorithm with 10 patients. If you are talking about 3,000 patients, an algorithm makes sense.
Yeah.
So typically an algorithm would imply that you have some patient numbers to talk about.
Yes.
So you don't have any numbers in this?
No, sir.
So this algorithm you designed or the
No, sir.
internet design?
There was one incomplete design. I just further added some things on it.
You use the normal online search or you use the AI mode?
No, sir, not AI mode. I had to read most part of
You
it.
put AI mode, it will give everything, man. Because
I tried it. It didn't give me what I wanted.
Because the algorithm what you put is a nice, decent, but it is not looking like very great.
I had to do it by hands.
Yeah, this the AI will give. Even if we cannot follow it, it will give.
It didn't give me the what I wanted. It just gave me a small one.
You have to feed it better.
I'll try it, sir. Thank you. Thank you, everyone.
Dr. Mausam Maiti.
Good morning, my respected faculties. Myself, Dr. Mausam Maiti, resident of AIIMS Bhubaneswar, MCH Plastic Surgery. Today I'm going to present my paper on anterior versus posterior SAN to assess a nerve transfer for brachial plexus palsy, functional shoulder abduction outcome, or institutional experience. Restoration of shoulder abduction is one of the major reconstructive priority. We use spinal accessory nerve to suprascapular nerve for performing through an anterior versus posterior approach. The posterior transfer permits more distal coaptation, potentially shortening the renervation distance and allowing SSN to inspect and decompression at the same operative time. The objectives of our study being, we compared the average duration required to attain the MRC grade 3 for shoulder abduction, and also we compared the active shoulder abduction range of motion achieved at 1 year of age. And we also described injury to surgery interval in the 2 approaches that we followed. The study group being, we included 42 patients, mostly they were male. The anterior approach being done in 16 and the posterior being done in 26 patients. The materials we use a retrospective comparative study, and sources being we have utilized like on the basis of parameters, and we have compared like the M3 shoulder abduction and active shoulder ROM at 1 year of follow-up. Coming to the results, the study cohort being 42 in number, the anterior approach we use 16 and posterior 26. The average time for M3 shoulder abduction that we obtained in posterior approach is 10.6 months and in anterior being 11.75 months. And 1 year average active shoulder range of motion being in posterior 75 degree and versus anterior 55 degree. Coming to discussion, despite a longer mean injury to surgery interval that we have seen in the posterior approach, but we have seen that there is greater achievement of mean active abduction in the range of motion at 1 year by posterior approach, and also the M3 attained approximately by 8 months earlier in posterior compared to the anterior approach. Earlier comparative works were being done, and mostly they have not shown much significant differences, and few trial studies have shown that posterior sand to assassin approach has subsequent comparative better outcomes and also sometimes mixed results. But our study has shown that posterior approach is comparatively compared to anterior has shown better in terms of early recovery as well as for range of motion at 1 year of follow-up. The limitations of the study being it is a retrospective design and unequal group size because as the anterior and the posteriors were not equal in number, and the baseline difference in injury to surgery durations all were not performed at the same time duration, and there is concomitant nerve injuries were also there in both the comparative groups. And to conclude, in a 3-year retrospective cohort study, from posterior to sand to SSN transfer was associated with faster attainment and along with M3 shoulder abduction, which is greater at 1 year active abduction range of motion. And these findings support the posterior approach as a useful option, but prospective control studies with standardized injury pattern with rehabilitations are required. Yes, sir.
Yeah, I have a question for you.
Hi. Good morning, sir.
Yeah. So you said the recovery is faster in posterior approach. That's understandable. But you said the range is more. Does it mean that we'll always do posterior approach? And how do you justify this?
Sir, actually, in what we have seen that mostly anterior versus posterior, in posterior, they are like at 1 year of follow-up, they are attaining somewhere around 60 to 70 degree of movement, whereas in anterior, somewhere around 50 to 60, like 10 degree to 15 degree difference is there, what we have seen in our patients, sir.
How to justify this?
Sir, for what we have seen, matlab, sir, in posterior approach, the we can justify ki proximal trapezius muscle is spared. Like we are not the trapezius proximal is being spared, so that can be one reason for this more greater degree of movement, sir, that we are achieving.
Is it not the duration that your duration of follow-up is less?
Yes, sir. Our duration is less, sir. We also wanted to follow up the same patients over 3 years and 5 years.
Yeah. So actually, there is a study which correctly compares them. So at 1 year they are different, but at 3 years they are not different according to that study. Because as sir rightly pointed out, if it is not recovering, if there is a distal injury, it will not recover.
Yes, sir.
But the range being less is a little bit of a tricky thing. And when you are harvesting spinal accessory from the anterior approach also, if you are, you will go down and you preserve the upper trapezius middle part. So that is not so much of difference. I think the main catch point in your this study is
follow-up time.
The follow-up time is less.
Yes, sir. Thank you, sir.
How did you choose which one doing anterior, posterior? Actually, there only all the studies go to the mat.
Sir, what in our institute, what we mostly follow is any patients having any, mostly coming with anterior, early injuries, and we are expecting an exploration of nerve. In there, we go for anterior approach, sir. And patients having any clavicular injury, associated other injuries, we go for posterior approach.
Yeah, so it is not explored. So whenever you are not exploring, you go posterior. When you are exploring, you go anterior.
Anterior approach, yes, sir.
That itself, like kind of selection criteria becomes a problem, no?
Yes,
so
sir.
Whenever you are having a comparative study, we have to have a comparison. We should not do with our choice. Even two surgeons doing one doing like that, one doing like that also is not a correct thing. So it is like this. The study which I am quoting is actually from India itself. It came to our journal. I was reviewer of that, so I'm not telling the name of the people. But it was just like every alternate case they did, anterior, posterior, anterior, posterior.
Like there was no selection, they did alternately, sir, anterior.
Yeah.
Okay.
And then that is a good study. So then, but their study finally tells both our results are same.
Thank you so much, sir.
Thank you. Our next presenter is Dr. Subhashri Page. Wait, no.
A very good morning, everyone. Myself, Dr. Shubhashri, and I'll be presenting a modified trapezius transfer. It's a novel dual target technique for restoration of shoulder abduction. So as we all know, the restoration of shoulder abduction in brachial plexus injury, especially after late presentations, is quite challenging. The sequence for shoulder abduction is such that supraspinatus initiates it and then deltoid takes it over. So in the existing knowledge, we found lacunae such that the trapezius transfer targets exclusively the deltoid and nothing is done for initiation or stabilization of the shoulder joint. So our study aimed at a modified technique which included trapezius transfer to deltoid as well as supraspinatus for stabilization, induction and maintenance of sustained shoulder abduction. Our study was carried out for the duration of 18 months with a sample size of 30 patients. And our inclusion criteria were adult patients with traumatic brachial plexus injuries who had passive range of motion at least around 120 degrees and presenting after 1 year post-injury either as primary or as failed nerve transfer. We excluded patients who had trapezius less than MRC grade 4 and any conditions which have contributed to shoulder stiffness. So our surgical technique is a modification and extension of the modified trapezius transfer technique given by Dr. A.K. Singh sir and Dr. Durga Karki madam in the year 2007. So with our technique did not use any screws or any sort of bony anchorage. So in lateral decubitus position, we use the S-shaped incision as shown. And we raise the trapezius with a strip of just periosteum, not the bone, and separated it from acromion and spine of scapula. We dissected the trapezius as proximally as possible, and after that we exposed the supraspinatus. We dissected the supraspinatus from the origin, and anterior strip of trapezius without dividing was first hitched to the supraspinatus using Ethibond 10 sutures, and trapezius was transferred to deltoid by double breasting technique. We split the deltoid and the trapezius was then transferred with a periosteal hitch, and double breasted technique. We transferred it as distally as we could. We targeted that we should reach the tuberosity, but we couldn't reach till there, but we as much as possible we transferred. We maintained immobilization in 110 to 120 degrees for 8 months and nocturnal splint for 8 weeks, and nocturnal splint for another 15 days. So our results gave us a mean abduction of 62.97 degrees, and there was a significant improvement in the DASH score. However, our study was only a single institute study, only with 30 patients, and we had a follow-up of only 6 months. So we need to do a further follow-up to check the results. And these are some of the results which are showing the pre-op and the post-op pictures. So to conclude, this is to the best of our knowledge, this is the first study which has targeted trapezius to deltoid as well as supraspinatus. And we have used a screw-free fixation because in our center we had encountered a lot of cases of screw loosening and failure with time. And we have found not much increase in the operating time. So we would like to further do this on a higher scale in future. Thank you.
Question one, the more important one. When you insert a muscle to two different targets,
yes, sir.
Is it likely that both of them are going to work, or which is going to work?
Sir, basically, madam, what we have concluded is supraspinatus here is just being augmented because since the anterior fibers.
You have split the end of the trapezius to give two
No,
different
sir, we have not
insertions?
split it. We have just the anterior fibers, we have sutured it without splitting.
So it's unlikely to really work because it depends on the tension, the terminal insertion, and whichever is the tighter one, that's going to work. The other one just comes loose. That's what common sense about transfer says. Number 2, have you used AI to create this presentation?
Sir, I have used for the layout, I have used
that's what
for
I
the
meant.
layout and the graphics.
You have used AI for the graphics.
Yes, sir.
So what was your sample size you told?
Sir, we did it in 30 patients.
Okay, and why do you feel that your transfer is better than the traditional transfers which are available?
Sir, I cannot say it's better, but we have found a new technique with a similar operating time. The results were comparable. So we want to do it on a higher scale and with a longer follow-up. That is it actually sustainable in the long run? Thank you.
Our next presenter is Dr. Nikhil Sharma.
Good afternoon. I'm Dr. Nikhil Kumar Sharma, resident at AIIMS Bhubaneswar. I'm going to present a poster on staged functional reconstruction of a pan-brachial plexus injury. So here we have a case of RTA, following which the patient lost the sensation of motor function of his left upper limb, and for which we did SAN to SSN, and after that, as a secondary procedure, we went for FFMT with gracilis. So the patient had an accident in the year 2022, and left upper limb okay. So the patient had a RTA in the year 2022, and he had injury over the left upper limb, and he lost all the motor function of his left upper limb, including shoulder abduction and adduction, and there was no movement over the elbow and the wrist and fingers. On sensory examination, we found there was the sensation was grossly preserved, and after a while, after 7 months, we went for reconstruction using SAN to SSN nerve transfer. Our goal was to restore shoulder abduction and external rotation. So after which, after 12 months post SAN to SSN, we went for secondary reconstruction using right gracilis for FFMT, and for which our functional targets were elbow flexion and wrist and finger extension. The gracilis that we harvested was fixated proximally to the lateral clavicle, and we tunneled it subcutaneously, and we pulvertafted it to the biceps tendon, and we roundabout, and we inserted it, we pulvertafted it to the EDC and EPL en masse for wrist extension, and these are the these are the clinical journey of the patient. Initially, the patient was not able to move his left upper limb, and post SAN to SSN and gracilis FFMT, he was able to abduct his shoulder up to a level of 30 degrees, and wrist and elbow flexion was noticeable in the patients. And even the wrist drop was counted well. Thank you.
What was the time at first surgery? How many months after accident?
Sir, actually accident happened in 2021, sir, mid 2021, and yes, sir, there's some typo,
No,
sir.
it's okay.
Yes, sir.
Assuming that the accident happened in 2022, how many months after that you operated?
Sir, we operated after 7 months, sir.
7 months of the injury.
Yes, sir.
So what was the need to do a staged reconstruction? Couldn't have something been done for the elbow flexion at that stage? So let us assume for whatever reason, if today you get a patient, 7 months,
Yes, sir.
what would you do?
Sir, we'll go for nerve transfer first of all, sir. Exploration and nerve transfer, sir.
What nerve transfer?
SAN to SSN or Oberlin, sir.
In this case, persistent elbow, wrist and hand paralysis, how can you do an Oberlin? This particular case,
Yes, sir.
if you get him today at 6 months after injury, what are you going to do? You said SAN to SSN.
Yes,
Anything else you would like to do?
Sir,
Look, doesn't matter.
okay, sir. Thank you, sir. Thank you.
Good morning, respected members of the jury, senior faculty members. I'm Dr. Neha Sharma, MCH resident, Department of Plastic Surgery, IMS in some hospital. My topic is trapezius transfer for treating the flail shoulder after brachial plexus palsy, a case report. After brachial plexus palsy involving the shoulder, lack of shoulder mobility significantly hinders the use of upper extremity. Secondary operations are sometimes required to restore the function if there is late presentation or the primary nerve transfers fail to show result. These include shoulder arthrodesis, rotational osteotomy, muscle transfers, or a combination of these procedures. For the paralysis of deltoid and supraspinatus muscles, many different muscle transfers have been advocated to restore the movement and stability of the shoulder. This is a case report on the result of trapezius transfer for flail shoulder after brachial plexus injury. We treated a patient of 29-year-old with brachial plexus injury by transferring the upper trapezius to the proximal humerus. The patient had a global brachial plexus injury and had undergone nerve transfer elsewhere, SAN to SSN and intercostal to musculocutaneous. The results were unsatisfactory for shoulder mobility but had a satisfactory results for elbow flexion, which was M4. The wrist and the finger flexion and extension was not present. The delay in the between the injury and the transfer was 2 years. So the shoulder abduction in the pre-op was only 10 degrees. So these are the various intra-operative steps. First, we use the skin flaps was raised, the deltoid and the trapezius muscle insertions were exposed. Dissection was done for the trapezius insertion, and deltoid was also partially detached from the lateral third of the clavicle. Followed by trapezius insertion was detached from the spine of the scapula, lateral third of the clavicle with the acromion fragment. The deltoid is then split longitudinally, as you can see in the, it's not there, is split longitudinally to expose the proximal humerus, followed by fixation of the acromion fragment to the trapezius on the anterolateral aspect of the humerus with one 6.5 mm cancellous screws, and with shoulder and keeping the shoulder in 80-degree abduction. The followed by the deltoid was sutured on top of the trapezius as proximally as possible with maximal tension. That is a Ruhmann's modification. Post-operatively, 8 weeks of immobilization of shoulder was done in 90-degree abduction, followed by 8 to 12 weeks of passive range of motion was started. Results: the patient had improved function with the decrease in shoulder instability. The gain in shoulder abduction was approximately 50 degrees. 10 degrees were before and 40 was gained by this procedure. The surgical time averaged to be 2 years, 2 hours. The mean blood loss was less than 200 ml and there were no post-operative complications. Conclusion: trapezius transfer can provide us satisfactory functional improvement for the paralysis of the shoulder as a secondary procedure in brachial plexus injury. Thank you.
What are the follow-up of the patient? How long did you follow up the patient?
So we follow up the patient for now is just 6 months, sir. We'll follow up for 2 years at least.
So 6 months, for how much function did you see, notice?
Yes, sir. So 50 degree is there, sir, as of 6 months.
Okay, all right. And you told that you fixed the trapezius to the anterolateral part of the humerus.
Yes, sir.
Why is it like that? Why not on the lateral part?
So the lateral parts, sir, then it will cause a external rotation of the humerus, sir, if we do it more laterally.
This is Dr. Nikhil Malela.
Good afternoon, everybody. I'm going to discuss about my topic on elbow flexion outcomes for brachial plexus injury between monofascicular and bifascicular oblique nerve transfer. Coming to the background, restoration of elbow flexion is a primary reconstructive goal in upper brachial plexus injury. As described by the man himself, the classic oblique transfer uses an ulnar nerve fascicle to reinnervate the nerve to biceps. Later modified by Dr. Susan McKinnon, Luvenox, between the years 2004 to 2006, adding a median nerve fascicle to the nerve to brachialis, potentially adding a second flexor, improving strength and speed. So our objectives in the study were to compare average duration required to attain MRC grade 3 elbow flexion, compare elbow flexion range of motion at 1 year follow-up. And we also wanted to describe the injury to surgery interval between the two technique groups. Our study group included 20 patients, average age of 27.6 years, monofascicular 10 patients, bifascicular 10 patients. The injury pattern was C5, C6, upper trunk injury. So our design was a retrospective comparative observational review. And we've taken into account the age, sex, diagnosis, operative procedure, the surgical technique, injury to surgery interval time, and MRC elbow flexion, active elbow range of motion at 1 year. Coming to the results, we've seen in our study cohort that the time to achieve M3 was 6.35 months in bifascicular and 7.10 months in monofascicular, which is not very significant with a p-value of 0.014. But the range of motion was 126.8 degrees in bifascicular, whereas 112.5 in monofascicular, with a p-value of 0.02, which was significant. The injury to survival surgery interval is not quite different in both the study groups, with an approximate of 6 months in both. So coming to the discussion on this topic, which has undergone a lot of debate in our literature, if really the bifascicular repair is beneficial and gives more strength. In our systemic reviews and in other comparative cohorts, we've seen that we know that the double fascicular repair gives more strength up to M4, but there's a catch. It shows that the lesser the surgical delay, the more the recovery is to M4. Literature shows that M3 elbow flexion after Oberlin type transfers generally falls between 4 to 6 months, with strength improving further up to 12 to 24 months. So all other series that we've seen with the power increasing up to M4 in most patients after double transfer techniques, where we've also seen contradictory studies on the same. So in mono and bi, the donor nerve ulnar and ulnar plus median in bi, muscle innervated is only biceps in mono and biceps plus brachialis in bi. Surgical time is shorter and donor site morbidity is lower is what is proposed, but whereas recent studies have shown that the donor site morbidity is similar and there's no difference in both the techniques, in the bifascicular technique as well. And concluding this topic, ours is a retrospective cohort with very few sample size. And our only observation which was significant was the range of motion, which we measured through a goniometer, which is subjective again. Recently, measuring muscle power using transducers can give out more objective data on such a study. So we'll be looking forward to it, but this is our study and these are our results. Thank you.
What was the donor morbidity that you had in this group of patients?
We've not had any donor morbidity, sir.
No donor morbidity.
No, sir.
And the evaluation was done at 1 year.
1 year follow-up range of motion,
Only
sir.
with goniometry to measure the range of motion.
Range of motion, yes, sir.
The strength of the motion was not assessed.
Not assessed, sir, yes.
The previous slide of this. See these two patients, what you have put, monofascicular and bifascicular. See, the monofascicular patient has such a bad wrist drop. So that itself indicates that this patient was a more extensive
brachial plexus injury.
So that more extensive plexus palsy, if you present compared to a good upper plexus palsy, the result is not going to be same.
Yes, sir.
No? So this is a very good thought process what you have, but it is, the answer is not there in literature because the patients are not comparable. So if you are doing, you have to do it only pure upper plexus palsy.
Controlled injury, yes.
And extended plexus palsy and compare.
Yes, sir.
Otherwise you will not get good result.
Yes, sir.
And when you are doing in upper, no difference comes. But when you are doing in extended plexus palsy, difference will come.
Difference between bi and monofascicular. Okay.
So the study has to be designed like that. So in a presentation, when you are putting, these two photos are too striking. It is not correct to put like that.
Okay, sir. Yes,
so they are not at all comparable. So if you say bifascicular transfer in these two patients itself, so much difference will be there. No? So we need to have the comparable cases to do a different type of operation.
Yes, sir. Okay.
What was the criteria to select the cases for monofascicular transfer? Because all the literature supports that bifascicular transfer gives better result in terms of strength as well as range of motion. So what was your criteria to include in this monofascicular group the cases?
Sir, if you look at the systemic reviews and literature, there is also contradictory evidence that bifascicular truly does not really improve the strength. Also, sir, not exactly, there are more studies on bifascicular being better, but there are also studies which show no significant difference between mono and bifascicular. So, there is a gray area there, and
because you are operating in the same area, and
we can get, yes, sir.
Yes, it is acceptable that it takes little longer time, but that's not significant.
Not a
the time
significant.
taken for bifascicular in comparison to monofascicular. So,
Yes, sir.
is it IC approved study? Not.
No, sir. Okay. With observational study, so we didn't, whatever has been done in our institute, we've just retrospectively compared it, sir. From 2024 to 2026, whatever patients we've done already, I've just compared, sir, between already operated patients.
Okay, thank you.
Thank you, everybody.
Next presenter is Dr. Kalyan Das.
Good afternoon, judges and the delegates. I am Dr. Kalyan Das. I am from Kolkata, the Institute of Postgraduate Medical Education and Research. I am going to share an epidemiological study which was done for a study period from September 2024 to March 2026. This is a study on 50 patients who presented to our OPD with features of brachial plexus palsy. And all the patients who presented and consented to be part of the study were taken up. So the sample size was 50, and we evaluated the patients clinically, as well as we did electrophysiological studies, and we did radiological studies like the MRIs. These are the key demographic patterns and the injury mechanisms. As we know that from Ganga Hospital in 2012, there was a study of about 300 patients, more than 300 patients. The road traffic accidents are the most important causes of brachial plexus injury. What we have found was a striking male to female ratio of presentation because of outdoor activities probably. And also we had two-wheeler accidents which were overwhelming in our series. And among the two-wheeler accidents, high-velocity traumas, which may lead to deceleration injuries, probably had an effect on the epidemiological data, because we got more supraclavicular and more higher injuries like the preganglionic injuries in our series of patients. There were associated injuries like in about, say, a decade back studies show lesser number of associated traumas, but as in the 2020s, we are getting more number of high velocity injuries, and so polytraumas like head injuries, like bony injuries, that is the neighboring bone injuries, as well as the distant bone injuries, thereby delaying the referrals, thereby delaying the treatment initiation in brachial plexus injuries. The vascular injury associated with with our cohort of patients was similar to all the other earlier studies, though in our institute, because of the referral bias, since in the eastern India, in our part of the state, we are a referral institute for brachial plexus, more number of severe injuries are presenting. So as we are increasing the number of patients, as number of patients presenting to our OPD are increasing, more striking vascular injuries associated are now found. So I would like to stress on the fact that more number of patients have preganglionic injuries in our series of 50 patients compared to the earlier studies. And the road traffic accidents, the two-wheeler accidents, the deceleration injuries, that may be one of the contributing factors. And the associated injuries like the like the skeletal fractures, that is the clavicle fractures, the scapular fracture, will have an effect on the treatment outcomes. In conclusion, I would like to say that more amount of epidemiological data has to emerge from all the institutes who are treating brachial plexus injuries, so that we can have index of brachial plexus injury patients in India from all parts of the country. Thank you.
So this you have taken only the adult brachial plexus injuries for the pediatric?
Yes, sir. Yes, sir. We excluded the birth brachial plexus palsy, only traumatic adult brachial plexus injury, and the age group was also more than 12 to...
Okay. And like just for information, what is the incidence of pediatric brachial plexus injuries in your setup?
Sir, birth brachial plexus injury is present to our OPDs, but I have not come across traumatic brachial plexus injury.
Yeah.
Only in a case of a sarcoma in the chest wall, we had an iatrogenic brachial plexus injury in a pediatric patient.
Okay. Thank you. Thank you.
Thank
Dr.
you.
Kalyan.
Thank you, everybody.
Thank you. Our next and last presenter is Dr. Devinder Kumar.
A very good afternoon to all. Myself, Dr. Devinder. I'll be presenting a poster on modified upper trapezius transfer using tensor fascial atta augmentation and suture anchor fixation for secondary shoulder reconstruction in traumatic brachial plexus injury. A little background first. Upper trapezius transfer is an established secondary procedure for shoulder reconstruction after traumatic brachial plexus injury. Conventional techniques may require acromial osteotomy and extensive soft tissue dissection. Our modification aimed to preserve the soft tissue while providing secure distal fixation. R is a retrospective case series in which 10 patients, they were included, operated from July 2025 to February 2026 with a follow-up of 6 to 12 months. All adult patients presenting late or with failed nerve transfer procedure, they were included. Coming on to the surgical technique, patient is kept in a lateral position. A skin incision is planned with the preservation of intervening skin bridge, as seen in the first picture. Upper trapezius is mobilized without acromial osteotomy, and a triple-folded, next the triple-folded TFL graft is harvested from the thigh and sutured to the mobilized trapezius. Then a limited separate deltoid incision is used, preserving the intervening skin bridge. The TFL graft that is passed through the tunnel toward the deltoid insertion site, and this graft is secured to the proximal humerus with a 5 mm anchor while keeping the arm in 90 degree of abduction. It is fixed in the anterior part of the proximal humerus. In post-operative period, the patient is kept in an aeroplane splint for 6 weeks. Then gradual adduction over the next 2 weeks, followed by range of motion and muscle strengthening exercises are initiated. Coming on to the results, the patients were in a mean age of 30 years. 9 patients were male and 1 was female. 8 patients had pan-brachial plexus injury. In these pan-brachial plexus injury patients, they had a completely flail upper limb, and no reconstructions were performed over the elbow and wrist. And 2 patients had upper or extended upper brachial plexus injury. The mean duration from injury to surgery was 31.6 months. The functional gain achieved was around 21.1 degree abduction, and forward flexion was around 10 degree. This was a mean gain. And there was an improvement in the VAS score from 4.8 to 3.5. And all the patients, they achieved a stable shoulder. There was absence of sulcus sign post-operatively. Coming on to the discussion part, the modest gains, motion gains in our series likely reflect predominance of completely flail upper limbs and early stage reconstruction. In the severe pan plexus injury, the immediate goal may be proximal shoulder stabilization rather than a larger arc of abduction. TFL augmentation and anchor fixation avoid the acromial osteotomy while providing a defined distal fixation point. Limited incision, preservation of the skin bridge, and minimal deltoid dissection makes the technique tissue preserving. However, larger studies with a longer follow-up, they are required to establish durability and functional outcome. Thank you.
Why did you prefer TFL augmentation compared to the other procedures?
Sir, initially we were using the original Saha's technique in our institute, but we had some patients with screw loosening. So we shifted on to the use of this TFL graft.
Any incidents of TFL breaking or anything in your series of patients?
Sir, in these patients, we didn't have any incidents of TFL loosening or breakage.
Okay.
That suture anchor is the place where TFL is attached.
Yes, sir.
Yeah. So you don't try to go more distal?
No, sir. We are placing it there only.
Thank you so much.
Thank you.
Thank you. With this, we come to the end of the e-poster competition. I would like to thank all our judges, Dr. Shrikant sir, Dr. Praveen sir, and Dr. Devi sir, for judging our competition. And the results will be announced in the valedictory part of the function. Now we will begin with the inaugural function shortly. Good afternoon, ladies and gentlemen. It gives me immense pleasure to welcome you all to the inaugural function of the workshop and CME on secondary procedures in brachial plexus injury, organized by the Department of Burns and Plastic Surgery, AIIMS, Bhubaneswar. Today, however, is more than just the beginning of an academic program. It is a milestone. As we gather here today, the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, celebrates 10 remarkable years of its journey, its decennium. A decade is built not merely through the numbers or milestones, but through the countless patients treated, residents trained, difficult cases undertaken, ideas exchanged, and lives changed. And perhaps there is no more appropriate way to celebrate these 10 years than by bringing together the science of reconstruction and the people for whom that science ultimately exists. Today, we are privileged to have with us distinguished surgeons, academicians, faculty members, residents, and delegates who have come together around one of the most challenging problems in reconstructive surgery. It is now my privilege to extend a very warm welcome to all our distinguished faculty members, delegates, residents, students who have joined us for this academic program. May I now invite to the dais our chief guest for today, Padma Shri, Professor Dr. Ashok Kumar Mahapatra, Founding Director of AIIMS Bhubaneswar. Okay. Our esteemed guest faculties, Dr. Praveen Bharadwaj sir from Ganga Hospital, Coimbatore. Dr. R. Shrikant sir from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Manaswini Mangaraj, Dean of Examinations and In Charge Director, AIIMS Bhubaneswar. Lieutenant Colonel Abhijit Sarkar sir, Deputy Director, Administration. Dr. Binayak Mishra sir, President APRASO. Dr. Sanjay Kumar Giri, Organizing Chairperson. Ladies and gentlemen, may we welcome our distinguished guests with a huge round of applause. Padma Shri Professor Dr. Ashok Kumar Mahapatra. Dr. Praveen Bharadwaj, sir. Dr. R. Shrikant. Dr. Manaswini Mangaraj. Lieutenant Colonel Abhijit Sarkar. Dr. Binayak Mishra. Dr. Sanjay Kumar Giri. Thank you. In a surgical conference, we often speak about techniques, procedures, outcomes, and innovations. But standing before us today is a reminder that behind every one of those words is a person who entrusted us with their care, a person who placed their confidence in our hands, and a person whose recovery gives meaning to everything that we do. As we celebrate 10 years of the Department of Burns and Plastic Surgery, we could think of no better way to acknowledge this journey than by celebrating some of our patients who have been a part of it. Today, we are honored to have with us a few of our successfully treated patients who have kindly joined us for the ceremonial lighting of the lamp. We are deeply grateful to each one of them for being here with us today. May I now request our patients to kindly come forward and join our distinguished dignitaries on the stage for the ceremonial lighting of the lamp. Barsha Das, Birsen Jain, Bhagyabati Behra, Manas Kumar Nayak, and Mohan Dolai.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य दिष्टे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you. It is now our privilege to felicitate our patients as a mark of our appreciation, not simply for being here today, but for being an important part of our department's journey. Their presence reminds us that the true measure of reconstructive surgery is ultimately not the operation we perform, but the life that the patient is able to return to afterwards. May I request Padma Shri Professor Dr. Ashok Mahapatra sir to kindly felicitate our patients. Barsha Das, our first honoree exemplifies extraordinary resilience in the wake of sudden tragedy. Following a severe traumatic amputation of her left forearm at home, Barsha was rushed to our department, where our surgical team immediately performed a complex emergency replantation. Navigating a grueling series of intricate procedures to reconstruct her limb and restore vital blood flow, she demonstrated unwavering courage every step of the way. Today, her remarkable recovery stands as a testament to the miraculous possibilities of modern microsurgery. Please welcome Barsha Das to the stage. Birsen Jain. True strength often shines brightest in the face of profound adversity. Birsen confronted a challenging oral tumor that required an extensive resection, including the removal of a portion of his jawbone. Undeterred, he underwent a cutting-edge microsurgical reconstruction where our team meticulously crafted a new jawbone using a customized bone and skin flap from his own leg. His remarkable recovery highlights both surgical innovation and personal fortitude. We are honored to invite Birsen Jain to the stage. Bhagyavati Behra, our next honoree, is the very definition of grace under pressure. Bhagyavati survived a harrowing ordeal when a sudden seizure resulted in severe facial and neck burns. Entrusting our burn center with her care, she underwent advanced staged reconstructive procedures utilizing artificial dermal substitutes and delicate skin grafting. Pushing through every clinical challenge with phenomenal strength, she achieved an outstanding 90% graft success rate and a beautiful recovery. Manas Kumar Nayak. Sometimes survival is nothing short of miraculous. Manas sustained devastating high-voltage electrical burn injury and a severe traumatic brain injury while working atop a railway coach. During a prolonged and intensively challenging stay in our intensive care unit, he battled through complex wounds and severe infections with awe-inspiring determination. And against all seemingly insurmountable odds, he walked out of our hospital as a true medical marvel. Mohan Dolai. Our final guest's journey is a masterclass in steadfast patience and perseverance. Following a severe road traffic accident that left him unable to use his right arm, Mohan embarked on a multi-year reconstructive journey for a complex brachial plexus injury. From a highly intricate free-functioning muscle transfer to restore his movement, to a subsequent wrist arthrodesis procedure to provide essential joint stability, he has approached every surgery with inspiring hope. His enduring spirits inspires our entire department. Thank you. A successful academic meeting begins with a vision. This two-day workshop has brought together an operative experience, a scientific discussion, and a practical approach to decision-making. It is therefore my privilege to invite the person who has envisioned and led this initiative. May I please invite Dr. Sanjay Kumar Giri, Organizing Chairperson and Head of the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, to deliver the welcome address.
Respected dignitaries, respected dignitaries in the dais, today's chief guest and founder director Padma Shri, none more than that, our very dearest to us, Ashok Mahapatra sir, director in charge, and also my teacher, Manaswini Mangaraj madam. Then with us, two doyen of the CME and the workshop, Dr. Praveen Bharadwaj sir and Dr. Srikant sir. Dr. Praveen Bharadwaj sir from Ganga Hospital, Dr. Srikant sir from Nizam's Hospital, and our APRASO President, Dr. Binayak Misra, and Deputy Director Administration, Lieutenant Colonel Avijit. And in the audiences, my teachers of general surgery as well as plastic surgery, and all my seniors and all the HODs of our AIIMS department, and all the distinguished delegates who has come long away from different parts of the country, all residents and all the nursing officers and all paramedical staffs, welcome to this day. Today is the day when we have started our department. That is, it is going to complete 10 years of our inception of this Department of Burns and Plastic Surgery, AIIMS Bhubaneswar. I have just, when I sat back, when I entered into this institute as alone, and I thought what to do by just passing just MCH and doing some walks in, I was just passed in SC Medical College, so I was doing their duty where it is all the sets are there. To come here and to start the department, I know sir was there. I think I was the last person in the department to join to start the department at that time. Sir was asking, where is the person? Till now this department has not started. All other departments have started, and why plastic surgery is not started? But due to plastic surgery, because I was working in the state government, required much more time to come here and join here in 22 August. And with me, I think Dr. Alok was there, who is sitting behind his, and he is one of my friend. So when we come here and I saw that nothing is there, and Dilip sir was also not here. Dilip sir was medical superintendent at that time. So we are very much afraid of sir, because sir is always told you to work. Then Dilip sir told you just see where to do, what to do. Then only you go to the sir with a vision. Then after 7 days, I think I have met with sir. In the 7 days, I asked what Dilip sir, what I will do. Now you do one thing, you have already general surgery OPD has started. You go and start there seeing the cases. So I have gone and started. Then I gone to Tushar sir. Dr. Tushar was when we were UG, he was PG at that time in SCV. So he knows me. So he told that you just start seeing the cases by sitting in the surgery OPD. So this was the way we have started. And after 7 days when I met sir, I don't think sir has remembered or not, sir told me how many CTAs you have done. Then I thought, sir, carpal tunnel syndrome. Sir, yes, sir, I will do, but I don't have any instrument, any equipment. No, nothing is there. Sir, where I will do, sir? Then sir told, nothing. You go and wherever what is there to start. So this was the vision of sir. Wherever you got and when you got, and you in your any time of your OT, if you are getting it, you just try to do that one. That was the type of inspiration from him we got at that time. Of course, we are not able, I think 3 months I have worked with him, sir, and after that sir has retired. Then after that the journey started, and it was little bit of difficult, of course, but to start a department and to start with all the equipments, instruments. But anyway, this 10 years has passed. In between, we have achieved something, we have tried a lot, we will also focus on all those things. So when we thought how to celebrate these 10 years, as usual, I thought we will do something, and by this we can celebrate these 10 years. So my vision is always remain to do some CME and workshops so that we can gain. We will also gain, our department will gain, as well as all other people also can gain. So what is thought that brachial plexus we have done just 2 years, 3 years back. My whole of the faculty and teammates have started 2 years back, and we saw that many of the results has come out, but the secondary procedures like whatever wrist orthodosis and trapezius transfers, all those things which are the real secondary procedures which will complete the treatment. And we saw in many of the cases we are little bit of behind, and we must know where to do, what to do. So I thought that we will do one day workshop, and the next day we will make the CME, so that we will have also knowledge, and we will also in that way we can celebrate the 10 years of our inception of our department. That was the basic thought by which we can celebrate our 10 years. And about the inception and department, a vision, a short documentary has been done, which Dr. Aparna will show. And I will say that although it was 10 years past, but all the departments of AIIMS Bhubaneswar have supported us in a very grand way, whatever required, anytime, anything required, from administration to starting to nursing officers, to all paramedicals. They have supported us, due to which we have traveled so much. And I hope in another decade we will definitely become one of the centers where patient care, research, and education will be taken priorities. And before that, I just want to two things to say to Dr. Praveen Bharadwaj sir and Srikant sir. In spite of their busy schedule, they have given 3 days from their time, and they have showed us, I think it's not inaugural today, yesterday we have seen 10 live cases of secondary brachial plexus procedure. So it was a huge applause to both these faculties because 10 procedures in one day. We started at 8 o'clock and finished at 6 o'clock, but we finished 10. I think it was already 5:30 and already 9 cases has finished. Then 1 case has left. Then Praveen sir was told, no, we will finish that one. Because 10 years, so 10 cases should be finished. So that way, we finished 10 cases tomorrow. And I'm thankful really, Praveen sir and Srikant sir, for showing us 10 cases yesterday. And today also we are in the midway of the CME. We gain a lot of things from them and hope all the delegates and all the participants who has come from a long distance definitely will gain something. And of course, many people have asked for the videos, YouTube transmission, we will send it. Of course, here we have 110 registered and out of 70 is offline and 30 people are in the online. So definitely this is going to give them better experiences and results will be known after these things. And from the Decennium celebration, the award Decennium is given by Dr. Amir, and he told that why 10 years we should light Decennium celebration. So it's a good thing from the department, and I hope we will do better in the next part. Thank you all. Thank you all these dignitaries in the dais for giving us the opportunity. Thank you.
Thank you, sir, for those warm words and for bringing together this enriching academic program. May I now invite Dr. Manaswini Mangaraj, Dean of Exam and Acting Director, AIIMS Bhubaneswar.
So very good afternoon. Our esteemed chief guest, Professor Dr. Ashok Kumar Mahapatra, Padma Shri, and our founder director, AIIMS Bhubaneswar, the current president of AIIMS Bhopal, as well as advisor of SOA University Bhubaneswar, our invited guest and Dr. Srikant and the resource persons, and Dr. Praveen Bharadwaj, our DDA Lieutenant Colonel Abhijit Sarkar, and the president of this association, and as well as the chairman of this committee, Dr. Sanjay Giri. Along with that, dear students, faculty, head of the department, and staffs of AIIMS Bhubaneswar. Department of Burn and Plastic Surgery, AIIMS Bhubaneswar, is proudly celebrating their successful completion of 10 years since inception. This is a remarkable decade of dedicated service, academic achievements, as well as excellence in patient care and research. It is a decade of healing touch, as well as hope. So it is not merely a time, rather, it is a testament of vision, resilience, tireless dedication, as well as countless lives they have touched. With collective symphony of effort, this department has provided pioneering care, integrating cutting-edge techniques, as well as saving lives, along with academic excellence. To honor and memorialize their milestone, This department has organized this event, Decennium 2026, a CME program, with a live workshop on secondary procedures in brachial plexus injury which was conducted yesterday. And both the CME and workshop, they have been nicely or meticulously as well as precisely, they are designed to bridge the gap between innovation as well as practice. So let us use this milestone as a springboard for the future and continue raising the bar of excellence. Being an institute of national importance, department is also to play a major role in providing state-of-the-art patient care and a research center for imparting training to faculties and students of different medical colleges of the state and to develop a center for excellence for born present treatment at AIIMS Bhubaneswar. Besides, a center for this microsurgery lab as well as the state-of-art, the skin banking center. So these are the expectations from this department. And I would like to extend my heartfelt appreciation and congratulations to the organizing chairperson as well as the entire organizing team for their tireless effort in putting this academic feast together. A special thanks to the guest speakers as well as the resource persons who have shared their invaluable expertise as well as clinical pearls with our students and delegates. So I wish this event resounding success and wish you all a deeply enriching day. Thank you once again for making me a part of this celebration.
Thank you, ma'am, for your encouraging words. May I invite Lieutenant Colonel Abhijit Sarkar, sir, Deputy Director, Administration, AIIMS Bhubaneswar.
A very warm good afternoon, ladies and gentlemen. Respected and honorable dignitaries on the dais, Padma Shri Professor Dr. Ashok Kumar Mahapatra, our founder director, as well as President AIIMS Bhopal, Professor Dr. Manaswini Mangaraj, the officiating executive director, Professor Dr. R. Shrikant from Nizams, Professor Dr. Praveen from Ganga Hospital, Professor Dr. Binayak Mishra, President APRASO, Professor Dr. Sanjay Kumar Giri, organizing chairperson, as well as the head of the Department of Burns and Plastics. Present honorable dignitaries who have come all across the state and the other parts of the country. Present respected head of the departments, eminent faculties, resident doctors, nursing administrators, nursing officers, officials and staff, experts, resource persons, and participants for this two-day workshop and CME on secondary procedures in brachial plexus injury. Firstly, I welcome you all to this two-day workshop and CME, which is being organized by the Department of Burns and Plastics, and also duly compliment the department for completing their 10 years of professional excellence in providing effective treatment, and also for their constant endeavors in organizing such academic excellence as well as educational workshops, wherein this is the most avid platform where there can be knowledge sharing, resource sharing, as well as it is the most viable platform for a lot of case studies to be deliberated and discussed. And of course, there would be a lot of lessons and takeaways for making it a more effective medical treatment as well as transformation in the field of medical sciences and research. Lastly, I sincerely thank once again Professor Dr. Sanjay Kumar Giri and his team from the Department of Burns and Plastic Surgery for organizing this successful workshop and also providing an avid platform for all the other participants to learn and also enrich their experience and professional journey. Thank you all. Thank you very much.
Thank you, sir. May I now invite Dr. Binayak Mishra, sir, President APRASO, for his address.
Good afternoon to all. Respected dignitaries in the dais and invited faculties and other delegates and other supporting staffs, nursing staffs and others. Today really it is my pleasure to be here. Being the president of the APRASO, I am part of this program. I have, since the inception of AIIMS, it was in the right hand of the departmental person like Dr. Giri, and with support from a able guidance person like Dr. Ashok Mahapatra, this department has grown to this height. Previously, it was having a one person, now it is having a lot of faculties and MCA students have grown to 30. So certainly growth is enormous in these 10 years, and the academic activity they are conducting in different parts, different faculties, like they have done microsurgical, they have shown bone and plastic, they have shown brachial plexus. In all the arenas of the plastic surgery, they are showing their excellency. And conducting such a live workshop, brachial plexus workshop by the experts from national and international repute is nothing less that Odisha can gain. So, inviting the distinguished brachial plexus surgeons like Dr. Praveen Bharadwaj from Ganga and Dr. Srikant from Nizams is really, we are fortunate to see their operation live. Because earlier we have to refer these sort of cases to go to Ganga, go to Nizams, like that. Previously, since peripheral surgery has grown a lot, now our persons have grown. We are also learning from different YouTubes and also from the experts and conducting these seminars. By conducting seminars and academic activity, we can at least guide and treat these brachial plexus surgeries in our state. So I think Dr. Giri has rightly guided the department to such a height. And nothing more to say. I again invite all the delegates for this welcome ceremony. And one more thing, we are recently also going to conduct one APRASOCon conference in January 27, where our topic is also, our theme is tendon transfers defying deficits. So that is somewhere related with this sort of tendon transfers. I invite all of you to, that will be conducted in our SAM hospital, SUA Campus 2 University auditorium. Hence, I invite you all to that conference. Thank you.
Thank you, sir. Some surgeons are known for the procedures they perform. A select few are remembered for the fields they help advance. It is a privilege to introduce one such distinguished surgeon and academician. Dr. R. Srikanth is a senior professor in the Department of Plastic and Reconstructive Surgery and Associate Dean for Research and Projects at Nizam's Institute of Medical Sciences, Hyderabad. He also serves as Associate Editor of the Indian Journal of Plastic Surgery. An alumnus of Calcutta Medical College and PGI Chandigarh, his pursuit of excellence in reconstructive and microsurgery has taken him to some of the foremost centers in the world, including Chang Guang Memorial Hospital in Taipei, Necker Hospital in Paris, and Policlinica Multimedica in Milan. His contribution to brachial plexus surgery in India has been particularly noteworthy. He served as president of the Brachial Plexus Surgery Group of India from 2021 to 2023 and was an Ethicon visiting professor in microsurgery in 2020 to 2021. His academic leadership extends beyond the operating room, with his having served as organizing secretary of APSICON 2006, ISRM 2010, and BrachialCon 2013. Beyond the operating room and academic pursuits, Dr. Srikanth has a keen and abiding interest in books and music. We are therefore privileged to have with us someone whose experience encompasses precisely this intersection of surgical innovation and academic leadership and reconstructive judgment. Sir, it is an honor to have you with us today. May I invite Dr. R. Srikanth to address the gathering.
I did not plan to speak, but there were a couple of things I wanted to say. From what I observed about Dr. Sanjay Giri in the past 2-3 days, trust me, he's going to go very, very far ahead and high up. Because I noticed it's not only the kind of work that you do, but the compassion. We had done a similar kind of a thing when we had some kind of an anniversary celebration. We called some patients. So no one, I think, told him. He did it of his own. It just shows that he's going to be a great leader. I need to thank him because I have been to my alma mater, Calcutta Medical College, as an examiner, as a speaker. I have been to PGI Chandigarh as a visiting professor also. But somehow I had this thought in my mind, at least once, someone should invite me to the apex medical institute in this country. Now I'm extremely happy that Dr. Sanjay called me, and I think I should be thankful to him more than him being thankful to me. Now I can die in peace. I can tell people that I went to All India Institute, and from what I understand, among the new institutes which AIIMS has generated, Bhubaneswar is the best. Before I go home, I'm going to go to the front gate. I saw a banner there which says, I love AIIMS Bhubaneswar. I want a photo there. I have always liked coming to Orissa for 3 reasons. One, the people are very warm and there's a wonderful sense of hospitality. One such person is Dr. Vibhuti Nayak sitting there, Dr. Subrajana also. Second, you have a lot to see in this state, which is still untouched by crowds. So I keep coming back, Gopalpur, you name it, Chilka, Puri. The third is, even though I had a long background in Bengal, I'm not a Bengali, I'm a Tamilian, my wife is a Bengali, but there is no beating the rasgulla that you get in Orissa. Luckily, he got it for me yesterday. I thank you all.
Sir, it is now my privilege to introduce another distinguished surgeon and academician whose career brings together orthopedics, hand surgery, microsurgery, and complex reconstruction. Dr. Praveen Bharadwaj is a consultant in hand and wrist surgery and reconstructive microsurgery at Ganga Hospital, Coimbatore. He holds MS and DNB in orthopedics, FNB in hand and microsurgery, and the European Diploma in hand surgery. His academic contribution is equally impressive, with 109 publications. He currently serves as Chief Editor of the Indian Society for Surgery of the Hand, Academic Cell, and as an editor for the Journal of Hand Surgery, Asia Pacific Volume. His expertise at the intersection of hand surgery, microsurgery, and reconstruction makes his perspective particularly valuable at today's workshop, where our focus is on translating reconstructive principles into meaningful functional outcomes. Sir, it's a privilege to have you with us. May I now invite Dr. Praveen Bharadwaj, sir, to kindly address the gathering.
Hi, thank you, madam, and thank you all of you. Giri is a very good friend from many years, and he has been telling me for quite some time that we should do some workshop here. Every time I do, tell him, okay, we will do surely, but we don't tell when we will do. But last time he caught me really, then I told one date. And in the busy schedule, I must say that they were sending me all the cases, but I hardly saw anything. But I was sure that this is the thing which we regularly do, so we will be able to manage. But 2 days back, I got really worried whether all things are there, because when plastic surgery department you are going, you may not have the things which orthopedic department requires. Just a simple screw may not be available, or screw is there but drill is not there. But drill is there but tap is not there, because everything I cannot think and tell. Because once you are working in an institute like Ganga, so we don't even ask like what to bring for the case. So all the things are there. If anything not there, we ask immediately, all the things are available. So just while traveling in the plane, all these thoughts were coming in my mind, and I got really worried whether everything will go fine or how it will happen. Then I saw all the messages, and then I kind of mentally prepared myself. I have done live surgery in at least 10 centers till now. But I should say this was the most easiest and the best. And it appeared so natural that you would have observed Ambarish was there with me. So I almost sometimes giving instruction to the sister in Tamil. So it became so natural that I was feeling as if I am operating in the Ganga hospital itself. And that was the reason it didn't feel like we did some 6-7 cases. It was looking like our routine list. Thank you so much for arranging it so well. Your team is really good. I think the 10 years is a good landmark. And in 20 years, you will be maybe 10 times more than this. Thank you so much. Thank you for inviting me. Thanks.
Thank you, sir. Some individuals contribute to an institution. A select few help shape its very foundations. And some leave behind not just a legacy of achievement, but a legacy of institutions, ideas, and generations of professionals they have inspired. It is therefore a matter of immense pride and privilege for us to welcome our chief guest, Padma Shri Professor Dr. Ashok Kumar Mahapatra, an eminent neurosurgeon and academician of national and international repute. Professor Mahapatra has led a distinguished career spanning more than 4 decades in clinical practice, teaching, research, and academic leadership. He served for many years at AIIMS New Delhi, including as professor and senior professor of neurosurgery, and subsequently served as director of SGPGI Lucknow. For all of us at AIIMS Bhubaneswar, however, his association has a particularly specific significance. He was the founding director of this institution, entrusted with the challenging task of building AIIMS Bhubaneswar during its formative years. His contributions to neurosurgery and academic medicine have been remarkable, including pioneering work in complex neurosurgical procedures and an extraordinary academic record spanning hundreds of publications and numerous books and chapters. His immense contribution to medicine has now been recognized at the national level, with the Padma Shri conferred upon him for his contribution to the field of medicine. It is particularly fitting that he joins us today as we celebrate the decennium of the Department of Burns and Plastic Surgery, a department that has itself grown and evolved alongside this young institution. Sir, your presence today makes this celebration truly special for all of us. On behalf of the Department of Burns and Plastic Surgery and AIIMS Bhubaneswar, it is my privilege and honor to invite our chief guest, Padma Shri Professor Dr. Ashok Kumar Mahapatra, to address the gathering.
Jai Jagannath. I think it's a wonderful experience to be here after 10 years or so. And I was thinking that how I studied brachial plexus. When I was in neurosurgery, that was junior resident in 78. So I assisted brachial plexus. But I was not sure I should go for neurosurgery or not. Because I had done pediatric surgery at AIIMS, and that was much more interesting because small children and variety of cases, all this. But then I thought, doing neurosurgery, we will have more perspective because everybody wants. People saw that every surgeon can operate pediatric surgery. It's only small. Today, 5 years doesn't look like that small. But neonatal surgery is really different. I do neonatal. Nowadays, I operate less than 6 months. But that is not the point. I did 6 months with Dr. Upadhyay, who lived 1 year in pediatric surgery. Then I shifted to neurosurgery because I was not sure pediatric surgery was good or that will not give a job. But anyway, why AIIMS was created? If you look at the Bohr committee report, it was 1942, Joseph Bohr was taken as a committee, and why should committee? What are the requirements of India? What type of medical college, what type of medical school, how many medical school, and then it could not be 1942 to 1956. Can you believe? It cannot start. So in 1956, they have AIIMS Delhi. Joseph Bohr had written there should be medical university, at least central medical university, to give training to the different people. So imagine that many things has gone wrong because of independence, that it was not many things. So I think he did a very good thing by advising AIIMS. Now we have 23 AIIMS. And when I went to minister and tell no more AIIMS, because by starting more AIIMS, you cannot do justice to humanity. Because you don't have that much of good quality people, then people come from outside, they don't have experience of, when I was doing 15,000, interview, we had 15,000 interview in 2012. And 13,000 came and several thousand on interview. I asked everything, what is AIIMS? What is AIIMS? A lot of people didn't know what is AIIMS, what is the meaning of AIIMS, why it was created. I was not asking any question. I said, what is the meaning of AIIMS and why it was studied? That was not possible. But anyway, I think today there are 23 AIIMS and all AIIMS. What is the problem with AIIMS? We still have 40% post vacant. Like IIT and IIM doesn't have reserve category. Because in quality of treatment, there is no reserve category. Whoever best should take them. Yesterday I was talking to somebody, he said, Mantri had told that they will do it, but then they thought they will not get put. So question is that if you have reserve category, I am telling good or bad. It's not reserve or unreserved. Good or bad. Because IIT doesn't take it, IIM doesn't take it, then why AIIMS? But then forget about that. Coming to the brachial plexus, my brachial plexus injury started 1978, and I had at least 30 cases when my resident. We were operating about 40-50 cases once a month. Not only brachial plexus, nerve injury, different type of nerve cases. But then I thought I have to go to pediatric surgery and do the case. So there is a person of medical MBBS, not MBBS, PG, he caught the hands in AIIMS. And that night I was struggling because I have to repair. That was 2022. I have to repair here and here. One may think putting two nerves, two sutures, glue is not difficult. But then when a medical student or a PG student of the same institute come at 8 o'clock, then it becomes much easier, difficult. That day, it was December, and my senior colleague, Dr. Mehta, who is doing it, were not there. So my point is that we should train enough people in the same institute who can do it. Because we are 4 faculty. I was doing pediatrics, Dr. Mehta was not, then few of Dr. Bhatia was doing vascular, and then Dr. HOD. I'm talking about before 2000. The question is that when you start a department, what you want to department? Today, I created a lot of faculty. When I was leaving institute, by that time I said 25 calculate. This is 5, everybody should be 5. Because in summer vacation we take leave. If you do not have enough faculty, you cannot have it. So I calculated 27. And 3 to 4 is the reserve category. I should have minimum 24 faculties. Now, if you go to AIIMS, we have more than that. Because trauma center itself has 10 faculty. So if you put the faculty as neurosurgery, it's about maybe 35. So the question is that, what is your planning? When I start planning the trauma center at Sanjay Gandhi, I had a little problem in Delhi Trauma Center, that's 100 beds. So I said it will 250 beds, which have good basement. And the basement will be having banks and lecture theatres, so that cannot be used and dumping around. So that if you go to Sanjay Gandhi, go to the basement. So question is that if the planning is not enough, execution is enough, then you will have problem. So I think I thank you and thank everybody here, mostly Dr. Giri and their colleague. Even I started here, I am not working anymore here, and I am working in, I have even 3 years BC also I finished. So at 75, you cannot do any good job, but I still work. I am the first person department and last person go. I reach the office at about 8:30 and leave at kuch bhi nahi hua, I can write a paper. So if you don't know how many people are writing paper, but I think in AIIMS, people should write paper. Because every day you are not either OPD or OT. Some days you are free from writing paper. So I wrote about 750 papers, 10 books. Not everything in brachial plexus injury, this injury, that injury. We have a book on brachial plexus injury. When I was getting SAMI, we have got Deborah, we are getting a lot of people abroad. So that is the reason, I think Dr. Sumit Sinha. Sumit Sinha was doing, that time he just passed MTS. I say, you take this one, all multiple international faculty, then when for multiple faculty, they wrote a book, Surgery for the Brachial Plexus. So I would write, I think Dr. Giri, all the papers published here, you should write a book. Otherwise, the people those who did not come, whatever reason, they should get benefit out of that. Because we are not here to teach the people, those are here. The AIIMS was created to teach the people at home. So if you have to write a book, tell everybody a date that, what is that, the ultimate date, so that you will give it, otherwise I can give this topic to my own colleague. If you do that, then I think that's good. Thank you very much. God bless you. Jai Jagannath.
Thank you, sir. A decade of healing, learning, and excellence deserves to be preserved as a memory. As the Department of Burns and Plastic Surgery celebrates 10 remarkable years, I invite Dr. Sanjay Kumar Giri, sir, Head of the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, to unveil the Decennium Souvenir, a tribute to the journey behind us, the people who shaped it, and the possibilities that lie ahead. I would also like to acknowledge the contribution of Dr. Ashutosh Adhikari, one of our MCH residents, and Mr. Devi Prasad Sahu for making this souvenir. उधर ही खड़े हो जाओ। Ladies and gentlemen, today's occasion carries the significance because it's our department's decennium. 10 years of burns and plastic surgery at AIIMS Bhubaneswar, those 10 years represent far more than just a passage of time. They represent everything from patients to residents to everything people have toiled for, and through their service, teaching, and innovations. The Decennium 2026 therefore gives us an opportunity not merely to look back at the last decade, but to acknowledge the foundations that have been laid for the decade ahead. May I now invite Dr. Aparna Kanungo ma'am to share with us the journey of the Department of Burns and Plastic Surgery at AIIMS Bhubaneswar.
And teachers and my dear colleagues, today is a very special and emotional day for all of us from the Department of Burns and Plastic as we celebrate the 10th anniversary of this department. For me, this day carries a meaning far beyond anniversary. I stand here not only as a faculty member, but as a proud alumnus of this department, having had the privilege of being its second MCH student. To return as a faculty to the very department where I was trained, learned, struggled, has a feeling of its own, which is far beyond what I can express. This has been a deeply emotional journey, and I bow before all the esteemed teachers who have molded my life. So a decade ago, AIIMS Bhubaneswar opened a department built not just to treat patients' wounds, and to restore lives. 10 years of this journey has been expendable. From a small founding team to a growing center of excellence, every scar told a story worth fighting for. Putting forth a small video highlighting the fond memories and the long associations, the people who are deeply rooted to this department. To everyone, thank you so much for being an integral part of this journey. 10 years and more as that we struggle for. Thank you. So I'm going to play a small video for all of us to enjoy.
scar has a story. Every reconstruction begins with hope. Every life restored is a shared achievement. A burn injury can change a life in moments. Reconstruction can restore not only a hand, a face, or a function, but confidence, dignity, and hope. At AIIMS Bhubaneswar, the Department of Burns and Plastic Surgery was created with this purpose: to heal, to restore, to teach, and to serve. On the 22nd of August 2016, the Department of Burns and Plastic Surgery at AIIMS Bhubaneswar became functional. What began as a new department carried a large responsibility to build specialized burn care, reconstructive services, and surgical training for Odisha and beyond. The early years were years of building clinical systems, patient pathways, operating room capability, and the foundations of specialized training. Services expanded. The OPD and minor OT became active. The MCH program began. The foundation for the Burn Center was laid. Partnerships such as Smile Train strengthened the department's ability to serve children and families needing reconstructive care. The department's journey was not without adversity. Cyclone Fani tested systems, infrastructure, and endurance. Soon after, the COVID-19 pandemic transformed every aspect of hospital care. Yet, even through uncertainty and disruption, the department did not lose its tempo. Clinical care continued, emergency needs were met, teams adapted, teaching evolved. The commitment remained unchanged. Patients with burns, trauma, deformity, and reconstructive needs could not wait for better circumstances. A defining aspiration of the department was the creation of a dedicated burn center. The foundation was laid in 2018. The Bhumi Pujan followed in March 2019, and the IPD was inaugurated later that year. On the 7th of January 2023, the Burn Center was formally inaugurated, transforming a long-held vision into a space of specialized care, recovery, rehabilitation, and renewed possibility. Rehabilitation, regrowth, reformed in a renewed way. Patient rehabilitation imagery with consent, otherwise show hands. Gait rehabilitation, splinting, vocational activity, or anonymized before-after illustrations. Screen text. The department's growth has been measured not only by infrastructure, but by the breadth of service it provides. From burn management and reconstruction to complex plastic surgical procedures, from teaching and research to outreach and awareness, every step has reflected a commitment to comprehensive care. In May 2025, the visit of the Honorable Union Health Minister, Shri J.P. Nadda, to the Burn Center marked an important moment of recognition. It reflected how far the department had traveled, from a new beginning to a recognized center of specialized service and aspiration. 10 years is not merely an anniversary, it is a responsibility to build further, teach better, innovate responsibly, and reach more lives. As we enter the next decade, the Department of Burns and Plastic Surgery at AIIMS Bhubaneswar renews its commitment to clinical excellence, compassionate care, high-quality training, meaningful research, and innovation that changes lives. From restoring form to restoring function to restoring hope, this is our legacy, and this is only the beginning. Viva as a team's celebrations never fade away, even on hectic, exhausting days. The ride is on, to more challenges, to more opportunities, to more skills and advanced care and learning. Seva, Sankalp, Samarpan, from healing hands to human hearts. A decade of restoring form, function, and hope, celebrating 10 years of burns and plastic surgery, AIIMS Bhubaneswar.
Another video.
Congratulations to all my faculty, residents, nursing officers, all the paramedical staffs in the Department of Burns and Plastic Surgery for 10 years, glorious 10 years, and making it successful in this institute. Thank you all for making us proud in our AIIMS Bhubaneswar. And my past or my future plan will be to make this center one center of excellence, to establish the skin bank, as well as to start the hand transplant unit and to have a microvascular lab in this part of the country for the residents.
Hi, I am Dr. Sunil Kumar Raut. I joined in the Department of Burns and Plastic Surgery AIIMS Bhubaneswar on 30th of December 2017 and continued for about 5 years and few months. That was the formative years when I joined as the second faculty in the department, and we contributed a lot to develop the department. We started
Hello everyone, I am Dr. Ritesh Panda, working as an Associate Professor in Department of Trauma and Emergency. After passing out my DNB Plastic Surgery from Sir Gangaram Hospital, New Delhi, I joined this department as a senior resident. At that time, Dr. Giri was working alone and building the department from scratch. We worked together and brought many laurels to the department. And I am very happy to see the department grow to such heights in a short span of 10 years.
Hi everybody, this is Dr. Ratnakar Singham Sethi, the first academic SR of Department of Plastic Surgery in Bhubaneswar. I am very delighted to wish the Department of Plastic Surgery in Bhubaneswar on the occasion of celebrating the 10th anniversary. I wish the department to prosper and more to reach heights of success. Thank you.
मुझे अकेले नहीं, सबको
सबको दिस इज अप्रूवल का पार्टी अप्रूवल तो आने दो।
अच्छा कब देगा?
आप बताओ कभी देंगे। आप कहाँ पे?
ताज को तो
ताज।
Hello everyone, this is Dr. Priyanka Pan. Currently I am working at PSP Hospital Haldwani in Uttarakhand, and being an alumnus of AIIMS Bhubaneswar has always been a matter of great pride for me. At AIIMS Bhubaneswar we have not only learned surgical training, but we have also received lifelong friendship, mentorship and experiences that have helped us in shaping our life.
Hello everyone, this is Dr. Vishnu Swarup Reddy, consultant plastic surgeon at AIG Hospitals, Hyderabad, proud alumnus of Burns and Plastic Surgery Department, AIIMS Bhubaneswar. On this special occasion of 10th year anniversary of the Department of Plastic Surgery, AIIMS Bhubaneswar, I would extend my gratitude to all the teachers, colleagues, and entire department of burns and plastic surgery in AIIMS Bhubaneshwar. I am deeply grateful to all my teachers, seniors, colleagues, friends, and the entire staff of burns and plastic surgery AIIMS Bhubaneswar.
Hi everyone, this is Dr. Akanksha Rajput. I am a practicing plastic surgeon in Father Muller's Medical College, Mangalore, Karnataka, and I have been a part of AIIMS Bhubaneswar since January 2022. It's a privilege to be a part of this 10th celebration anniversary of our department, AIIMS Bhubaneswar.
Hi everyone, this is Dr. Gopika Jit from Jan 2022 batch. Today, I'm able to serve and help my patients every single day because of the strong foundation I got from the Department of Burns and Plastic Surgery, Bhubaneswar.
I have been associated with this association for the last 10 years. I am blessed to have a...
Hi everybody, this is Lalita Moharana, ANS Department of Burns and Plastic Surgery. I am associated with this department since 2019. A beautiful journey, and we are celebrating 10 years of excellency. Wishing you all a happy, prosperous and beautiful journey ahead.
Thank you, my team, and all the departments of AIIMS Bhubaneswar.
Thank you, everyone. Now I'll give it to the Dr. Kirti to carry ahead.
Thank you, ma'am. Now I would like to invite Organizing Chairperson, Dr. Sanjay Kumar Giri, to felicitate a few senior teachers and faculty members.
So I will request Ashok sir, some of my teachers who were mentors of mine, I just want to felicitate on this occasion. Professor P.K. Devta sir, my teacher in the general surgery, and he has told what to do and what not to do, and I am really, now he is serving in the KIMS Bhubaneswar, but he has told me how to do the surgeries, so thank you sir for coming. Sir was the guide of my surgical journey, and I left 2 times plastic surgery. Then on the 3rd occasion, sir told, just take it, don't leave. So thank you, sir, for guiding and showing me the path.
I thanks Sanjay for inviting me for this auspicious occasion. From the beginning of the undergraduate as well as postgraduate, and Sanjay was working with us, including the residency. And from beginning, I see he is very sincere devotee and very organizational responsibility. A very critical situation he will manage so smoothly.
So it was a very difficult decision by Sanjay when he leave SCV Medical College, Plastic Surgery Department and PSC and join in AIIMS where a newborn child is there to nourish the newborn child and make him up to the 10 years of age. Now the child is of 10 years of age. I congratulate him. I wish him more and more success. I wish you all best. Thank you.
My two, Professor Narendranath Swai and Professor Ramakant Mahanti, who usually teach how to do surgery in emergency time in SCV. I'll never forget these roles. I thought this is the occasion I can felicitate them. Thank you, sir, for coming. Sir is now in Puri. Narendranath sir is in Puri Medical College and sir is in Keonjhar Medical College.
Thank you, Sanjay, for calling us on this day. And
Professor Narendranath Swai and myself, Professor R.K. Mahanti, are friends. And we are very much pleased to see our student, Professor Sanjay Giri. And Professor you are HOD now, Professor. So,
okay, thank you.
Sanjay.
So, we Department of Plastic Surgery from General Surgery to Plastic Surgery in SCB. Three of my teachers, Professor Chaudhary, Professor Vibhuti sir is sitting here, and Puthira sir, at that time, sir, both of them have taught me about the plastic surgery, and I think this is the opportunity to felicitate them. Of course, Chaudhary sir is not here, he is in UK, but he has given his good wishes. I will request Professor Vibhuti Naik sir to come to the stage, and I will be very much thankful for felicitating him. Professor Puthira Singh sir, now he is HOD of MKCG Medical College. At that time in SCV, he has also learned how to do all the basics of plastics. I am very much thankful sir has accepted the invitation and come to this workshop.
Thank you, Sanjay. It's a nice, beautiful and humble gesture. I think Sanjay is the fourth or fifth batch from SCV. Fourth batch. And as Devta sir has already told, he's always, when there is a problem, he's a problem solving man for us all the time. And many more events during his tenure at CV, because at that time I was assistant professor over there. So most of this time we have spent. I still remember mostly the posterior approach in brachial plexus surgery for restoration of shoulder abduction. He will be retracting and he will be sweating so much because that OT is, though you have got some two window AC, but it was probably not. So he was a very lot of strength and he will make your work not all, I think this thing make easy by retraction and all that. Similarly, as sir has already told, a problem solving man, when some issues comes in managing the patients and also the public, he's always there. And he has a lot of organizational skill from the very beginning we have seen. I think I have seen him from his 97 or 98 batch MBBS? 96 batch, yeah. So we are the welcoming batch for 95 batch, and when we are in internship, he joined. So I have seen him from those days, and he has been also the JDA and association president of JDA also, and a lot of organizational skill, and he is the right candidate for, I think, AIIMS. I think many more conferences and workshops we have attended because of him, otherwise used to go to outside. So thank you, Sanjay, keep it up, keep signing. God bless you. Thank you.
Just to conclude, some of our senior teachers like Dr. Subrat Jena sir and Dr. Ramesh Das sir, they are always there with us, so I will request to them to come to the stage and we'll. Some of the departments, all the departments have helped me for the last 10 days, but some of the departments, I cannot forget those days when they have actually helped to build my departments. So I would invite pediatric surgery HOD and department, Professor Manoj Mahanti to come to the desk. And general surgery HOD, Professor Tushar sir. Tushar sir is not there, I think they have a. Professor Prasant is there, urology, because we started the OPD, IPD, OT, everything sharing with him. He is always there to help at any time, what required, what not to required. Sometimes he has also given their theaters. We have also excelled their theaters, OPD, everything. So that makes us. I cannot forget the Department of Anesthesia because due to their so much of cooperation with us, we are able to do so much of cases. I think they are the people who give the longest time the anesthesia if we have used their department, and they have never given the complaint. So I have called their HOD. I didn't think, but Dr. Vikram, Dr. Alok, and Dr. Mitra. Dr. Alok, you come and take this on behalf of. HODs are in out of station. I think Sunil sir has sit here. He has a lot of contribution to our department, so I will invite him to just come and take a little bit of assistance, whatever we can give from our department to you.
I would like to say something. So, actually, it was a great experience working at AIIMS Bhubaneswar for more than 5 years. And I joined as second faculty after Sanjay. And we, both of us, along with Ritesh, I think he is there in the auditorium, we tried a lot to develop the department and started everything. And subsequently, Dr. Santanu and Dr. Mainak, Dr. Ranjit, everybody joined, and I am very happy to see the department at this stage, and very happy to see that with the leadership of Sanjay, the department has progressed so much. And I have all the best wishes for the department to march forward to a very great level. Thank you so much, Sanjay.
There are three representatives from AIIMS. I think I will request Snehajit from Nagpur and Navneet Sharma from AIIMS Bilaspur and Dr. Niraj from Rajkot. Please come to here. They have come from long way and they have accepted our invitation to join this occasion. I'm thankful to both three of you to come and accept and come. Professor Devi Mahapatra from JIPMER is there. He is the founder examiner for MCA student and he has also unveiled a lot of things to us and guided us how to grow this department, and sir has accepted the invitation and has come long way. Thank you, Devi bhai.
Thank you. Thank you. Thank you, sir. It is now time to felicitate our dignitaries. May I please request Dr. Sanjay Kumar Giri, sir, to kindly felicitate our chief guest, Padma Shri, Professor Dr. Ashok Kumar Mahapatra, ex-founding director of AIIMS Bhubaneswar. आगे आ जाइए। Dr. R. Shrikant, sir, Nizam's Institute of Medical Sciences, Hyderabad. Dr. Praveen Bharadwaj, sir, Ganga Hospital, Coimbatore. Dr. Manaswini Mangaraj, Dean of Examinations and Acting Executive Director, AIIMS Bhubaneswar. Lieutenant Colonel Abhijit Sarkar, Deputy Director, Administration, AIIMS Bhubaneswar. Dr. Binayak Mishra, sir, President Apraso. Now may I please request our chief guest, Padma Shri Dr. Ashok Kumar Mahapatra, sir, to kindly felicitate our organizing chairperson, Dr. S.K. Giri, sir. Thank you, sir. No academic program is the work of a single individual. It represents the collective effort of faculty, organizers, residents, operating room teams, anesthesia teams, nursing staff, and everyone working behind the scenes. Most importantly, our understanding of reconstruction is ultimately built upon experiences of the patients and with whom we have a privilege to treat. May I now invite Dr. R.K. Sahu sir to propose the vote of thanks.
Respectable distinguished member on the dais, my teachers, friends, colleagues, and delegates of the dais, from the Department of Bone and Plastic Surgery and the organizing committee, we are grateful to our director, sir, DD Hospital Administration, for giving the permission to conduct such type of event, to lead with a scientific program. Secondly, we are grateful for the presence of our founder director, ex-director of AIIMS Bhubaneswar, Padma Shri Professor Ashok Mahapatra sir. Your presence is always a grace, sir, like a sun for the world. Being the founder member of AIIMS Bhubaneswar and founder member of many societies of India, sir, you'll always throwing heartbeats in millions of hearts. Thank you, sir, for your presence and accepting our invitation. Today's 10-year celebration in the blueprint, we are thinking many things, but without a scientific program, it is not that fruitful. So the presence of Dr. Parveen Bharwaj sir from Ganga, Coimbatore, and Dr. R. Srikant from Nizam, Hyderabad, it's really a light awakening of brachial plexus, the rare surgery we are doing, for their time, for their energy. All have witnessed here in the last day, yesterday, and the bullet point of actions which will lead for the future brachial plastic surgeons. Thank you, sir, for your presence here. The most important, such a rare occasion of this conducting in the rare topic, secondary reconstruction of brachial plexus, we have delegates more than hundreds in offline and offline mode. So the presence of delegates, really the highlights of this, our 10-year celebration, because sometimes quantity matters. For your food, for your stay, for your any transport, anything problems happen, any suffering happen over here at Bhubaneswar, just little forgive us for our organizing team. Last 3 months, we are busy for this event. Dr. Giri, our residents, our departmental all staffs, for their effort, continuous effort, making this event very successful. Thank you, everyone. Lastly, the audio virtual team, the security persons, making it a disciplinary event. Thank you for your help. And my special thanks to my 2 faculties, Dr. Sunil Raut and Dr. Mainak is not here, but they are also part of this celebration, making this department in the early part. They have taken the burden, so many, many thanks for their presence. Thank you everyone for being present here, making the event grand success. Thank you on behalf of Department of Bone and Plastic Surgery and the organization team. Thank you.
Thank you, sir. With this, we come to an end of the inaugural function. I request everyone to join us for lunch, and we will resume. I request everyone to kindly stand up for the national anthem.
गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We have a short lunch, and by 3 o'clock we will again continue our CME. I think we are delayed in 1 hour, but we will have a half an hour of lunch. Thank you all of you and inviting for the lunch. And at 3 o'clock we will start our sessions.
We now resume the session post-lunch, and now I would like to invite Dr. Praveen Bharadwaj sir.
Sir.
For the video demonstration. Moderated by Dr. Lakshmi Kant and Dr. Ramesh Das sir. May I please invite them to the dais?
So what I will do now, I will take.
I request everyone to kindly be seated so that we can resume our post-lunch sessions. Since we would like to adhere to our timeline.
Now just, sir, we can start now.
Good afternoon, everyone. So I am not taking that video talk because yesterday we did the same operation and the video is only 5 minutes. We were operating for 1 hour. So and then I thought maybe there was a lot of people asking about the questions on when to do mod quad, when to do bony procedure. So it would be good to have the overall protocol or planning what we have for the children who are present with shoulder deformities. Shoulder in birth palsy, there are various ways of managing. So what I am telling is not like a real thing which is accepted world over. But this is what we have evolved over a period of last maybe around 15 years. And this is what we presently practice. And it also means that many times our previous fellows come and tell that, sir, 5 years back you told me this, now you are doing something else. So it is just like a evolution in progress. So we can change over a period of time, but these are the basic principles what we follow presently. So why this topic is so much essential? Birth palsy, though it is told that many of these children recover, but you would see that when you see these patients when they are grown up, none of them we can tell that they have not recovered. Even parents will tell everything started with 0 and now they are better. But they will still be so much deformed and quite disabled. Maximum problems are at the shoulder. They can be a combination of loss of abduction, loss of external rotation, sometimes loss of internal rotation, various scapular deformities. And shoulder deformity in birth children is quite disabling because for kids everything is at little bit height. So if they are not able to bring the hand up, they cannot go and pick up things. So they would really look quite disabled. So though the combinations are many, you can break them into these 4 categories. So this is the categorization which allows you to do or select a type of operation in different patients. So first category of the patient is one where there is limitation of only shoulder abduction, but the external rotation is present. Second is limitation of internal external rotation. Third, both limitation of abduction and external rotation. And fourth is limitation of internal rotation. We'll see each of them one by one. Now, this is the category which is quite common, limitation of shoulder abduction. So here the patients can be grouped into 2 categories. The A category where the deltoid is working. You can see over here nice contour of the deltoid. So deltoid is working, but when the child tries to do shoulder abduction, the adductors are very tight and contracting. So this is exactly like the child what we operated yesterday. So these patients are very much helped by this soft tissue release operation, similar to what was done yesterday, release of the adductors, transfer of latissimus dorsi to teres minor and the neurolysis of the axillary nerve. This gives quite a reliable and good result. Result is maintained over a period of time, which is quite an important thing because it is thought that many of the results may deteriorate with time. This child at 6 years follow-up, good amount of abduction maintained, and external rotation also has recovered with the tendon transfer itself. Another patient, 6 years age, 8 years age, and not only the abduction improves, by release of the anterior axillary fold, hand to back of the head reach also improves, which is quite important for girls, especially when they are grooming their hair. This procedure has worked well even for grown-up patients. This patient who was 17 years old, preoperatively having 90 degrees abduction and postoperatively improving to about 140 degrees. We published this series of 120 cases quite some time back, and there was a significant improvement in shoulder abduction in patients with postoperative abduction averaging about 161 degrees and increase in abduction of 76 degrees. So this is one of the main reliable operation what we have in our bucket. The problem becomes little more difficult if the deltoid is not working. So we saw the first category was where deltoid is working. So the problem is mainly because of the tight adductors. But if the deltoid is not working, then only adductor release will not work. So that's why the first thing to check is whether deltoid is working or not. If deltoid is not working, then these patients would require augmentation of the deltoid, which can be done by the trapezius to deltoid transfer. In children, we don't take the acromion. You have to do the soft tissue transfer itself. We don't use the fasciolata, take the trapezius with the periosteum and put it onto the humerus. And in children, surprisingly, it may give much good result because maybe the weight of the arm is less, or maybe other stabilizers of the shoulder are working. So you can expect almost about 90 degrees of shoulder abduction in some children. So another example, a child who is able to lift up 90 plus. So that is just because some stabilizer is working and you act add an mover, so you are likely to get a better result. Also, when you are doing the trapezius transfer in these patients, it is always good to check whether there are adductors which are tight. If they are tight, they can be released at same time. The next category is the patient where there is a limitation of external rotation. This is again a very important category, and maximum questions are asked in this category because very commonly people will get confused whether you do mod quad external rotation will improve, whether you do tendon transfer it will improve. Yesterday Soham was telling me that in CMC we always do the transfer of to the external rotators, to the infraspinators. So I think we need to understand the principles correctly, that not one procedure can be applied to everything. So here we need to divide the patient into two categories. One is where the passive external rotation is present. The second one is where the passive external rotation is not present. By the normal rules of tendon transfer, if the passive external rotation is not there, you should not do the tendon transfer. So any child who has a good passive external rotation possible, yes, we can do a tendon transfer, it will work very well. So this patient underwent latissimus dorsi to the humeral head or infraspinatus transfer, you can expect a good result. So this is the common Hofer operation and various modifications which all around the world are very famous. But they will not work if the passive external rotation is not there. And passive external rotation in a baby, when we are checking, we need to see whether the rotation is truly rotating at the shoulder or it is only the scapula which is lifting up. Many times when we forcibly turn like that, we feel that rotation is happening, but it is only that scapula which is getting elevated. For such patient, if you do a tendon transfer, you are only creating the elevation of scapula, which is going to be very problematic for the child because it will reduce the internal rotation at the shoulder. So we must make sure that the passive external rotation is present, then the patient is good one for doing a tendon transfer to the humeral head or infraspinatus where you can expect a good external rotation. But if the passive external rotation is not there, then those patients will not be helped, and these patients are the most complex category. So if they are very young, we can try to relocate the humeral head by doing release of the subscapularis. If the child is younger than 4 years, this release operation actually works quite well. You see the video here, after releasing, we can see the humeral head, how it pops and comes into the correct position. It was dislocated and now it is coming inside the joint. But this will work only when you are doing surgery much earlier age. And the humeral head should not be much deformed. If you have seen them early, this kind of operation, and you will get a result like this, you get an improvement in trumpet sign, you get the improvement in the position of the hand. So it is quite an effective one, but the child should be young and the glenoid shape should be good. On MRI or CT scan, we should make sure that the child does not have too much of retroversion of the glenoid, too much of deformation of the humeral head. If it is not, then the procedure will work well. And you can get this kind of result where the child will have a dramatic improvement in the posture and the external rotation. However, most of the children, when they present to us, they will be having deformation of the glenoid. If deformation of the glenoid has happened, then restoration of the joint congruity will not work. Then we need to go for external rotation osteotomy at the humerus like this. This is also a very good operation and immediately will improve the main problem which patients come for, that is the trumpet sign. Especially when it is on the right hand, the parents are very concerned that every time child eats, it looks very odd. So this sign will immediately get corrected when you do an external rotation osteotomy. This is a very effective operation, very safe operation. Though to an orthopedic mind and heart, it does not sink inside because every time you will feel as if like you have not corrected the joint anatomy. But long-term studies have shown that these children develop something like a pseudoglenoid, and that pseudoglenoid in a non-weight bearing joint like shoulder is enough, and they will not develop any arthritis. So you can very comfortably go and do an external rotation osteotomy to get a wonderful result like this. Now coming to the third and more complex category where there is limitation of both abduction and external rotation. So these patients, if they are young, we can do correction of both at the same time. However, most of the times these patients to be dealt at two stages. First stage, we will do a soft tissue release to improve the shoulder abduction. And second stage, do an external rotation osteotomy. After 2 stages, you will have a result like this, where the abduction is better and the external rotation also is restored. The child which we operated yesterday, I think the next stage when the child turns around 5 years, we will require an external rotation osteotomy. Then the last and the least common of all the deformities, that is a limitation of internal rotation. Not much is talked about it because the child overall the posture will look normal, so that's why not many parents come for complaint. But sometimes children will have a very unique complaint that they are not able to put on their dress properly because the hand does not go inside. Especially girls, they are not able to put on their undergarments, put on their slacks. So this girl was very keen that she should be able to reach and touch the tummy area so that she can dress herself comfortably. So we did an internal rotation osteotomy, just the opposite of what we do commonly. So you can turn the hand about 40 degrees inside and it immediately allows the child to reach to the belt area to put on their clothes comfortably. And this is the video we asked her to, this girl used to send, I tell I am very comfortable. And we told, okay, you send the video. See, she has sent a video of a tightest of the jeans she has. She is really finding it so much difficult to put, but even then she is able to manage it. So this makes the patient actually more independent and more comfortable in managing themselves independently. So to summarize, this is the general plan what you can have. This kind of fragments and makes the decision making very easy because many times the children will look very confusing. So you can just break them down, limitation of abduction, external rotation or internal rotation or a combined one. And then depending on the age, depending on the anatomy of the shoulder, we can decide whether you can do a single stage correction or a 2-stage correction. Thank you so much. Happy to take any questions. Any questions?
Any question from the floor?
Sir. Sir. Yes, sir. Sir, this one actually while operating yesterday also we were having discussion on that. We sometimes thought that it will not make any difference and whether we do without axillary nerve and see. But it looked like it is not worth it because axillary nerve is just there near to the structures what we are dividing. And then on repeated observation and the experience of various other papers, there is a nice thing what happens in the biomechanics of this deformity is whenever we do an abduction of the child, if you put hand there, you would see that the humeral head is subluxing inferiorly. And that typically happens in children with birth palsy because their subscapularis is tight. So when child is doing abduction, it cannot go anteriorly, it goes inferiorly. So we would see that when we are doing an external rotation in this position, it is very limited. But when you do in abduction, it is very easy. That is just because that humeral head is subluxing inferiorly. So this inferiorly subluxing humeral head is kind of crushing that axillary nerve against the tendon of the triceps and the teres major. So it is a position dependent axillary neuropathy. So I don't know whether there is any way of proving that, but it looks like it is logical and that's why we continue to do that.
One question.
Yes, sir.
Site of osteotomy.
Sir, site of osteotomy can be above the deltoid level, below the deltoid, or the lower humerus, or the medial. 4 approaches are described. But if we do above the deltoid insertion, it is better, because there we can do a little bit of varus angulation which corrects the scapular deformity. So we always do proximal to the deltoid insertion.
Yeah, any question?
Sorry? Subscapulary slide, yeah. So subscapulary slide is good for children who are less than 3 years of age. So in that, clinically we check. So suppose the patient looks like having some tightness on the anterior side where you want to release the coracohumeral ligament, we'll go from the anterior side. Suppose the patient is not looking like coracohumeral tightness is there, then we do from the scapula from the posterior approach. So that is one. Second thing, if you want to combine it with tendon transfer, then I like to do from the back side subscapulary slide and transfer of the lower trapezius for external rotation. So that is the usual combination.
Thank you.
Thank you. Sir. Yes, sir. Thank you, sir.
Sir, your next topic is there, no? Presentation. In construction.
Yes, sir.
कहाँ है? No, I won't do that.
Cooperative session was
I'm just making a couple of changes because we had the triceps to biceps case yesterday. I'm not going to show it. Instead, I have a video in which we have done a transfer of levator scapulae for shoulder abduction and a latissimus dorsi for external rotation. Just to make you understand that video better, the video comes with its own voiceover. It's about 7 or 8 minutes. But I thought I'll give an introductory talk on this and then we go on to the video. Yeah. So, we published this sometime in 2021, but I really cannot claim any originality. When I go back in the literature, I find that it had been described by Dr. Narakas way back. And I was fortunate to attend a meeting in Pune in which Dr. Alex Muset-Lara, who is basically a surgeon who deals with children's problems, he hinted at that. He made a diagram that showed the levator scapulae, and so I got back and thought, let's see what we can do about it. So the levator scapulae is a muscle that arises from the first 4 cervical vertebrae, and it gains an insertion along the medial border of the superolateral corner of the scapula. Now, when you want to do something for the shoulder, you need to understand the vectors. One is abduction, the other is external rotation. Now, when you are using the upper mid trapezius, there is something pulling from above. So it's very natural to assume that it's going to act as an abductor of the shoulder. If you have something from the horizontal vector, like the mid trapezius has also been described for shoulder abduction, that is still reasonable. But if you are going to get a muscle which is going to pull in this direction, like when you do an LD transfer for shoulder abduction, it doesn't seem very logical. Or for that matter, if you have got the lower trapezius and you want to use it for shoulder abduction, it doesn't seem very logical. So ideally, the vector for shoulder abduction should come from above. That is what my simple mind tried to grasp. And secondly, LD as a donor for shoulder abduction has been done for a long time in OBPI. But even literature says that if you do it at the age of 4 or 5, it seems to work as an abductor. But over a period of time, maybe when the child is 14, 15, they put on some weight. Then there is an attrition in the value of shoulder abduction. That is because when you transfer the LD, it is basically a class 3 lever. A class 3 lever is pretty inefficient. So I just shown the diagram that if you have a muscle that is running from top to bottom like this, and you are going to put it there, it is going to pull upwards. That's the correct vector for shoulder abduction. Unfortunately, that levator scapulae muscle gets an insertion here, and that length obviously is not enough to reach, say, the supraspinatus. So the trick in the game is to get a prolongation of the levator scapulae so that without using a graft, you can always add a graft, nothing like that. So then what you do is you take the periosteum along the medial border of the scapula in continuity with the levator scapulae. Now when I say periosteum, if I'm truthful, I'll say there are a few fibers of the rhomboideus major with it. You just can't, take the periosteum as a single layer. But you see, you get a sufficient length of that muscle and tendon extension. And it would be a simple matter to tunnel it under the trapezius and take it where you want, that is the supraspinatus insertion. Right. Seems very smart. But then again, I come back to that original question, what I know and what I don't know. It ideally simulates the supraspinatus. So that implies that some innervation of the deltoid should be present for it to work. A patient who has a lower BMI is a preferable candidate if you want to do this transfer, and it is ideal in pediatric patients. On the other side of the coin, what I don't know is you cannot predictably test it preoperatively. So unless you know the muscle is there or not, how are you going to use it in a transfer? That is a problem. Though textbooks describe dorsal scapular nerve as the primary nerve supply, anatomical textbooks mention that it gets branches from the cervical plexus motor branches, which is usually proximal to the C5 and is not implicated in a brachial plexus injury. It would be easy for me to assume that I am doing something great by transferring it as a shoulder abductor. But what it really may be doing is it just builds upon the rotator cuff so that the existing muscles are actually working and it is not truly the levator scapulae. But I couldn't care. If it does the job, why not use it? So, does it work directly or by increasing rotator cuff stability is another unanswered question. And the last is whether it is expendable or not. So having said this, I'll just run you through an 8-minute video. I only, sort of assisted the surgeon and did the videography. कहाँ है? ये नहीं, ये audio है ना इसका?
This video demonstrates tendon transfers.
You have to get the audio on.
In a child.
इसका audio on. दोबारा start करो.
With birth brachial plexus palsy. The objective is to restore two important
Let me start it again. You have to give credit where credit is due. She is my junior colleague.
Demonstrates tendon transfers for restoration of active shoulder function in a child with birth brachial plexus palsy. The objective is to restore two important components of shoulder function: abduction through levator scapulae to supraspinatus and external rotation through latissimus dorsi to infraspinatus transfer. The child is placed in lateral position. The medial border, angle, spine, and acromion of scapula are marked. Vertical incisions, as shown, are marked for the harvest of donor tendons and for the exposure of the recipient tendons. The incisions are infiltrated with adrenaline saline solution. The procedure begins with the harvest of levator scapulae. Via the medial parascapular incision, lateral border of lower trapezius is identified and is reflected. 1 to 2 centimeters of its insertion into the spine of scapula is divided. Then the muzzle is retracted superomedially to reveal the rhomboids and levator scapulae inserting onto the medial border of scapula inferior and superior to the spine of scapula, respectively. Levator scapulae is defined in this region and its stimulation is confirmed. For this reason, anesthesia with no muzzle relaxant is preferred. The levator scapular muscle is freed from the surrounding muscles, supraspinatus laterally and the rhomboids inferiorly.
So that is a muscle
As
which
the
is being
insertion of levator is short and it practically has no tendon, a 1 to 1.5 centimeter wide strip of periosteum along the medial border of scapula is harvested along with the insertion, stopping just short of the angle of scapula. This periosteal extension gives us sufficient length to reach the supraspinatus tendon at its insertion. About 5 millimeters of attachment of rhomboids and infraspinatus muscles along the medial border of scapula need to be reflected off to harvest the periosteal strip. The periosteum is incised and elevated with a periosteal elevator. The periosteal harvest needs to be very careful to avoid narrowing. This can happen at the region of the spine of scapula. The periosteal extension here can slip off while transferring. In case of such a mishap, a facial ladder graft can be used for the extension of levator tendon. The reflected attachments of rhomboids and infraspinatus muscles are sutured back to the medial border of scapula. The levator scapular tendon, along with its periosteal extension, is reinforced with a whip stitch using 3-0-proline.
just use a running 3-0-proline to strengthen that musculo-tendinous junction and the periosteal extension.
Now we proceed with the harvest of latissimus dorsi muscle per transfer. The lateral border of LD is identified and the muscle is released from the surrounding fascia and muscles, preserving its origin and neurovascular pedicle, maximizing its excursion for transfer. Its tendon is separated from that of teres major and the insertion is divided as distally as possible to obtain
One thing to beware when you cut this high up, because you're always greedy for length of the LD tendon, the radial nerve is very close by.
Is confirmed. The LD tendon is tubed using 3-0-proline so that it can pass freely through the tunnel. We now proceed with the isolation of recipient tendons through the incision at the acromion. The deltoid origin from acromion process is divided and retracted, and subacromial bursae is incised to identify the supraspinatus and infraspinatus tendon, seen here separated by a groove. The tendons are dissected and space is made for the transverse. The reach of the levator scapula and the periosteal extension and latissimus dorsi are confirmed once again, and a subtrapezius tunnel is made to retrieve the levator scapular tendon. A subdeltoid subcutaneous tunnel is made to retrieve the latissimus dorsi tendon. Once the donor tendons are retrieved, the incisions on the back are closed over drains after meticulous hemostasis. The harvested donor tendons are now sutured to the recipients. The LD to infraspinatus transfer is done first. The LD tendon is grouped around the infraspinatus tendon and is sutured with 2O-proline, keeping the limb in 90-degree abduction and external rotation. The levator scapulae is now transferred to supraspinatus tendon by looping its periosteal extension around the supraspinatus tendon once or twice and anchoring it with 2O-proline, keeping the arm in 90-degree abduction. The deltoid origin from the acromion process, which was divided earlier, is now sutured back using proline. The skin is closed in layers after thorough hemostasis. The upper limb is immobilized in 90-degree abduction and external rotation, usually in a custom splint for 3 months, with gradual physiotherapy starting from 6 weeks. The splint is changed to night-only splint for the next 3 months. Thank you.
So, we are done.
This video demonstrates tendon transfers for restoration.
Not again. How do you come out? Yeah, I'm done. I think that's okay for this session. So, there are always questions. How can you take a tiny muscle and expect to get a shoulder abduction against gravity? Even I have that question, and I strictly dissuade you from doing this procedure in patients who are pan-plexus injury. I have seen it being done. Believe me, it's not going to work. Like Praveen said earlier, sometimes it is that there is some kind of a muscle activity going on in the rotator cuff. Those are the patients you try, and you can try it as an alternative to existing procedures and secondary corrections of OBPI, but I think it's worth giving this a try since it's been described a long time back, and maybe it just fell into disfavor for whatever reason. Thank you.
Thank you, sir. Thank you for your presentation.
So I don't have to do anything, I'll just come back and do the FF.
Any questions from the floor?
I now invite Dr. Prarameen Bharadwaj sir for his talk on considerations in treating the forearm and hand in birth brachial plexus palsy.
So from the shoulder, now we move on to the forearm, which again is quite a common operation what we will require to do once you start doing the secondary procedures in birth brachial plexus palsy. Now in forearm, you can have a supination deformity or you can have a pronation deformity. The terminology can sometimes be confusing. The supination deformity, there is a limitation of pronation because the hand is in supinated position, and pronation deformity, there is a limitation of supination. So you can actually tell it either way. So in this patient, we can tell that the problem is limitation of pronation. Child does not have pronation, but it is called supination deformity. So somewhere some terminology difference may be there. So, but the basic problem is that hand is all the time in supinated position. Child is not able to turn the hand inside. And in pronation deformity, child is not able to supinate. So both of these deformities, often parents will come and ask for correction. The children would have supination deformity, parents will feel like child is not able to do down, and the down people will say the child is not able to eat. So eating is a big problem if full supination is not there, because that is the movement which requires complete supination and putting the food into the mouth. Especially when you are in the southern part of India, where eating with hand is an important tradition. So when you see a child with these deformities, there are many things which crop in your mind. If you come across these patients and you want to have a detailed assessment, what to be done, when to be done, this is one article which we have written in the Journal of Hand Surgery. It has all the information about what complaints patients will have, what are the various treatment considerations when you treat these children. And these deformities are actually quite common. So continuous consecutive 100 patients, we just in the OPD, okay, all next 100 patients we will examine and see how much pronation, supination they have. Surprisingly, only 17 children with birth palsy had a almost complete range of pronation and supination. So that means 83% of children would have limitation of forearm rotation, and maximum would be limitation of pronation. So they have a supination deformity. In this paper, we had 111 patients which we have treated the supination contracture, and only 18 patients treated for pronation contracture. So why this difference is there, you would know by seeing this picture. You see this patient has a supination deformity at the forearm. This typically happens in children who have a very global involvement, more severe involvement in the brachial plexus. So obviously these patients have more deformity and they have a less function. So these patients are more likely to come to the hospital, number one. Second thing is, the supination deformity looks very odd. You see immediately the hand looks like that. It is very bad terminologies which have been given for this, called as a beggar's hand. You know, the hand is all the time like that. And if it is in the right hand, a child cannot go and shake the hand. It is called as an unshakable hand. So these two problems, that child is looking very odd, child is not able to even give a handshake, is the one which bring the patients more often to the hospital. And also that's why these are 5 times more common than requiring operation for the pronation deformity. Functionally, what problem it will cause? You see a child here when having a supination deformity, because the hand is fixed like that, if he has to pick up a small thing from the table, he is turning his full body up, down and try to lift, just because the hand is not turning down. So it is quite a disabling deformity. And for a simple task like this, he has to work so hard to try to pick up a small object. They will not even able to turn a page because the hand is not going into pronation. So it looks like very strange, but yeah, these are the very bad problems they will have. And because the hand is supinated and extended, the hand does not reach to the mouth either. So that way the supination deformity is more disabling, and that is the reason why more patients will come to the hospital. As contrast to this, the pronation deformity on appearance looks decent. This boy, if comes to the outpatient, you will not know whether any deformity is there. Similarly, when he goes in the public, he is not identified as a person having a disability. So that is the reason why many of the patients don't come to the hospital for treatment. Also, pronation deformity is more suitable for doing normal function, our desktop activities. So if it is in the left hand, patients would never report to us for surgery, and they will be comfortable in all their day-to-day function. However, if they are having involvement on the right hand, they will have difficulty in reaching to the mouth because supination cannot be compensated at the shoulder because trunk interferes. So that's why many of the patients would come if they want to desire to eat with the right hand. Now, when supination deformity we have, our main aim is to correct the posture of the hand so that the hand improves in the overall appearance and also to improve the tabletop activities. That is an important word to remember. So, pronated position improves your tabletop activities. One thing which patients should understand is it will decrease the supination, but tabletop activities will surely become better. And when you are doing operation for a pronation deformity, our main aim is that child should be able to reach to the mouth and be able to eat. Now, having this in mind, now let us see what are the treatment options we have for these children. So when you have a child with the supination deformity, that is you want to improve the pronation, when you see such a child, there are three things we need to check. First is whether the deformity is passively correctable or no, because you want to know whether tendon transfer is possible. You want to check whether the wrist extension is there and the triceps power you need to check. Now, why wrist extension is important is because if the child has good wrist extension, then you can do a pronation posture in them and they will feel better. But imagine a child who does not have wrist extension. If you do a pronation deformity in that child, he will develop a wrist drop. And dropped wrist looks worse than this. So that's why we must make sure that that wrist extension is there before we correct the supination deformity. The third thing, we check for the triceps power, because one of the common operation tendon transfer to correct the supination deformity is rerouting of the biceps. We know that the biceps is a strong supinator. You reroute the biceps around the radius to make it a pronator force. But that can be done only when the triceps is good power. So you check for the triceps power. If the triceps power is good, we can consider the patient for biceps rerouting. So this is the overall treatment plan. So you check whether the patient has got a passively correctable deformity. This group will be suitable for tendon transfer. We have two options available. If triceps is functioning good, we do the biceps rerouting. If triceps is weak, then you do the brachioradialis rerouting, which I will tell how it works. But if the deformity is fixed, then we cannot do a tendon transfer and then we go for a bony procedure like a radius pronation osteotomy. This is the situation 1 in which the patient has a passively correctable deformity, wrist extension is there and triceps is of good power. You take the biceps, turn it around the radius in such a way that it starts acting like a pronator now. So you can see his child has got a good amount of pronation now and we have changed from that position to this position. Once pronation comes, children start having a better tabletop activities. In this patient where the triceps was weak, we can take the brachioradialis and divide and reroute it around the radius in such a way that it starts acting like a pronator. This is not a very strong transfer, so has to be done only when the forearm is very supple. But in a well-selected patient, you can get about decent amount of pronated posture of the hand. However, with all the physiotherapy efforts, whatever you do, these deformities very commonly become fixed. In fact, out of 10 patients, 7 patients at presentation itself will have a stiff forearm. So the most common operation what we would require to do is a pronation osteotomy of the radius. It is quite a simple operation where you just cut the radius and turn it around and fix in that pronated position. If you are turning about 100 degrees, only radius osteotomy is sufficient. But if you require anything rotation more than 100, we will require to do an osteotomy of ulna as well. This is a nice operation and dramatically changes the posture of the hand. Immediately the child starts looking better. And that is the main advantage. And it also improves the overall tabletop function of the hand. See the child here, very odd, going in supination posture and lifting things. And once the hand goes into pronation, it looks like it is ready to pick up anything. So it improves the appearance and it improves the tabletop activities, and that is the main important thing what we are doing this operation for. So once the child starts picking up things very comfortably from the table, the function improves, they are able to go to the center of the body also much comfortably, and they are quite happy with this operation. Osteotomy obviously only turns the arc, but tendon transfers can give active rotation. So our first choice should be a tendon transfer, but if the deformity is fixed, then we have no choice other than go to the osteotomy. But all the time, not even once, at least 5 times we should tell to the parents, especially when we are doing an osteotomy, that this child will not be able to do supination after the operation. Because in our Indian culture, eating with right hand is one thing which all the parents want. And once they start using the hand for better tabletop activities, then their expectations also will improve. Then why he cannot eat now? But you have turned the hand in pronation, now he can never eat. So that's why pronation osteotomy should be done only for the hand where you have decided that this hand is not going to be used for eating. The second thing, many parents would say that child going to the temple not able to take the offering. So these 2 things have to be told to the parents first itself. In fact, one father after the surgery was telling that previously child was able to do, now not able to do. But the appearance of the hand and improvement in tabletop activities is so nice that over a period of time they will feel that their decision to get the operation done was much nicer. And this is what they are asking just for the sake of making sure that whether there is any other option. So this is really a good operation and patient satisfaction is immense. Now coming to the correction of the pronation deformity, that is like improvement of supination. So here again, if it is a passively correctable deformity, you do a tendon transfer. If it is not passively correctable, you do an osteotomy. Sometimes if it is just a firm deformity, you can still do a interosseous membrane release and improve the range and then make this patient suitable for doing tendon transfer. So why I am telling this more to go for tendon transfer is because when child has a limitation of supination, it is not like a cosmetic deformity, it's just like a functional deformity. So if you do a supination osteotomy and child does not have pronation actively, then the child will have a very visible deformity in the hand, which parents will really not like. So we should avoid doing an osteotomy in children with pronation deformity and try to go for tendon transfer. The best transfer is FCU transfer to brachioradialis. It works really well and will give a very nice robust supination. So this operation very good for right hand because the child, if they want to eat, we can do it for that hand. And this child actually is on the left hand, but right hand, it is really very useful, will make the patients very happy and the parents also very happy. Now this child is a very unique child where this was the only patient where we have done supination transfer on the left hand. Because left hand full supination is actually not required. Neither you are going to temple and take the offering, nor you are going to eat with that hand. So this patient very keen on dancing. So when she dances, she is not able to do this mudra, and that's why the mummy wants the operation to be done. So this mummy is one very unique, I remember her all the time. So normally when you don't want to do operation, the last thing you will say is, if it is my daughter, I will not operate. So when I told her, if this is my daughter, I will not operate, she is very quietly telling, but this is not your daughter, this is my daughter. I want operation. So then this child we did, and they were very happy because this is what they wanted. And other option is to do a pronate teres rerouting. This also is decent operation, but works only when you have a good passive range of movement and will make the parents quite happy. Forearm deformities really, I feel, as I told in this example, is a real patient demand operation. So we need to really know everything about what thing can happen, what negative effect will be there, so that we can put a clear picture in their mind. So this child, the operation they are asking only because when he plays tennis, he is not able to toss the ball up. So which book will write that whether you should operate or no? So this, and then you think, okay, what can be the negative part of it? And this child finally we operated. So he just want to toss the ball up so that he can play the tennis. Again, one dancing example that they want to do this mudra. And this is one girl, this girl is from Visakhapatnam. It's a very interesting girl, again, just like that dancing girl. Her only complaint is when she go to temple, she is not able to do the hand like this. So at least 3 times we send her back that this does not look like operation required. We are going to create more problems. Bone does not heal. It will be a big issue. But they would again and again come. And finally, the last time when they came with the photo like this, so this is after the surgery. So after surgery, she is so much proudly telling that I am able to take the temple offering now. And they were trying to prove that what I was guiding them initially was wrong. But this is one happy side only. So that way that's why in forearm deformities, secondary deformities, I think all the patients, we need to become so much friendly with them that we start thinking like one of their parents only. And finally let them decide. But for letting them decide, we should be knowing everything, so that any question they ask, we should be able to tell that. And once you are knowing that, you are able to take a good decision. This group of the patient actually the most satisfied of all. If you do a global palsy, that patient whole life is going to tell you this not come, that not come. But here, since you have already fixed your aim, okay, we are going to improve your position, we are going to improve your tabletop activities, we are going to improve your dancing. So whatever we do, if you are able to achieve, you really make a lot of good to them. And you can, many times the patient themselves will come and tell, now I am able to shake the hand. And from unshakable hand, you are converting some shakeable hand, and then from beggar's hands to lot of happy hands. Thank you so much.
Thank you, sir. Very nice presentation, sir. Fantastic results. It's open for discussion. Any questions from the floor?
So how do you decide the amount of correction whenever you do a osteotomy for a pronation or a supination deformity? Is this eyeballing, or is this just on the table you decide that this much of pronation, neutral position that I want to maintain the forearm?
Yeah, so in that, the principle is to see whether the patient has got the wrist flexion or no. See, if the patient has got wrist flexion, then we should aim to bring the hand into mid-prone position, because then they can move on both sides. But if the child does not have wrist flexion, then we should aim to bring it in 30 to 40 degrees of pronation. So what this position will do is, now he will do an active extension and let the hand fall with gravity down. So this gravity falling down is possible only when you hyperpronated the hand. So whenever wrist flexor is not there, aim to get in 30 to 40 degrees of pronation. And if wrist flexors are there, aim to get to mid-prone. This movement makes them really happy, because initially the hand is like that. It is not moving up because the wrist flexor is not working, and it is already down. So once you do a pronation osteotomy, you are getting movement in both directions. It is moving up also, and now it is falling down with the gravity. So if wrist flexor is there, mid-prone. If wrist flexor is not there, 30 to 40 degrees of pronation.
So for derotation osteotomy of radius, what is the area we should aim for to the surgery? So is it the mid shaft?
So generally the area is between the pronator quadratus and pronator teres. So plate should start at the quadratus and finish at the teres. So in between area we can do the osteotomy.
And can it be done in any age?
Any age is okay. Any age is okay. Age is not a problem. Only thing is child should not be very small. So child should be minimum of 5 years to be suitable to put a plate. And children who are much younger, actually we can do a osteotomy and just turn the hand and put the cast without fixation. So that also can work. But that is only after 3 years.
Sir, why do you prefer the pronator over the FCU over the brachioradialis transfer? You told that the best way to correction the pronation deformity is to use the FCU.
Because FCU is a strong muscle. See, other options what we have is a pronateris rerouting, which is not so much strong. So it just drags the hand into supination, but it is not that much strong. FCU, if you take and put to brachioradialis, it gives a very strong supination. But only problem is most of these children, the FCU is not available for transfer because you may be requiring it for something else. But if child has everything, like that boy who want to play tennis, toss the ball, for this type of person, pronateris is not going to do anything. So for him, FCU is a nice, strong donor. But we should make sure that FCR is working. We should make sure that palmaris longus is there. And we should also make sure that this FCU is not required for any other important function.
Thank you, sir.
Thank you, sir. Thank you for your nice presentation.
Thank you, sir. I now invite Dr. R. Shrikant, sir, for his talk on role of functional muscle transfer in brachial plexus reconstruction.
Time, and I'll just, no, not this. Wrong.
Can we please have the audio from behind?
They are more commonly done for the total plexus injury, especially when previous nerve surgery has failed, uncommonly for partial plexus injuries or delayed presentations. The functions replace their elbow flexion and finger flexion. The results are very predictable for elbow flexion, but not so predictable when they are done for finger flexion. The spinal axillary motor nerve is a very good motor nerve, especially when used for driving a functioning muscle transfer for elbow flexion. In partial plexus injuries, sometimes the medial pectoral nerve can also be used as a donor for a functioning muscle transfer. As you can see, it is possible to get a reasonable range of motion and a strength which is usually less than or equal to MRC grade 4. And the results are much better when the shoulder is stable or mobile. Even though we try to use it for two different functions, the distal function is usually because of a tenodesis effect and rarely independent movement can be achieved. When we do it for finger flexion on account of the intrinsic paralysis, most of the time you get only a hook grasp. This is not so in a functioning muscle transfer for Bookman's ischemia, where even if an intrinsic paralysis is present, it is seen that the range of motion and the type of motion is much better, probably because of the orthotopic placement of the gracilis. In addition, when we do a functioning muscle transfer for finger flexion, it is mandatory to fuse the PIP joints and the thumb CMC joint to get some semblance of a grasp. The best results till date have been from Dr. Doi because there's an insane level of physiotherapy and rehabilitation that he follows. So we need to use the gracilis most often. The recipient pedicle is usually the thoracoacromial or the thoracodorsal. The spinal axillary nerve, intercostal or the medial pectoral nerves can be used as motors. Whatever innovation has to be done before or after the procedure, and the procedure has to follow set steps. Here we are marking the left gracilis muscle. The pedicle usually enters at the junction of the upper and middle third, as also the branch of the obturator nerve that innervates it. And we also give a distal incision to retrieve the tendinous end. Sometimes it needs to be extended further down to get an extra length of tendon. The same marking on the left side is only to demonstrate that there is a laterality to the gracilis in the functioning muscle transfer. What do I mean by this? So the gracilis that is taken will depend on the pedicle that is being used as the recipient. Medial pectoral means you take a contralateral gracilis, and if it's the thoracodorsal pedicle, it is better to take the ipsilateral gracilis. A case of delayed presentation, pan plexus injury, for which a functioning muscle transfer has been planned for elbow flexion and wrist extension. A supraclavicular incision, intraclavicular incision, 2 incisions in the arm where the gracilis will be tunneled through down into the forearm, and an incision at the cubital fossa. Infiltration of all the incisions ensures a bloodless field during surgery. Here we use a transverse supraclavicular incision because the only reason is to isolate the spinal axillary nerve, which will be connected to the obturator nerve of the gracilis. Since no exploration is contemplated in a delayed presentation, the infraclavicular incision exposes the pectoralis major muscle right down to its lower lateral free border. And after this is done, the dissection continues in the deltopectoral groove because in the first plane, the cephalic vein needs to be harvested. A considerable length of it is available. Once this is done and kept on the side, attention is turned to the white line which lies between the clavicular and the sternocostal heads of the pec major, and this incision is deepened to expose the clavipectoral fascia. Once it is done, the clavipectoral fascia is incised to expose the pectoralis minor muscle. Dissection along the lateral border will also define the medial border of the muscle because certain branches from the thoracoacromial axis also supply branches to this pec minor. The intention is to trace the source vessel. The pectoralis minor is cut to give some space. The pectoral nerves are also seen and also the pectoral branch of the thoracoacromial artery here. Any excess fat under this clavipectoral fascia is removed. I cut the clavicular head of the pec major. I'll use it later, the proximal origin of the pec major. And the terminal portion of the cephalic vein is de-roofed to prevent an acute kink because you need the vein to come and lie close to the thoracoacromial vessels. A subcutaneous tunnel is created between the neck and the chest because the spinal axillary has to be co-opted to the nerve of the gracilis. The lower border of the pectoralis major is again dissected. This will facilitate the placement of a subpectoral drain because the dissection of the recipient vessel is in a much deeper plane and a subcutaneous drain does not help. Pulsatile bleeding from the artery says we can start the anastomosis. An alternate incision in case the intercostal nerves have to be used as the donors. These intercostal nerves are harvested by subperiosteal dissection. At least 2 are required. And once the dissection is complete, they can be tunneled under the reflected pec major muscle to come and lie close to the thoracoacromial axis. Once this is completed, attention is turned to the arm. At least 2 transverse incisions are required. The intention being to identify the biceps muscle under the deep fascia of the arm. And once it's identified at 1 incision, finger dissection helps to define the subfacial plane and the fascia is cut blindly under the tunnel skin. The incision in the cubital fossa is to retrieve the distal end of the muscle as well as the biceps tendon. Again, the deep fascia is cut in the intervening skin bridge to prevent compression of the muscle when it is taken through. Here we are defining the lateral, the medial border of the native biceps muscle, and that facilitates placing a hemostat under it because the gracilis is going to be taken around it. The dorsoradial forearm incision is only to retrieve the extensor digitorum communis or the wrist extensors. That will be the second insertion for the gracilis tendon. In this case, we have chosen the wrist extensors. Sufficient length is taken so as to permit primary coaptation between the distal end of the gracilis and this extensor of the wrist. Any extra muscle fibers are trimmed away from the tendon end to prevent unwanted adhesions. And the last thing is to connect the cubital fossa incision to the forearm incision under the brachialis muscle and mark the tunnel with a drain. The gracilis muscle has been dissected off, awaiting detachment. The donor site was the left thigh. It is now being transferred to the right arm, and a 90-degree clockwise rotation permits the gracilis vessels to lie comfortably close to the thoracoacromial axis. The muscle and the tendon are now tunneled under these incisions in the arm. And at the cubital fossa incision, we make sure that the tendon is wrapped around the gracilis tendon before it's being delivered into the forearm, where it will meet the cut tendon of the wrist extensor. Preparation for anastomosis is done. Bleeding from the second vein implies that the anastomosis is patent. This is followed by coaptation of the spinal axillary nerve to the gracilis, or the intercostals, two of them, in case they are chosen as the donors. Having done that, now the proximal end of the muscle is being sutured to the stump of the pectoralis major using non-absorbable sutures, and this is fixed as laterally on the clavicle by including periostal fibers of the clavicle also. Then the distal end of the tendon is going to be sutured to the wrist extensor in a pulver-tap technique. And once that is done, these forearm incisions can be closed over a drain. The position is 100 degree of flexion of the elbow and 60 to 70 degree extension of the wrist. Forearm incisions and the arm incisions will be closed. The result at the end of the procedure with a small window over the upper arm, which helps in monitoring the gracilis for the first 3 days, the color of the muscle being pink. And subsequently, this wound is closed under local anesthesia on the 3rd or the 5th post-operative day. There are 3 things to beware to get a successful result. 1, we need to make sure that the peripheral pulse is intact, decide which side of the gracilis is to be harvested, and make sure to transect the donor nerve after the muscle harvest is complete. This will ensure. Yeah, I'm done. I was scared about doing a functioning muscle also for the surgeon in case there's some problem. I think this substitute has worked.
Thank you, sir.
Thank you, sir.
Sir, you said that you said that to cut the donor nerve.
Say, suppose you have done, you have cut the donor nerve. Ultimately, you are doing the anastomosis. For some reason, the anastomosis blocks, and you can't do anything.
Okay.
Then you are left with having cut a nerve, normal nerve. It doesn't answer the question, what happens if the vessel gets blocked the next day? Then anyway, it's gone. But it is something like now psychological for me. I will dissect the nerve, but I will cut it and do the coaptation only after my anastomosis is complete.
Okay.
Better to be safe than sorry. That's all.
And ICN, both of them are used. So then do you prefer the phrenic nerve or any other? What's your choice of nerve in that?
No. See, when you have used the SAN, there are very few brachial plexus surgeons who will be willing to go back into that scarred neck and take out the phrenic. That is point number one. Ain't I true? When you say you have used the intercostals, you still have some more intercostals. So I was a bit surprised, but I suppose that's the standard technique. Everyone seems to harvest the intercostal with an incision like that. You take 3, 4, 5, but an incision like that. Suppose things don't work and you need to take 6, 7 for the next time, you have to use the same incision, undermine and go below. So what I do is, when we do the intercostal transfer the first time, we give an incision like this. Even if it fails, I can always give another incision. It is ghastly, but you will approach through an unscarred area. So I was a bit surprised, but I seem to see that the whole world is doing this way, excepting me. I do it this way and this way. So then I'm sure that my second time when I'm going to access the intercostal nerves, I have a relatively unscarred area. And that's why I started my morning talk also. When you do these kind of surgeries, it is very obvious what you're going to do now. The problem is to plan what you are going to do subsequently in case. You get my point? So, like you have planning in reverse, planning in future. That will make your job easy.
Thank you, sir. We now end this session, and I would like to call Dr. Sanjay Kumar Giri, sir, to kindly felicitate our moderators. Thank you, sir. We now have an operative video, and Dr. Mukund Thate, sir, will be joining us online. I kindly request both of our guest faculties, Dr. R. Shrikant, sir, and Dr. Praveen Bharadwaj, sir, to kindly moderate this session. Dr. Shrikant, sir. Will entertain questions.
Dear friends, this is a video which shows our method for exposure of the ipsilateral brachial plexus in a case of birth brachial plexus palsy in a very small infant. Initially, we do the marking, and after doing the marking, we infiltrate 1 in 1 million saline adrenaline. There is no local anesthetic in this infiltrate, so that stimulation can be done without any issues. And the adrenaline is very, very dilute, 1 in 1 million. The dotted lines are showing the clavicle and the sternomastoid, and the solid lines are our incision. The supraclavicular incision is a bisection of the sternomastoid and clavicle, and the second one is a perpendicular drop from it to the coracoid process, which is marked with a X. So as soon as the child is induced, we infiltrate like this. The remaining infiltrate is now going under the flap, which will be raised to expose the pectoralis muscle for the infraclavicular. And the final infiltration goes in the deeper plane in the neck. Now the child is prepped and prepared. About 10 minutes have gone so that you can see the excellent effects. I am now palpating the clavicle and marking it, showing you that my incision is a bisection. The cross marks the coracoid. And my incision stops at the anterior border of the trapezius. So we are now starting with the supraclavicular exploration. Skin, platysma and subacute fat. At this point, we usually encounter some veins and the clavicular nerves which go across. See, this is an example of a supraclavicular nerve which I am taking right up to the clavicle and cutting. I can use it in two ways. I can use it to give sensory input, and I can use it as a nerve graft. Having taken that nerve out of the way, now I am exposing the external jugular vein, which is usually the next major structure that is seen. It's being clipped with hemo clips. Always put 2 on each side for abundant caution. And the next structure we see is the omohyoid, which we always cut with a coagulating current, not only a cutting current. And now we have come on to the plexus, where you can see the scalenus anticus and the upper trunk, and the nerve you are seeing is the phrenic. This is the key. Seeing the phrenic nerve is the most important, and preserving the phrenic, I am using a bipolar to remove the scalene from under the phrenic nerve while keeping a close watch. Now I am going in the posterior aspect, just anterior to the trapezius, without removing the epimysium, and I am going to look for the 11th nerve and the spinal motors, the cervical motors. So this is the 11th nerve. It is stimulating the trapezius. I will look for extra motors going in this area, which we usually find there, those two. We will confirm they are also motor. So these are the cervical motors coming out of C3-4. We will loop them separately and use them for separate targets. So the yellow is on the 11th nerve. And these two are the cervical motors. And the red band is on the cervical motors. Now we are going infraclavicularly. We have seen the upper trunk. We have removed part of the scalenus anticus. And now we'll go below and come back up till we reach the foramina and expose everything. So now we are going in the deltopectoral area. That's the clavicle, that's the pectoralis major. And that's the fat in between the pectoralis and the deltoid. The vein that you are seeing is the cephalic vein, which is dipping down to meet the subclavian vein. This is an important landmark because we get an idea of where we are. We will now try and look for the lateral cord under here. And take the clavicular head of the pectoralis major away to give us exposure. Once that is done, we are seeing the subclavius muscle under the clavicle, which we will cut in line with the upper trunk that we saw above, so that we know where the nerves are emerging below the clavicle. Subclavius is a much bigger muscle than we think. It doesn't come out in one shot. You have to do it 2-3 times. That was the posterior layer of clavipectoral fascia, and you can see the subclavian vein below, where the cephalic went to join it. Now I am looking for the lateral cord. That's the first thing to be seen. Typically, the way to confirm it is the lateral pectoral nerve emerging out of it. This is the posterior cord, and that is the medial cord. So at this point, they are all in a bunch coming out from the clavicle. This whole lateral, posterior, and medial business happens slightly more distally. That's the lateral pectoral nerve at the tip of my scissor. In fact, you can see the 7 and 5-6 component joining here, forming the lateral cord. And the lateral pectoral comes out of the 7 component. I personally always feel the lateral pectoral nerve is a C7 nerve. Sometimes has a C6 input. So that was the lateral cord. Now this is the posterior cord. And this is the medial cord. This child has a complete global palsy. Nothing is moving. Now we'll explore and see what is the situation of the plexus in the neck. So now I am going beyond the lateral pectoral nerve. That's the 7 component coming and joining the lateral cord. And as you can see, the lateral pectoral comes out of it. And there is a small 6 component in this particular case. So now I am going behind the clavicle and going above like that. And then I have this enormous amount of scar tissue over the lower trunk. The medial cord, as we go up, becomes the lower trunk. And we will trace it up till we can put our scissors in the foramen, or at least palpate the foramen with our scissors. You can see the formation of the lower trunk above. scissors is now in the foramen. I'm stimulating, but apart from the phrenic, nothing else is working. And of course, this I'm checking for serratus anterior because I have some faint hope that some stump of the upper trunk I can use as a donor. Now I'm checking the medial cord whether fingers are moving, but nothing is moving. Again, I'm tracing it up. Now you can see this ganglion of C8, which is in my forceps. So it has avulsed out. While T1 seems to be in continuity, but is not functional, which means it is probably a internal avulsion, the ganglion not being seen because electrophysiology calls it preganglionic. The C8 is clearly avulsed with the ganglion out. So now I am pursuing the middle trunk, that is the C7. Again, you can see this is the ganglion that is in continuity. So now I have come above the clavicle. That's the lower trunk I am right now dissecting. T1 in continuity, C8 is avulsed. Now I am seeing the ganglion of 7, which is what I am dissecting now. So the 7 also is avulsed. Now I am cutting that C8 because I am planning to give a contralateral C7 to the lower trunk. Since the T1 is in continuity, I am not cutting it. I will put in the donor input into the cut end of the C8. And my finger to palpate and show that I am at the spine. So now the C7 also is avulsed, the C8 is avulsed, the T1 is completely non-functional. Now I'm gone on the upper trunk and I can show you the 3 parts. What is my forceps is the anterior division of upper trunk. Below that is the posterior division on my scissors, and below that is the suprascapular nerve forming the Erb's point. I'm removing the scar tissue on top, between the upper and the middle. Intermittently, we always keep looking at the phrenic to make sure that we have not damaged it. So now this is the SSN which I am stimulating, nothing is happening. The whole of upper trunk I am stimulating, nothing is happening. Except for some movement felt in the serratus anterior. So there is some hope of proximal part which now I am looking at. But now what I am seeing is a ganglion of C6. Which means C6 also is out. So the remaining question is whether C5 proximal end is viable or not, which is what I am now pursuing. There is some viable neural tissue seen over here, just below my scissors, because above my scissors is a C6 ganglion. This is the motor root and that is the ganglion. So at this point, I am going to take this proximal for whatever it is worth. I will not depend on it for hand function or for biceps, but I will give it to the posterior division for whatever comes in deltoid triceps, etc. So I'm cutting now across, and ganglion is gone. You can see the 5 and the 6 components there. So this is the upper trunk and its three parts. My scissor is showing you SSN. Above that is posterior division of upper trunk, and above that is anterior division, which is what I am now dissecting out. So the strategy is going to be 11th nerve to the anterior division of upper trunk. Try to do it end to end. The cervical motor nerves to the suprascapular nerve, again end to end. And then whatever is remaining from that C5 stump, we will give it to the posterior division. And the contralateral C7 with nerve grafts we'll put in the C8. That's all the donors that we have just now. So beyond that C6 ganglion, I am looking for the C5 root proximally. It's very, very tenuous, which is why I will not depend on it for hand. But if there are a few axons in it, I would rather use it for the posterior division of upper trunk. So I am cutting across. See that stump there? This stump I am going to use. This is the proximal stump of C5. Thank you very much. Chopping. Hello.
Yes, sir. One minute. There is some question coming for you, sir.
Sir, he is asking what
So I will just
what are
stay
the
here then.
anastomosis the plan was after it.
Bus has not come, is it?
So
The bus is coming.
the question asked is, what is the final cooptation plan in this patient? What video you have shown, sir?
So, yeah, that's another video. But what we did was, we did 11th nerve to musculocutaneous. We did cervical motor nerves to SSN. We did contralateral C7 to C8. And we did that stump of C5 to posterior division of upper trunk.
Yeah.
Can you hear me?
Yes, sir. We heard, and yes, sir. We got the point, sir.
Yeah. So the only thing I wanted to show in this video was how to explore the roots all the way to the foramen, for
Yes,
which
sir.
you need to remove the scalenus anticus properly. Otherwise, you don't see them all the way.
Yes, correct. Yeah.
And you have to preserve the phrenic nerve.
Yes, sir. Yeah, we saw the roots quite nicely. The avulsed root
Yeah,
also,
all the
ganglion was seen. Sir.
yeah.
Any other questions? So the infraclavicular part of exposure, you decide after you don't get the root, sir, or first itself the plan was there
No,
based on the findings?
So in a global plexus, it is with this much scarring, it is better to come from below above, so that you know exactly where you are following the scar.
Yes, sir.
So the upper trunk you can see upstairs itself,
Yes,
but after that it is better to come below above.
Below down, okay.
For middle and lower trunk, safer that way.
Yes, sir.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Sir.
Thank you for having me.
Yes, sir. Today we learned how to be at two places at one time.
Yeah, Hari was standing next to me while all this is going on.
Luckily, Giri didn't know, otherwise he would have taken Hari sir also faculty.
But he has now gone shopping.
Yes, sir. Yes, sir.
Thank you.
Okay.
Thank you, sir.
Okay, thank you. Thank you so much. Bye. Bye.
We'll do the quiz session. It's a very interesting one. 26 questions are there, and one crossword is there. So you can do it in 30. Each question we have 30 seconds.
Who will answer? Everybody.
Everyone. No groups. You will not, sir. You will the judge. If anything you require, you will tell that one. Sir, Sam. And those you want to visit the burn center, Dr. Sam is there. He is accompanying with the people who wants to visit the burn center. So, in the meantime, we can ask the first session of here. You distribute the
Ask for
participants to come to the front rows. In the meantime, you ask for some of the. So one session of to appreciations of our 10 years to our staffs will start in between 10 minutes. So I will request Praveen sir to come to the stage and to distribute the certificates. Please, sir. So you start that one. Burn center nursing officers to come front so that we will quickly distribute your certificates for the appreciation of work for last 10 years. Give the names. So those who want to participate in the quiz, please come in the first 2 rows. Start it. Give it. We'll call names.
ANS Haripriya Bal, ANS Lalita Moharana,
Please come fast.
ANS Shushri Sangeeta Malik. Can we please have you all on stage? SNO Krishna Yadav, SNO Swarnalata Raut, SNO Vijesh Bhati, SNO Sarani Banerjee, SNO Ranjit, SNO Ram Kishore, SNO Satish Kumar, SNO Sarita Nahak. Can we have NO Abhilasha Murli, NO Arpit Shringi, Nursing Officer Aradhana Nath, Nursing Officer Shushanti Gamango, Nursing Officer Netram Meena, Nursing Officer KM Ekta, Nursing Officer Sasmita Panigrahi, Nursing Officer Pooja Anjali Sahu, Nursing Officer Sita Lakshmi S, Nursing Officer Paulami Chabri, Nursing Officer Smitanjali Behra. Nursing Officer Shushmita Khatwa. Nursing Officer Vanilam. Nursing Officer Kanu Bhaumik. Nursing Officer Pinky Paul. Nursing Officer Manorama Pani. Nursing Officer Chetan. Nursing Officer Borla Kunta. Nursing Officer Sayani Kundu. Nursing Officer Shirabdi Tanaya Lenka. Nursing Officer Krishna Das. Nursing Officer Rumpa Haldar. Don't give them. Nursing Officer Krishna Das. Nursing Officer Thanga Meena. Nursing Officer Chinmay Patra. Nursing Officer Devi Datta Nath. Nursing Officer Naresh Salvi. Nursing Officer Bhavesh. Nursing Officer Jivita. Can we have SNO Baby? Nursing Officer Sarah. Nursing Officer Roja. Nursing Officer Chandrakant. Nursing Officer Tejaswini Rana. ANS Priyadarshini Sahu. SNO Mamta Parida. SNO Priyanka Karmarkar. Nursing Officer Subhash Patra. Nursing Officer Subhash Patra. Nursing Officer Preeti Priyanka Chaudhary. SNO Amrita Das. Nursing Officer P. Pavitra. NO Swagatika. SNO Alina John. Nursing Officer Roshni. Nursing Officer Neelam. ANS Ajju Soren. DNS Sudha. ANS Anita. DNS Vaishak. Nursing Officer Aarti Ram. SNO Parmananda Regar.
All residents, all delegates can participate. Consultant also, no problem. So, you have given, all of you have.
Explain the rules.
Ah.
Question है ना?
Srikant, come. इधर आ जाओ, इधर आ जाओ. शिवराम. हैं? हाँ. Tell.
Yeah, this is just a request. Kindly stick to the first page for now. Yeah, just fight the impulse to immediately turn the page and look behind. Yeah, Dr. Madan.
So we have 26 questions and one crossword. So please do not overleap the behind one because that is a crossword. So for each question there is 30 seconds and 2 marks for each questions, and for the last one we have 4 minutes. Yeah. So we'll go. Everyone is ready. Please don't use mobile phones and all those things.
Can we just have a show of hands once?
How many of you are there? Yes.
Okay.
Start.
Kindly fill the bubble of the correct answer that you think, and please write your name on the paper. You'll have 40 seconds per question, 30 seconds to answer and 10 seconds to read the question. And for the crossword at the end, you'll have 4 minutes. You have to encircle the words that are listed below in the
Technical
grid.
points, so Ajay has told. So we'll go with the questions. Everyone is ready? Yes? Yes.
Automatic. Slides will skip automatically.
Yeah. So which factor most strongly favors FFMT over a conventional tendon transfer in a complete brachial plexus palsy? Normal sensation, multiple available functioning donor muscles, absence of suitable local donor muscles, mild wrist stiffness, normal biceps function. Yeah, got it. Time of second question. The primary function objective of elbow flexion reconstruction in a flail upper extremity is to eliminate all the elbow extension, produce useful flexion for positioning of the hand, restore normal bicep strength, restore the forearm rotation, correct sensory loss. Simple questions. Three seconds left. Third question. Which finding is most important before performing FFMT for elbow flexion? Full passive elbow motion, normal tricep strength, normal hand sensation, normal wrist extension, intact biceps motor unit. Very easy. Next question. Patient has a 40-degree fixed elbow flexion contracture before planned FFMT. The best strategy is proceed directly with FFMT, correct the contracture and restore the passive motion, immobilize the elbow further, perform wrist arthrodesis fast, perform finger tendon transfer. टाइम ज़्यादा हो गया ऐसा लग रहा है, हैं? नहीं. Next question, which is the most important consideration when selecting a recipient motor nerve for FFMT? It is a sensory territory, adequate motor axonal input and favorable location, its length alone, its cutaneous distribution, its diameter only. Next one is shoulder arthrodesis is least appropriate in a patient with a painful flail shoulder, gross instability, useful preserved active shoulder motion, complete paralysis, severe functional impairment. Easy, actually 10 minutes 10 seconds देना चाहिए तो ये 30 कर दिया. Next question, in selected patients with preserved donor musculature, shoulder tendon transfer may be considered primarily to restore finger sensation, shoulder external rotation, elbow extension, wrist flexion, intringing hand function. Next question, which muscle is classically considered expandable and therefore useful as a tender donor? It's an easy one. You have to properly bubble it, otherwise it will be zero. Our technology expert has already told to me. Next question, a tendon transfer to a stiff finger is likely to fail primarily because the tendon becomes longer, passive joint excursion is inadequate, the donor nerve regenerates too rapidly, sensory recovery is excessive, muscle hypertrophy occurs. Tendon transfer. Next, in a complete brachial plexus injury, conventional tendon transfer is often limited because there are too many donor muscles, there are insufficient functioning donor muscles, tendons cannot be transferred, all joints are automatically stiff, sensory loss prevents tendon healing. There may be multiple answers, but single best answer should be there. Out of these 20 questions, there are multiple answers are there.
Next question, before performing a tendon transfer for finger flexion, the surgeon should first establish finger PIP, fixed PIP contractures, adequate passive finger flexion, complete sensory loss, wrist instability, severe edema. First establish. Okay. Next is a 28-year-old with chronic C5-6 palsy has M2 elbow flexion, M5 flexor pronators, M4 wrist extension, and a supple elbow. He wants to preserve strong triceps function. So best reconstruction, gracilis FFMT, modified Stenler flexoroplasty, triceps to biceps transfer, repeat nerve grafting, shoulder arthrodesis. Best reconstruction, okay. A patient has absent elbow flexion, but an M5 टाइम नहीं है मतलब क्या हो गया ये क्या हुआ अच्छा ये तो हो गया ना ये हो गया है 12
Okay, so you have got extra time now.
हाँ
You can solve the question.
ये हो गया ना तो फिर क्यों निकाल रहे ठीक है छोड़ उसके बाद मत सुन ओ हाँ मत सुन 13 हाँ This is a patient has absent elbow flexion, but an M5 latissimus dorsi with intact thoracodorsal innervation and a supple elbow. So best local muscle transfer, best, yeah. Next question. In a classical double gracilis reconstruction for complete BPI, the first gracilis is primarily designed to restore elbow flexion plus finger extension, elbow extension plus finger flexion, shoulder abduction plus finger extension, wrist flexion plus thumb opposition, finger extension alone. The first gracilis, not the second one. So next question. A patient has a good shoulder elevation after BPI reconstruction, but persistent hand and belly posture from absent external rotation. The shoulder is supple. Which secondary reconstruction specifically addresses this? Stellar flexoroplasty, lower trapezius transfer, wrist arthrodesis, gracilis to biceps, triceps transfer. Next question. A patient achieves active finger flexion and extension after double FFMT. 6 months later, the fingers progressively assume an intrinsic minus claw posture. Intrinsic minus. So what is the best explanation? Both muscles transfers have failed. Extrinsic motion has been restored without intrinsic muscle balance. The wrist fusion is too extended. The gracilis has become denervated. Median sensory recovery is excessive. Next question, a patient with weak elbow flexion is asked to pronate the forearm, flex the wrist, attempt elbow flexion, and elbow flexion suddenly becomes possible. What does this finding support? triceps to biceps transfer, positive Stellar effect, failed biceps reinnervation, LD transfer, radial nerve recovery. This is an easy one. Next question, identify the pioneer surgeon in BPI surgery. Next one is from MRI, just see the MRI. This image of brachial plexus, identify the grade of injury. Grade of injury, the arrow is given. Did you see the white arrow? The mark in the MRI. The Sunderland grade is there. So what will be grade? Like 1, 2, 3, 4, 5. What is the grade? Next question is identify the pioneer surgeon in BPI surgery. अरे विदुष हंस रहा है, सब पता है उसको. है? है? कलर फोटो नहीं हो पाया. चिल्लियो नहीं. I can tell obstetrical brachial plexus, that can I tell. Next is during supraclavicular exploration of the brachial plexus, the surgeon uses the instrument shown. What is the most appropriate identification and use? This is what? Decimus retractor, retract scalene muscles, nerve hook, atraumatic isolation and manipulation of the nerve trunks, tendon passers, passage of the nerve graft through the clavicular tunnel, periosteal elevator, exposure of the fast rib, right angle clamp, ligation of the transverse cervical artery. Very easy. Next one also, during supraclavicular brachial plexus exploration, the surgeon uses the pictured fine blunt-ended instrument to develop a plane between the epineurium and the dense perineural scar around the upper trunk. Which instrument is most likely be used? It is called as like this: Painfield dissector, free elevator, Watson chain dissector, micronerve hook, McDonald dissector. Next question, a patient with brachial plexus injury is asked to actively flex the elbow. The sequential images, if you see, show the progressive elbow flexion accompanied by marked movement. So what does this movement pattern most strongly suggest? Recovery of isolated biceps function, compensatory shoulder recruitment producing a trick movement, paradoxical activation of the triceps, dynamic tenodesis effect at the wrist, fixed elbow flexion contractures. If you see the positions, you can know. Next question is, in 1903, Wilfred Harris and Vincent Warren Lowe reported an operation that anticipated one of the dominant concepts in modern BPI reconstruction. What is the key principle? FFMT free function and gracilis transfer, intrinsic neurolysis of the upper trunk, tendon transfer around the shoulder, transfer of the injured root elements to adjacent functioning neural elements, contralateral C7 transfer through a vascularized graft. Key principle. Next question. The modern era of plexus reconstruction required abandoning one major surgical dogma that a nerve gap should be closed by direct repair, even if significant tension was required. So, which surgeon's work was pivotal in changing this? Alan Gilbert, Aligmatus Narakas, Hanno Milesi, David Seddon, Christopher Avolin. You can exclude and you'll get the answer. Next question, it is the last one. The most common birth brachial plexus palsy. The most common. Upper nerve trunk C56, C57, C5 to T1, isolated involvement of the lower trunk. Most common. So last question, it is about 4 minutes, and we have just in the just overlap. You got 4 minutes, and the rule for that one.
Encircle the word as shown in the image. Out of the 8 words given below, how many other words you can find? Only those 8 words count. Timer starts now.
Question has 8 marks. So 8 words are there. So you have to identify 8. All words are related to brachial plexus only. I mean, it बचा है. The 2 minutes left. Please, all of you, write your names.
For word number 7, you can either find Somsak or Saha.
Time over, eh?
Time's up.
Time's up, time's up. So you give all your papers. Given na? Analelo. आंसर बोल देंगे इसके बाद सर का 2 पेपर शांतनु को बुलाना पड़ेगा शांतनु चेंज कर रही पहले प्रीवियस से जाएंगे यू हैव गिवन ऑल योर पेपर्स ना कौन लिख रहा है सूर्या सूर्या तो पूरा श्रीकांत शिवराम हो गया anybody left submit so you can tell the answers and just fast very fast बैक से जाएंगे पहले हाँ हो गया मिल गया ना आंसर्स यू आर लिविंग so we'll go the one we'll go answers or we'll go sir's talk last 2 talks left है आंसर बोल देंगे ठीक है सर द फर्स्ट वन कलेक्ट कर लिया ना द फर्स्ट वन आंसर इज सी absence of suitable local donor muscles. I think everybody has written must be because complete plexus injuries frequently leave the insufficient functioning muscles for conventional tendon transfer. So FFMT introduces a new muscle with its own neurovascular pedicle and motor nerve. That is why answer will be C. Second answer is B. Produces useful flexion for elbow flexion because functional elbow flexion allows the hand to be brought forward to the mouth. So that is the right choice. B I told. Next question, answer is A. Full passive elbow motion. It is the most important before performing FFMT for elbow flexion. So full passive elbow motion should be there. And this is a patient has a 40-degree fixed elbow flexion contracture before planned FFMT. So the best strategy is to correct the contracture first, then and restore passive motion. So answer will be B. And what is the most important consideration when selecting a recipient motor nerve? So the answer will be B. Adequate motor axonal input and favorable location. Yeah. The shoulder arthrodesis is least appropriate. The answer will be C. So useful preserved active shoulder motion should be there. निकल रही क्या? सजा रहे हैं? सर फोटो लेना है थोड़ा. आएंगे ना? सर का 2 टॉक है खत्म करके. हाँ सर 7 the answer will be B shoulder external rotation So I am going fast little. If you have any doubt, then I will explain that one. Answer 8 will be C, Palmaris longus. It is the most expandable and useful tendon donor. And 9 answer will be B, passive joint excursion is inadequate. 10 answer will be, in a complete brachial plexus injury, conventional tendon transfer is often limited because there are insufficient functional donor muscles. It's easy, nothing to be explained. 11, the answer will be adequate passive finger flexion, first established. 12 answer will be modified stellar flexoroplasty. 13 will be, this will be bipolar latissimus dorsi transfer, because a strong normal innervated LD is available, so bipolar pedicle transfer to provide a powerful elbow flexion. 14 answer will be, first gracilis is primarily designed for to elbow flexion and finger extension. So answer will be C. Sorry, answer will be C. A. The next one will be answer B, because a patient has good shoulder elevation after BPI reconstruction. So shoulder is supple, so which secondary reconstruction? So low trapezius transfer is the secondary reconstruction, especially this one, because it is a dynamic one for external rotation. For 16, it will be answer will be B, best explanation, because extrinsic motion has been restored without intrinsic muscle balance. For 17, answer will be positive stellar effect. 18, answer is D, James Warren Saver. He is advocated to secondary shoulder surgery, because he has not given the flexor repair, he has the shoulder repair, which includes mostly the pectoralis major release and subscapular release. This is grade 5. If you see in the MRI, there is loss of continuity. If you see the arrow, there is loss of continuity of the C5, C6 nerve roots. So the diagnosis is grade 5 nerve injury. Sunderland grade 5 neurotomosis. Yeah. 20 is anyone? B. It is Robert Kennedy who first published the treatment of obstetrical brachial plexus injury. This is hook, B answer, nerve hook. This is A, pain-filled dissector. It's a dissector, pain-filled dissector. Watson is for the above dissection, but this one is pain-filled dissector. And 23 answer is B, compensatory shoulder recruitment producing a trick movement. 24 is D, transfer of the injured root elements to adjacent functioning neural elements. 25 is, if you exclude all those, Gilbert, Maracas, the answer will be C, Millesi. Millesi is infrafascicular nerve grafting emphasized. And the most common bar brachial plexus is upper nerve trunk, C5-6. C5-7 is extended nerve trunk, but most common is upper nerve trunk, that is C5-6. And for this, we have 8 things. Ajay, you tell those.
There are 20 words, actually 20 words in that. We asked you to find 8 words out of them. No.
So 8 words are Oberlin is one there, Meyer Green, Saha and Somsak. Trapezius transfer is there, latissimus. Okay. So that we'll see. So these are the 2 words which we can, from crossword you can know. Oberlin, Meyer Green, brachial plexus, double Oberlin, Hofer, latissimus transfer, Somsak Saha, trapezius transfer. Okay. I hope everybody have written right answers. Right. Thank you. We'll see the results. Thank you, Ajay, for helping me to make the quiz. Big clap for because all the technical things Ajay has done it. I have given only the questions. Thank you, and we'll move to your last talk, hai na, sir? That we will complete and we will do that one. For this, we can ask Santanu ka? Yes, Santanu.
May I please invite, for the next session, may I please invite Dr. R.K. Sahu sir for moderation. Ranjit Kumar Sahu sir for moderation, please. I also invite Dr. Praveen Bharadwaj sir to deliver his talk. Nikal do.
Sorry, 1 minute. Is not picking up. So there are two talks which are left as per the program. One is the more complex deformities in birth brachial plexus palsy, and second one is about some tips on the tendon transfers for the wrist and finger in adult brachial plexus. So being in the mood of birth palsy after shoulder and after the forearm, let us first take this sequelae of birth palsy complex deformities. Now, many patients with birth palsy would have deformities from the shoulder till the hand. So then it becomes very difficult to decide which one to do first and what order you have to follow, how much gap to give between the two. So general rule is shoulder around 3 years of age, forearm around 4 to 6, and hand 5 to 6. Tendon transfers where patient's cooperation is required should be done only after 6 years of age. Otherwise, the child is not going to understand what you are doing and will not do the physiotherapy properly. So that is the reason why you delay that. So overall, we can think that you go from proximal to distal, but it is good to do the operation which will show the most dramatic effect to the parents and also to the child functionally. Because once you have a good result of an operation, then it becomes easier to convince them for the next operation. So that is like a unwritten rule, but that is the general thing to follow when you are doing a patient with multiple deformities. And as your practice grows, you will start having children coming at much early age. Then you have a chance to prevent the deformities. And one of the deformities which we must try to prevent is the internal rotation contracture, which can be done quite well by doing stretching exercises and early buttocks and casting. So all the children we see in the OPD, first thing we check is whether there is any limitation of external rotation, and if there is any limitation of external rotation, we immediately go for buttocks injection and casting. And as in this classification, if patients are falling in that category, early muscle release, we already know about this discussion what we had about forearm deformities. So all these principles apply to all these patients who have multiple deformities. So the main thing will be to decide in which order to do. So this child, what we did is we did first the shoulder correction, then later on we went to the thumb, and last we did the elbow. Now, what we did for the shoulder was the external rotation osteotomy, forearm osteotomy at the forearm, radius osteotomy, and the tendon transfer for thumb, and then the elbow. In elbow, it is serial stretching. Now, it is an important thing to do the serial stretching last, because any operation you do in the hand, you would like to put a plaster or you like to elevate. And when you do elevation or immobilize the elbow, again it is going to become stiff. So that's why the stretching casting for the elbow should be kept last. But after this, you can see there is quite a visible change in the appearance and function for this child. You can see the supination deformity here, the kind of that beggar's hand what we were talking about. And here the hand posture becomes nice. And not only the cosmesis, the children function also quite well improves. This child who would have difficulty in doing any activity with that hand at all, now because of the pronated position, because there is an improvement in tabletop activities and she is able to lift up things quite comfortably. There will be some patients which are more challenging because of the deficit of the donor muscles over there, because it is an extensile palsy, so there are no donors available. So you would feel whether you can apply the adult principles like fusion of wrist to them. It is possible, but this is one operation where we need to be very careful. So this patient, if you see, we have not done the arthrodesis yet. We have just put 2 K-wires inside, just to give them a feel how the wrist will be after fusion. After the wire, patient is left for 1 week, okay, you feel how it is going to be once the wrist is fused, and after that you can go for the formal fusion. In case you straight away go and patient tells, no, I was previously only better, then you had it. So that's why for joints like wrist, fingers, it is very much possible to give them a trial fixation and let them feel how it is. This patient was quite very happy with this wrist fusion, because it made the wrist stable and made possible to use the hand. Otherwise, because of the floppy wrist, she was not using the hand at all. One other complex deformity which is not very commonly discussed is lack of elbow extension. But it can be very disabling sometimes. You see this child has got a good shoulder abduction, but whenever she lifts the hand up, because the triceps is 0, the hand will just fall on her head. Because of this falling of the hand on the head, she would not do any overhead activities at all. And because of limitation of these overhead activities, these patients can be quite disabled and not use this hand at all. Now, normally, what is done for these patients is lower trapezius to transfer, and many times these patients have limitation of shoulder abduction as well. So we started doing this new transfer, which recently has got accepted for publication as well, where you take the upper trapezius, weave it through the deltoid, extend with fascia lata graft and attach to triceps. So it is upper trapezius to triceps going through the deltoid. So on the way, it adds to your shoulder abduction also, because your transfer is going above the rotation of the level of the shoulder. So this upper trapezius to triceps transfer improves the shoulder abduction and also gives elbow extension. So this patient who was having very weak elbow flexion, elbow extension, in case you do only shoulder procedure, child will lift and still the hand will not go up because the triceps is weak. But if we do this trapezius to triceps, you get an improvement in abduction and you get an improvement in elbow extension as well. Some children who have some residual triceps function could actually become very good and so confident that they will be able to comfortably do this kind of overhead activities. And this is very difficult, because when the child is throwing, the triceps need to be really grade 3 to do this function. So with all these principles and keeping your mind all the time open to all the possibilities, most of the children with birth palsy, you will be able to offer something or other to make their life better. Thank you. So any questions on that before I go to the last talk?
Finish.
Yes, sir. So this is the last talk, and it is a bit of extension of the surgery what we did in the live surgery other day, the tendon transfer for the finger extension. As a plastic surgeon, orthopedic surgeon, hand surgeon, everyone is very comfortable doing the radial nerve tendon transfer, and like that is one transfer which everyone thinks that it is always going to work. And because everyone comes from the radial nerve transfers and then come to the brachial plexus, they tend to apply the same principles to the brachial plexus as well. But it is a very dangerous thing to do if you have not understood the difference in the anatomy in these two patients. This patient with the extended upper brachial plexus palsy would look just like a radial nerve palsy. That patient has a wrist drop. But there are so many important and significant differences because the various donors which we always use for doing tendon transfer for wrist extension and finger extension in radial nerve palsy are also not functional. The pronator teres and FCR, these are trademark C7 muscles. They are never working. Palmaris longus, FDS, FDP, even the FCU may be weak or maybe not working at all. So that's why the tendon transfer in this group of patients, we should not take it lightly at all and surely not think that they are just like a radial nerve palsy. As I told, pronator teres and FC are almost never working, and other muscles also can be quite questionable. Many times it comes in mind, FCU is working, if we put the FCU to finger extensor, so it is okay, what will happen? So this is the effect what you will see if the wrist flexor is not there. If there is no wrist flexor functioning, when this transfer acts, it is going to bring the wrist up and finger in this position because there is no wrist stability at all. And it looks as if the finger extensor transfer is not worked. But the transfer has worked, the biomechanics is failing it. Moment you stabilize the wrist, the fingers are going into full extension. So this effect is only because the wrist is not stable and there is no FCR or palmaris longus functioning on the volar side. This is a very bad situation to have because patient will feel as if the finger is not opening at all. And at this stage, the only solution is fusing the wrist. So we should not end up in this situation and be very careful when you do the tendon transfer. One solution which generally everyone follows is you don't have adequate donor, you do the wrist fusion. Wrist fusion is nice, but it is not a very good thing because once the wrist is fused, the FCU transfer to finger extensor cannot work very well because the FCU has an excursion of 3 and finger extensors desire an excursion of 5. So you will always have only about half of finger extension. The good finger extension what we are getting after radial nerve transfer is only because patient is flexing the wrist to get that extra excursion. If the wrist is fused, they will only have half excursion. So that's why we should always see some option where if any wrist fusion can be avoided. Also, wrist fusion really jams the wrist, especially on the right side. There are many patients who with flail wrist will be able to drive the bike because they can use the accelerator with the flail wrist. But once the wrist is fused, they cannot use the accelerator. In fact, one police person is coming and telling me that after your wrist fusion, I cannot drive the bike, I am become totally disabled. So we should know that these are very important considerations. So based on our experience of these 78 tendon transfers, we actually came across with this small class differentiation of this patient with extended brachial plexus palsy and have a protocol of what tendon transfer works in this set of patients. So class 1 is a patient where FCU is working, FDS is working, palmaris longus is working. Remember the FDS and the FCR and the pronator teres will not be working in this group, but these 3 are working. This is a good case for doing tendon transfer. This is exactly the patient like what we operated yesterday. The FCU here will go to the EDC and FDS of middle finger will go to the ECRB. For thumb extension, you can either put the FCU itself, or if the FDS is good, you can put the FDS of the ring finger to the EPL. The second category is where FCU and palmaris longus are good, but FDS is weak. Here you cannot take FDS for the wrist. So though there is nothing for the wrist, but still the FCU transfer done to the finger and EPL still can stabilize the wrist and allow the patient to come out with the fingers opening. The third category is patient where the FCU and palmaris longus is weak, again a common category, but FDS are good. In this case, you can use one FDS for the finger extension and one FDS for the wrist extension. Surprisingly, FDS have a good cortical plasticity, and same tendon is actually doing different work. One is FDS of the middle will extend the wrist, and FDS of the ring will extend the fingers. If none of these options are available, then only we should think of doing the tendon transfer. This is an example of the type 1 where the FCU, FDS and palmaris longus working. As I told, you can opt for a separate donor for the thumb, that is FDS of the ring for the EPL if it is available. You can get a very beautiful result like that. This is the best category. Though the FCR is not there, but palmaris longus is enough to maintain the stability on the volar side. You will get a good amount of independent movement of the finger and the wrist and the thumb as well. FCU can be transferred to the EDC and EPL also, just like what we did yesterday, and that gives good amount of independence of the thumb. Patient, after flexing the finger, can move the thumb like that, and they are quite happy with this result. It works quite well. So FCU to finger and the thumb, we should not have any concern at all. This case where only the FCU is working, the finger flexors are weak, you can do the FCU to EDC and EPL. We can note that the wrist is quite stable, finger is opening up, and that is sufficient for patient to carry out activities. This is not a described class where you are using one FDS for the wrist and one FDS for the finger. We were actually initially very concerned whether we will get a good result in this at all. But this patient was very concerned that I don't want any wrist fusion at all, and that gave us chance to do this. And now this has become our very common transfer what we do. It works really well. You see, you cannot imagine that one FDS is stabilizing the wrist and one is moving the fingers. So that is because the FDS actually have a very good cortical plasticity. So based on these examination findings, your good assessment, in most of the patient with extended plexus palsy, you will be able to avoid the wrist fusion. But when none of these tendons are available, not to hesitate to do wrist fusion, but give a good thought of whether any of these options is possible and we can prevent wrist fusion and have a mobile and stable wrist. Thank you so much.
Floor is open for questions. Any questions, any doubts?
Yeah, this is the last talk, so all the doubts related to the previous talks also we can ask.
You are free to ask any questions to Praveen sir.
Yes.
It's the last chance. We are in the finishing line.
Ahana, you have not asked any questions since I came here.
Yeah.
Ambrish, if you have got up from your sleep, you can ask now. This guy is sleeping so much after lunch, eh?
So in class 3, as you showed, after transfer, we are left only with, in the flexor aspect, FDP action. So does it later reliably provide wrist flexion as well?
Yeah, so that patient, the FCU and palmaris longus are weak, not that they are not working. The palmaris longus is actually always working in these patients, but we cannot take that because that is the only thing working. So we have taken the FDS and put there. One problem some patients can have is if it is very flexible joint category type of patient, they can sometimes develop swan neck deformity, swan necking. because FDS is taken. No? So that's why we should not go and take the FDS in the palm or in the finger. Cut the FDS here itself. That will prevent that formation of swan neck deformity. Wrist should be okay.
Thank you, sir.
Yes. Yeah, he again explained today, no? Yeah. Yeah, I think it is the cortical plasticity only which is working, because you are teaching the patient, no, that you are doing like this, up, down. So in the mind, it is like that same what you call the mirror therapy. So if he is saying that, okay, bending is there, straightening is there, then in the brain more learning happens. So we also don't use that technique. So what technique we use, I will tell. So you can see which one looks more logical to you, and we can apply both. So we also do that transfer. So what you do is you ask the patient to lie down, okay? And then ask him to relax the triceps and let the elbow drop into flexion, okay? So now what we are teaching him is, we are teaching him that you have to, when you relax the triceps, your elbow should bend. Okay? And then he will see that this long head which we have transferred on front, that is also becoming tight when he is flexing. And then we keep showing him this, okay, so this is the movement what you have to do. Then over a period of time, he understands that this muscle which is becoming tight is actually flexing the elbow. Then you do the same movement in gravity eliminated and then against gravity. So this also is a kind of cortical plasticity, but when he is seeing that this elbow is falling down into flexion, then in mind reads, okay, this is the muscle which is going to flex the elbow. So that is another way of training that, yes.
Sir, in the last talk you showed the muscles are weak or non-functioning. Do you do any EMG to confirm that, or is just a clinical examination?
Yeah, clinical examination only. Yeah, for power, you don't do the EMGs. Yeah, so EMG will not tell whether it is so much power that you can do the tendon transfer. EMG would at best tell only when it is a functional muscle or no. And again, as we were having discussion earlier also, no, EMG is very person dependent, so it is not that much useful when you are deciding tendon transfer.
And as usual, would you take a 4+ only, or would you take a 4 also for a tendon transfer in a brachial plexus space?
Yeah, 4 and 4+ is like very person dependent only. If it is 4, we will take. Especially children and all, if they are able to resist your one finger pressure, it is 4+, then you can take it. 4+ is, 4 is okay. So even if it is 4 and not plus, it is okay to do the tendon transfer.
Those are for fingers, and suppose you are taking something for a triceps for elbow flexion, you are doing a transfer.
Triceps to elbow flexion, if the triceps is weak, then we should not do that one head transfer. Then you should do the complete triceps to biceps transfer. If you are doing complete triceps to biceps, then even if it is grade 2 or 3, it will add to whatever biceps you already have, and both together will work. But we should not do the single head transfer in those patients. Even in fact, if you ask me, any triceps which is recovered after nerve surgery, we should not do one head transfer, because it will not have so much power. Either transfer will not work, or whatever remaining down will not work. So it has to be on original, non-recovered, or word is virgin triceps. No, then only we should use. Otherwise, it is not a nice transfer to do. Okay, thank you.
And your time and energy with us, with our department. We'll be grateful for your presence here. Thank you everyone being present here and enjoy the talk, scientific extravaganza. We are finishing, we are in the finishing line. Thank you everyone.
Thank you, sir. We now proceed to certificate distribution. I kindly request everyone to assemble to receive their certificates.
Plastic. Ranjit sir, Dr. Santanu, you come to this stage and to give the certificates with Dr. Ranjit sir. Start. You can ask sir also to join.
Yes, sir.
Now we are calling J5 ward nursing team. ANS CBYS. SNO Lopamudra Raut. SNO Dasharath. SNO Ramya CM. SNO Riju Sharma. NO Shibi Malar. NO Sushila. NO Gayatri Sahu. NO Rajendra. OT team, please be ready. NO Deepa Singh. NO Mautali Bhattacharya. NO Akanksha. NO Seema. NO Mekhala. NO Saroja. Hospital attendant Gyanaranjan. Hospital attendant Soumya Ranjan. Hospital attendant Sabita Malik. Hospital attendant Debendra Malik. I kindly request Dr. Aparna Kanago ma'am and Dr. Shyam Sundar Behra sir to and also Dr. Amia sir to join us on the stage. After. Hospital attendant Debendra Malik. Housekeeping team Manisha Pradhan. Housekeeping team, Deepanjali Behra. Housekeeping team, Chandrakant Behra. Security, Lakhan Gond. Security, Nijaranjan Patra. Security, Naresh. OT Technician Staff, Burn Center. Chief Technical Officer, Prakash Kumar Swain. OT Technical Assistant, Badal Kumar Das. OT Technical Assistant, Saroj Kumar Sahu. OT Technician, Ananta Padi. OT Technician Assistant, Rajesh Kumar Sahu. OT Technical Assistant, Satyabhrata Nayak. OT Technician Assistant, Swagatika Mishra. Madhusmita Sahu. Technical Officer, Harishankar Sankal. I kindly request Dr. Ahana ma'am and Dr. Shikha ma'am to join us on the dais. Swagatika Mishra. Shilpa Priyadarshini. Dejina Nayak. Sushita Bhuyan. Debirani. Surajita. Rajat Chatari. Madhusmita Sahu. Now we call our plastic OT nursing team. ANS Shalini Kullu. SNO Sangeeta. SNO Ashok. SNO Shobha. SNO Reshmi. NO Sandra. NO Surya Prabha. NO Sylvia. Pramod. Shahina. Shivanjali. Housekeeping Sabita Nayak. Housekeeping Dilip Kumar. Housekeeping Gopabandhu Nayak. Sobhagya Swain. Divyajyoti Mishra. I now request Dr. Shrikant sir to join us on the dais. नहीं है। रेखा, Sebati Nayak, housekeeping team. We call her Rekha. After this.
Finish that first.
Hospital attendant Tehemul Khan. Hospital attendant Yudhishthir. He's coming back.
Yeah, he's done. Dude, you finish these, huh? Sebati ke baad everyone. Divya Jyoti. Now take this.
What is J?
Leave that. Just
Now we call our plastic surgery OPD team. Rajinikanth Samal. Devi Prasad Sahu. Chinmay Kumar Pradhan. Sandeep Kumar Roy. Sandeep Kumar Roy. Sajan Kumar Panda. Badal Kumar Nayak. Sandeep Kumar. Badal Kumar Nayak. Devendra Hatti. Kamal Lochan Mishra. Lilima Priyadarshini. Lilima Priyadarshini.
दो नहीं है, सूर्या नहीं है कि मीना देवी नहीं है.
R. Surya Kumari. Now we'll start with Burn Center supporting staff. Dresser Jalimani Guru. Dresser Jyoti Ranjan Senapati. Dresser Pikan Sahu. Dresser Rudra Prasad Das. Dresser Narendra Kumar Sahu. Dresser Prafulla Nayak. Dresser Nirmal Kumar Bhoy. Dresser Hare Krishna Jaina. Yeah. Hospital attendant Prakash Behra. Hospital attendant Bipin Prushti. Anita Behra. Siddhant Kumar Sahu. Bipin Prushti. Avinash Sahu. Avijit Sahu. Kishore Malik. Benzer,
Benji.
Rajendra Kumar Purushottam,
ये नहीं, उनका नाम नहीं, बस डम्रुदर नहीं है सर.
Damrodar, now calling housekeeping team, Bhubana Bandanayak, Mamata Behra, Parbati Boy, Sanjay Kumar Mahapatra, Manoranjan Das, Vidyadhar Boy, Chinmayi Barimala, Sagar Barimala, Kaushalya Malik, Jitendra Nayak, Kaushalya Malik, Ranjit Kumar Sethi, Sanjay Kumar Nayak, Siddheshwar Bhoi, Archana Khandi, Lakshmi Priya Das,
Rachna, na?
Baikunta Das, Anjali Nayak, Niharika, Niharika Mohanty, Security team Aditya Behra, Sadhu Samal, Mekhil Pradhan, Awaz Nawaz, Bishwajit Pradhan, Meena Ketan Jena,
हमारा एक चिन्मय सब तय होगा ना एक दे दीजिए वो रिसीव करके फोटो ले लेगा चेंज कर देंगे बुला लीजिए चिन्मय कर
Classic OPD staff Chinmay,
So I'll announce the poster prize winners first. Third prize has, and I'd request the winners to please come up on the stage and take the certificates from the dignitaries. Third prize, we have two people, Dr. Devendra Kumar and Dr. Neha Sharma. Dr. Neha Sharma. Second prize goes to Dr. B. Pavni Lia. And first prize goes to Dr. Mausam. Dr. Neha Sharma, yes, please. First prize goes to Dr. Mausam. Coming to the quiz winners, the third prize goes to Dr. Shubhashri. Now it's Dr. Pavni has come. She has got the second prize in poster. Dr. Shubhashri gets the third prize in quiz. Second prize goes to Dr. Utsav Gupta. First prize goes to Dr. Surya Yashasvi. Congratulations to all the winners. Now we'll begin with the delegate appreciation certificate distribution. Start.
Dr. M.V. Chandramouli, Dr. Shivasharana Biradar, Dr. Pradeep Tendon, Dr. Shrikant Aruna Samantrai, Dr. Tamasuk Das, Dr. Shubhakant Mahapatra, Dr. Amitabh Das, Dr. M. Shiva Ramakrishna, Dr. Jada Mabu, this is Dr. M. Shivram Krishna.
We had made a list.
Dr. Bully Boidi, Dr. Jubin, Dr. Pratik Dash Adhikari, Dr. Shubhashri Page, Dr. Gopal Mahapatro, Dr. Lipsha Swain, Dr. Apurba Kumar Nayak, Dr. Santosh Upadhyaya, Dr. Devendra Kumar, Dr. Krishna Prasad Prishti, Dr. Sura Malik, Dr. Ram Seva Yogi, Dr. Mahesh Kumar Mandal, Dr. Mutrunjay Das, Dr. S. Asir, Dr. Balela Nagabhushan, Dr. Tanmaya Mahapatra, Dr. Ramesh B.A., Dr. Rajavardhan Pyadi, Dr. Gurupal Singh, Dr. Pratyush Priyadarshini, Dr. Neha Sharma, Dr. Mohammad Ashwaq, Dr. Prakash Chandramal, Dr. Pavani Lia,
वो तो स्टार्टिंग वाले नाम कैसे करते हैं in this order.
Dr. Surya Yashasvi PSV, PVS, Dr. Vidush Kumar, Dr. Anisha Ganguly, Dr. Utsav Gupta, Dr. Madan Mohan Reddy, Dr. Madan Mohan Reddy,
Dr. Amrish Ramasamy, Dr. Kirti Ji, Dr. Dipanjali Shetty, Dr. Kriti Jain, Dr. Nikhil Kumar Sharma. Dr. Mausam Maiti. Dr. Ashutosh Adhikari. Dr. Nikhil Malela. Dr. Sonalika Gupta.
जुबेन का सर्टिफिकेट
Dr. Sakshi Bansal. Dr. Rinsi T. Dr. Divela Ajay. Dr. Jubin Sonane. Dr. Navneet Sharma.
Three is celebrated as Hand Surgery Day. This is told by the ISH. I think Praveen sir is the secretary of ISH. We are fortunate this time sir is here. Although tomorrow is the hand day, so I think I will ask sir to convey some message, and we are going to have a cake cutting of for this, and also one cake cutting for our 10-year celebration. हाँ डिनर है सर तो सर प्लीज गिव सम मैसेज फॉर दिस ISH हैंड डे which is August 23, although it is tomorrow. How it has happened.
I think it is 30 sir jab the
So it happened is that this is the day when the Indian Hands Society was registered in Mumbai. So that's what it has been selected as the hand surgery day. And also this time there is every time one theme which is proposed, one hand, one change. So it is just like requesting all the ISS member to do something which is possible from their side. One thing what you have done is you have done this workshop. So something like that. So we can, any initiative to improve the hand surgery practice or to let people know what hand surgeons do. Any one of that type activity. So all the people who are members would do this kind of activity, and also people who are not member, this is also a good day to become member. So anybody who is becoming member on the National Hand Surgery Day, so people are available to propose your name, don't worry about that, okay? So thank you for remembering this.
Yeah, you will remember, yes. Ek member मिल गया.
एक वो लगाना पड़ता है proposal ready.
All can join for this cake cutting.
फोटो बैठे